Chairs for the session to please occupy the seats on the dais. The chairs for the session are Professor K.L. Jayakumar, Professor and HOD, the Department of Radiation Oncology, Shri Mookambika Institute of Medical Science. Dr. Ramesh S. Bilimagga, Professor, Department of Radiation Oncology, HCG Cancer Center, Bangalore. The moderators for the session are Dr. Ajay Kumar, Professor and HOD, Department of Radiation Oncology, Government Medical College, Kozhikode, and Dr. Maris Mezekis, Senior Radiation Oncologist, Stereotactic Radiosurgery Center, Sigulda, Latvia. We request the moderators to take over the session and to please introduce the speaker for the session.
Good morning. In fact, yesterday we had a very nice morning session and with mind-boggling scientific scintillating talks, and evening followed by a very good cultural program. And wonderful, and indeed we are very thankful to Amrita and all the delegates and who have really enjoyed. And we are now descending from the head to the abdomen today. And I'm sure it is also will be quite interesting, and we have a very good faculty to discuss and share their experience. I now request our moderator Jay Kumar to introduce the speakers.
Yeah, good morning. Let me take the opportunity to introduce Frank Lecquerie, MD, Somangi Country Kaposi's Hospital. He'll be speaking on IRS. What is the topic, sir? Yeah, with that short introduction, I invite Professor Frank. Yeah. Thank you.
Oh, okay, perfect. Okay, good morning to everyone. And in the next couple of minutes, I would like to make a summary about the current state of pancreatic SBRT. So here's my outline. And just a very fast background. Everybody knows well that this is a very deadly disease. I would say so currently it's the 7th leading cause of cancer-related morbidity, and it's climbing faster. So probably, as it is predicted, by 2033, it will be the 2nd or the 3rd leading one. And unfortunately, the prognosis is very poor, as you can see. Then the main reason is that the vast majority of the patient diagnosed with metastatic disease, and the remaining subset of patient diagnosed is locally advanced non-resectable disease, and the best life expectancy could be awaited from patient who has been operated. So the dominant pattern of failure, again, metastatic disease, but local failure is also an issue. I will show you later. In the recent years, there was some improving in terms of systemic treatment, and there's a technical revolution of radiation oncology. And there is some advancement. So what are the believed advantages of stereotactic treatment? When I'm talking about stereotactic treatment, it's a 5-fraction approach, but there are a lot of high-volume academic centers who are using prolonged treatment, but with very extreme dose escalation. That's why I also use another term. It is the dose-escalated hyperfractionated regime. So what are the believed advantages? Of course, we have some evidences that there is a association between the dose and outcome. It's coming from some retrospective series. And the second one would be the less systemic break, so less pause between the different chemotherapy cycles and just before surgery in the setting of neoadjuvant application. And of course, palliation, it is also a very important goal. So what about the indications? We have very nice papers. I've just listed 2 of them. What is the ASTRO executive summary, and the second one is it's a very good synopsis from the high volume academic centers. It's really a practical approach. So who is eligible for 5 fractions stereotactic treatment? Okay, locally advanced tumors and borderline resectable tumors, less than 5 centimeters, no big lymphadenopathy. So if you have a good remission after injection chemotherapy, you can indicate such a treatment. You have to use very advanced technology just to control respiration-related movements. And I think the most important exclusion criteria is the invasion of the luminal structures. So this is an absolute contraindication for SABR. And I would like to add another one. This is the CA99 response after induction chemotherapy. We have two nice papers clearly shown that there is a clear association between CA99 response and local regional failure and overall survival. There are some centers who are also using an absolute plafond as absolute limit just before SABR, for example, 300 units per milliliter. So some examples concerning eligibility. On the left side you can see a very nice case. In this case would be also operable. So with black line you can see the small tumor is quite far away from the organs at risk. You can also see the pancreatic tail with dilated versung, so it's a nice indication. But first surgery. The surgery would be the gold standard, but if the patient is not fit for surgery, you can recommend. In the middle, you can see a typical case for us. So big tumor, invasion of the vessels, very close proximity to the duodenum. So the major of the patients like this. And on the right side, you can see a clear contraindication. So the tumor bombing into the duodenum, there is a clear infiltration, so certainly not for 5-fraction SBRT. About target volume definition, I don't want to run into details. I think the most important one is that you have to include the vessels adjacent to the tumor. But probably this is not enough. Why? We have a very nice paper from China. So they have analyzed the spatial distribution of the local failures after SABR. They have found that more than 80% of the local failures could be found around the retroperitoneal vessels, so celiac trunk, mesenteric superior artery, or both. So the question arises, whether should we have to include as an elective target volume? And we have a pilot phase 2 trial with a very limited number of cases, but it's quite interesting. The protocol was 33 gray in 5 fractions, but after 8 patients there was an amendment allowing for inclusion of the elective volumes up to 25 gray. So it was a simultaneous integrated boost approach. And as you can see on the upper corner, that the clinical outcome improved. So there was a trend for improving outcome. So again, it arises the question whether should we, refine our target volume concept or not, like, Phil Jackson, triangle office. What about the dose fractionation? Currently, the recommended dose between 33 and 40 gray in 5 fractions. But right now, it is considered conservative. We have much more aggressive schedules. I have listed on the right side. So 50 gray in 5 fractions. So it's already BUD10, at least equivalent with 100 gray. It is considered ablative. So what about planning? You can see here a typical dose distribution of pancreatic SABR. The yellow line represents the 33 gray, and the red line is the 50 gray. So indeed, this is the focal dose distribution, because of course the organs at risk indeed do not allow for 50 gray for duodenum. So you have to indeed, fold the dose in millimeters. But so there is a high need for adaptation during the treatment, because there is a high variability of the volume and the position of the organs at risk. So that's why if you use COMBIM CT or CT-based treatment, you have to use PRV concept. So it means that you have to use a safety margin around your organs at risk as well. So your organs at risk definitely will overlap with your target volume. So you have to crop this volume for your target. And that's why this treatment couldn't be, a full dose escalation for the full volume. So don't forget this. Dose escalation, what are the pros and cons? Pros, again, we have some evidences that if we increase the doses, the outcome will improve. According to the retrospective series, probably we have to deliver more than 70 gray. Don't forget, this is focal dose escalation, but maybe there will be a bystander effect. Ablative, we don't know. What are the cons? We do not have hard evidences. Indeed, we do not have level 1 evidences. And it is considered that pancreatic cancer is an afferent systemic disease. Yeah, but this year we have a very nice trial. It has been presented in ASCO. It was the NORPECT-1 trial. So they have randomized a potentially operable patient. So with upfront systemic followed by operation and upfront surgeon, there was no difference. So again, another contradiction. So this is a focal dose escalation. So ablative only a certain part of the tumor. And again, you know, the anatomy itself determines the eligibility, and not only the eligibility, but the magnitude of the achievable dose escalation patient per patient. There is a huge heterogeneity, so we need predictive modeling. What are the known challenges during SABR? Everybody knows this, so it's a very difficult region. We have, you know, organs at risk around the tumor, very close proximity. Everything is moving by respiration, and which is I think the most challenging is the very high variability of the positions and the volumes. So we have to define our goals, and you know, at the bottom I have listed the percentage of the serious side effects. So, and then we have, and in the past trials we had grade 5 side effects due to bleeding. So we have a very wide technical platforms, you know, from C-arm Linux, Halcyon, CTON, Rail, and right now the new player is ML-Linac. And we have very nice features on these machines. However, these features, the availability of these features is quite different among the different technologies. But if we would like to put all of this together, and I think the most important is the visibility of the organs at risk in the tumor, or you know, the adaptive replaying and functional imaging on table, and you know, soft tissue visualization during treatment. Probably the game changer in this field will be ML-Linac. So what are the clinical evidences for borderline resectable pancreatic cancer? We have a level 1 evidence for neoadjuvant chemoradiation versus upfront surgery. So this is the new standard of care. There's no question about that. On the left side, you can see the meta-analysis. The benefit is clear. As you can see, there is an average of 10 months improvement in overall survival. On the right side, you can see the long-term results of the pre-OPENC trial, and also confirm this conclusion. What about SABR? Indeed, we have nothing. We have only one trial. This was the trial of contradictories. I like this term. This was the phase 2 aliens trial, and there was 2 arms. So it means neoadjuvant chemotherapy with FOLFIRINOX. On the other arm, the experimental arm, was 1 cycle less FOLFIRINOX, followed by SABR, 33 gray, and surgery, and etc. However, the trial was closed very early due to high rate of R1 resection, only after 30 patients, and nobody knows what has happened to this trial. You know, we have a lot of contradictories. So there was significant imbalances between the 2 arms. It was very low rate of R1 resection. So, and despite the fact that only 1 cycle less has been given, the rate of the distant metastasis on the experimental arm was 2 times higher. So the only conclusion what we can make that the 8 months overall survival rate, which was the primary endpoint of this trial, was really good after FOLFIRINOX, but we cannot conclude anything about SABR. Right now, this is a negative trial. Just surgical series. This is the surgical series of the Johns Hopkins between 2011 and 2016. As you can see, almost 200 patients is a lot. And they have retrospectively compared neoadjuvant chemotherapy versus neoadjuvant chemotherapy plus SBRT. And as you can see, the pathologic complete remission, R1 resection significantly improved. The toxicity is more than acceptable. However, PFS and OS was the same. Again, this is a recent publication from Johns Hopkins. Between 2016 and 2019, the SBRT dose was 33 gray. The resection rate was really excellent. It's brilliant. So almost 70% of the patients have been operated. And if you can see the LAPC patient, so 88% of LAPC patient got R1 resection. Excellent. However, there was a high rate of local failure despite these results, 33%. It's a quite high number. So probably our elective volume should be added. So probably we have to refine what is our target volume after SBRT. And right now, we would like to deliver 50 gray in 5 fractions. We have a very nice trial. It was the SMART trial. It has been published last year. And great reputation in the Radiation Oncology Society. The primary endpoint was grade 3 toxicity should be less than 0%, the trial met his primary endpoint. So yeah, amylinac could be a game changer. So 15 gray in 5 fractions could be delivered safely. However, some of these patients has been operated. As you can see, the resection rate is 34%. It's quite shy compared to the Johns Hopkins series. It's very shy. And on the other hand, there was a significantly larger need for, vascular resection and reconstruction. And on the other hand, you can see the grade 5 side effects. It was 6% versus zero compared to the Johns Hopkins series. Again, Johns Hopkins 33 gray, very high resection rate, no serious toxicity. But after ablative doses, we can see these kind of results. So the conclusion has been made that, okay, we should be cautious if we would like to operate this patient. What about non-resectable pancreatic cancer? We have some important trials for fractionated radiochemotherapy. This was the LAP07 and the CONCO 007. Both of them were negative trials. However, a subset of the patients had a clear benefit. It was the significant local control, the postponed interval till the systemic treatment. And for example, in the CONCO-1 trial, in which the R1 resection was the primary endpoint, for all randomized patients, the trial was negative. However, the patient who has been resected did significantly better in terms of overall survival. So, and the toxicity was minimal. And what about stereotactic ablative treatment? It's a very busy slide, I know. I tried to put together all important trials from 2015 because it was the first, I would say, breakthrough trial. It was the Herman trial with 33 gray in 5 fraction. And what we can see is that, the included number of patients is still very limited. As you can see, the gemcitabine-based treatment has been slowly but surely replaced by FOLFIRINOX, but don't forget, FOLFIRINOX only for fit patients. As you can see, C-armlinac has been replaced by amylinac. And again, just see the doses. So the BRD increased slowly but surely to 100 gray. And as you can see, the median overall survival, it depends from which date you will calculate, it's also improved. Right now it's 26, 28 months median overall survival. So it's not bad at all. And the toxicity is more than acceptable. So, so maybe there is something behind the technology. And we are waiting for these trials. We have 2 trials. The primary endpoint is overall survival. The first one uses 33 gray. It's more or less the same design as for the previous Alliance trial. And another trial is a new trial with amylinac, 50 gray in 5 fraction. Whether ablative doses could improve overall survival added to FOLFIRINOX. What about pain relief? We have a nice meta-analysis, and as you can see, we have a very nice pain response. It's a very important goal, I think, because in patients with pancreatic cancer, sometimes it's very challenging to control pain. So, and right now there is a very smart trial designed by the Swiss group, by amylinac, so it will be validated in a prospective trial. I think it's a very smart trial with a very good design. So what are my conclusions? Technical conditions are given for pancreatic SAB. There is an increasing use worldwide. You can find it in the NCCN protocol as well. amylinac will be a game changer here in this indication, and we're waiting for the results of the amylinac consortium from Electa. The grade 3 toxicity now is acceptable, is 0, beside an ablative dose. So yeah, technology brings something. The second one, do not forget, we're talking about an ultra-selected population, so the success of the technology related not only to the technical revolution, but for patient selection as well. We do not have level 1 evidence, so it's still unproven what is the real benefit for borderline resectable and locally advanced. Don't forget anatomy, it self-determines the eligibility and of course the achievable dose escalation. We don't know which dose to which volume, so we have a lot of questions. Local control is still an issue, even after R0 resection. Again, probably we have to rethink our target volume. Promising pain relief effect should be verified in a prospective control trial. And what we need is a better biomarker, better than CEA 99. So we have to select which patients prone to have more localized disease and which patient will have a very rapid systemic disease. But probably the first cohort will be our patients. And thank you for your attention.
Thank you, Dr. Avinsky. Now the paper is open for any clarifications or any doubts that the attendees have. Anything that you want to ask? Okay, yes, please go ahead. Can somebody give the point?
Thank you, Dr. Lacuzzi. Such a nice talk should not go without a question. I mean, looking at your presentation, one thing I find quite simple and straightforward is whatever you do, the higher extent of surgery as shown by the John Hopkins, 70% resectability, still you have a 33% local failure. So from the context, Indian context, are we ready to use SBRT out of a clinical trial? Are centers justified in using SBRT in CA pancreas outside the context of a clinical trial, given the challenges, 5 millimeter, without intrafraction, monitoring, it's extremely difficult. I would like to have your thoughts on that. And what is the pattern in your country? Have you adopted it without a MR-Linac, which is really humongous cost? Health technology assessment do not permit the usages with this kind of survival possibility.
Okay, my formal and my subjective opinion about that, I'm quite conservative. I wouldn't treat patient outside of a clinical trial because we do not have evidence at all. Because our work, our profession is, technical guided, market driven, as you mentioned. The second one is, whatever you have, because we have to also be aware that we have very nice results, even from high volume centers. The largest series coming from the membranous long quadring with 26 months median overall survival based on COM-beam CT. So we can deliver such a treatment with based on COM-beam CT and C-arm Linac. But probably the difference, the patient selection. With MR-Linac, you will be more, I would say, you will be braver, because you are more confident what you are doing, So probably you will expand the inclusion criteria. In my department, I add some slides at the end, but we're using COM-beam CT TrueBeam and triggered imaging and breast hold COM-beam CT and peritumoral markers placed around the tumor intraoperatively, just to be sure what we're doing. But the patient selection is very careful, So probably the difference between MR-Linac and, your C-arm Linac will be, I think, the patient selection. Because, I prefer, stay rather on the safe side. I know this patient has a very poor prognosis, but come on, bleeding is an issue. I like these trials, but if you see the previous trials, Herman trials, or even the Dutch trials with CyberKnife, we have grade 5 side effects. And, it's always written that probable not linked to our treatment. So I'm quite conservative, concerning patient selection, as I mentioned, we have nice results. We have just pilot results, very nice results. It's comparable with the literature, but no more than grade 2 toxicity at all. And 1/3 of the patients, have a very sustained tumor control. 1/3 of the patient very sustained. It means that 2 patients are still alive after 36 months after the diagnosis, even after end of the SABR. But I don't know whether it's linked to the technology, or tumor behavior. Nobody knows. But this is my answer. MR-Linac is a very nice tool, I think. I think the gold standard indication for pancreatic cancer maybe will be MR-Linac. And we are waiting of the results of the MR-Linac consortium, because there will be a huge amount of data from that platform and homogeneous data. And probably we will see it will be practice changing. But again, if you look at the numbers with MR-Linac and, for example, the membranous long quadring, the median overall survival is the same. I think the main issue will be the toxicity. So the grade 3 toxicity could be eliminated by MR-Linac. Yeah.
Thank you.
Thank you.
Thank you. It's a nice answer. But the point is certainly out of the clinical trial, we shouldn't be daring to include any of the pancreatic cancer treatment, even in our Indian setup. There are many centers, we are doing a SABR, but still it should not be out of the clinical trial. That's one. MR Linac, coming to the context of India, we have only one center in India, so therefore it can't be the gold standard as far as we are concerned. But we know that it's the way to go about. That's how these two can be taken in.
Yeah, I think,
I think we'll continue later because we'll have to other two people.
Clinical trial is how we learn.
Yes, that's true. Only thing, sir, I just want to say we generally tend to see only with a tunnel vision of a radiation. How precisely we give, how dose escalations but we really forget about the radiobiology and which works with pancreatic cancer. In fact, in pancreatic cancer, it is a stem cell the radio resistance that work. Unless we tackle that issue along with maybe chemotherapy or maybe target therapy along with radiation, I don't think we are going to achieve much more result than what we are really today. Thank you. And with that comment, thank you very much. And I'll hand it over for the next speaker to come. Thanks.
For the next presentation, we would like to invite you, Dr. Shirley Lewis-Salins, Head of the Department of Radiation Oncology in Kasturba Medical Oncology from Manil, Karnataka.
A very good morning, everyone. At the outset, I want to thank the organizers, Dr. Devnarayan Datta, Dr. Shruti, for this kind invite and to speak to you today on SABR for HCC. Now, HCC is a very complex disease, and I think we are still finding our footing for SBRT in this particular disease. And so today I would like to actually focus more on evidence rather than on the nitty-gritties of planning, because HCC is a multidisciplinary treatment, and often I see that we as radiation oncologists ourselves aren't able to put ourselves within the treatment algorithm and advocate for SABR. So to give an introduction, HCC we know is one of the most common cancers in liver. And of course, there are a variety of modality of treatment available, that is right from transplant, surgery, liver-directed therapies like TACE, TARE, and one of them in the armamentarium is SABR, and it's definitely more promising, and we'll show you the evidence today that very much applicable in all cases. More than the size and other criteria, I think it's very important for you to realize how the patient is. Most often it's in the background of cirrhosis. Nowadays we also see a lot of NASH-associated HCCs coming up, which may be likely non-cirrhotic, and they wouldn't have any history of decompensation or background liver disease. So for you to understand how well is the patient compensated or decompensated probably would be the most important thing when you're deciding for a patient to be treated with SABR. So your clinical examination, a good blood workup, gastro evaluations, assessment of tumor markers, biopsy probably in selected cases. Guidelines do mention that, especially in cirrhotic with classic features of HCC on radiology, do not warrant a biopsy. Only in cases when they are non-cirrhotic, you would ask for a biopsy. Get a proper prognostic scoring done for the patients, because you do not want to end up or jump and treat patients who are in child B8 and above, because their likelihood of survival with background cirrhosis itself is poor. So you're not adding much to their prognostication. Imaging is paramount. Identifying and visualizing the lesion is extremely important, and getting a full body imaging is also important. I don't say PET-CT is recommended for all cases. A CT thorax, abdomen, pelvis is definitely sufficing. But when we are doing something supra-major, like you're at many centers I know would also want to do some liver-directed therapy and transplant, or liver-directed therapy and surgery, then I think it's very relevant to do such certain imaging, which can be very sensitive for distant mets rather than done for the primary. So don't do PET CT to see what's happening within the liver, because that's not going to help. In about 30 to 50%, they're not even avid. So only if they're probably very well, most of them are well differentiated, and they're poorly differentiated, will have a PET uptake. Important here is just to highlight, we don't know that we have to look for the LIRADS 5 criteria, that is the capsule, washout, and look for growth. In PVTs, please try to identify which level of veins are getting involved, whether it is the main portal vein, so it's VP1, 2, 3, 4, or whether it is in the segmental branches. We all use BCLC-C for staging, and as per the new BCLC staging, even size of any cutoff can actually come in early. There's no size cutoff anymore now. And now with the expanded transplant criteria, some downstaging and transplant is also feasible. And I'm very hearty to present today that, the Indian National Association of Study of Liver Disease recently published this, and they've gone some steps ahead to divide the B into B1, B2, B3. B1 who may be more in favor for liver transplant, whereas B2 would be more well-defined lesions, B3 being more diffuse, and C is again dividing them into portal vein thrombus alone versus presence of distal nets. And even the D1, we can identify a subset of population who may be more eligible for transplant, that is the D1 criteria. And again, you can go through the publication which describes the two. Very important, all HCCs, please discuss in multidisciplinary tumor board, because you have to advocate for SBRT. Otherwise, all the cases end up going up with intervention radiologists, and everybody talks of TACE. And today I want to emphasize how SABR or SBRT can be a much better treatment than TACE, where you would require 3-4 times TACE to even get a proper response. So here I think the importance is to assess how much is the extension, how is the comorbidities, and socioeconomic status is also important in our setting in the country, where probably SABR is one session, or in other means, it's one treatment that is required vis-a-vis TACE, where you require 4 or 5 episodes, and imagine the amount of cost it may end up causing. So in that way, non-invasive SABR would be a very good modality. And I want to show you how SABR fits into different categories of HCC. Sadly, BCLC doesn't even fit SBRT there. However, if you look at the other guidelines, like the American at least have SBRT in stage A. ESMO also in 0 and A mentions that SBRT comes in the 0 and A category. NCCN of course puts it in different categories as a bridge to transplant, even in unresectable cases. Korean guidelines is the most extensive, very well defined, where in different cases how EBRT fits in along with the other modalities. It shows you very well how is the location of the lesion as well as the relationship to the vessels. And at least thankfully you can quote this guideline, which is a national guideline. And in this guideline they do show and have put in SBRT as a valid modality for BCLC-B, that is the B2 which I mentioned, well-defined ones, as well as C1, which is the presence of portal vein thrombus. And this has a set of people, that is the surgeons, the transplant surgeons, the gastroenterologists, radiation oncologists are very much in the group, which is a very good thing. Very good guideline to look at is the ASTRO consensus guidelines, which goes into detail into various steps. And this gives evidence for the various indications for SBRT, be it as a treatment when other therapies are not possible, or as a consolidation, or even in the palliative setting. So SABR is applicable across all, most commonly bridge to transplant, 0 and A, BCLC-B, presence of thrombus. And so far we used to talk of 2-year local control rates ranging from 68 to 95 because there's so much of heterogeneity of data. But this is a recent meta-analysis, a huge meta-analysis recently published in Red Journal, which I would like you to look at, where 5-year updates of this show that the local control rates are pretty good, above 80% to advocate. Of course, this is a mix of all the studies across the years, and shows significant benefit in larger or smaller, but of course the smaller would probably do much well. And differences in etiology also indicates how the disease may respond. Maybe the viral related one respond better. So in our context, again, that's one more thing. We have more of probably hepatitis B related HCCs, which again respond very well. and this is the recommendation they came to. Now I'm going to highlight some new trials which have come in different settings. Bridge to transplant, this is important because the waiting period is very long. This is a very large series from Princess Margaret where different methods were combined. It's a retrospective, but at least it gives you some understanding that SABR was used, albeit in low doses and even worse child performance, but despite that it did perform very similar to TACE. As you see the survival, of course RFA does better because they get all the best patients, well performing patients, but that does not mean SBRT is any less, and many did undergo downstaging and undergo transplant. The whole paper results are still awaited, and what I want to emphasize here is once SBRT done, patients do not end up requiring retreatments, whereas in TACE they end up requiring multiple retreatments, which you can see here. You can see, cannot have the pointer, which you can see here on the left side showing the TACE. And this is a recent publication in patients who are downstage for transplant, comparing proton with TACE. This is a randomized trial. And of course, I would again say all trials where SBRT is poised against different methods, no one wants to accrue. So there's going to be definitely poor accrual and then shun SBRT for not doing its work. But whatever cases accrue to the trial do very well. Now look at this trial. They've compared proton versus TACE, and in protons they've given 15 fractions. Although overall survival there is no difference, but all the other major and secondary endpoints, that is the first one showing the local progression-free survival, local control, as well as the within liver control, they were excellent with SBRT when compared to TACE. What about the duration of hospitalization post-TACE? Post-TACE is significant amount of hospitalization required with TACE when compared to SBRT. And the amount of cost saving was almost 28% because you have only one session required, whereas TACE requires multiple. And we always talk about toxicity and we blame SBRT for having liver dysfunctions or decompensations. Look at this. The yellow ones highlighted is related to TACE. And look at total bilirubin lysis. You can see it doesn't mean SBRT alone causes decompensation. Significant amount of liver necrosis as well as bilirubin rise is accounted by TACE as well. So do not think that it's only SBRT which hinders you from applying it in these cases. There are many ongoing trials for this particular setting. In event of time, I think I'm going to skip something about downstaging, but this is a randomized trial which did show that even in very early vein involvement, NART followed by surgery did give benefit in terms of surgery alone. Now, smaller BCLC 0NA, smaller lesions, these can be treated very effectively with SBRT. Especially we say not suitable, but even ones who cannot probably afford or cannot be comfortable for RFA or TACE in that setting have very good local control rates. And these are very new publications. I want to just show here a look at the dose fractionations. They're using 3 fractions in these, and look at the local control which I've highlighted, almost more than 90%, some even showing 5-year. And this is another one again published, again shows in 16:3 which can be delivered to very small lesions. And how about RFA? How does it fare well with RFA? There are many propensity score analysis which have compared and they're equivalent. In terms of meta-analysis, when they've put all these studies together, there is no difference in terms of local control with RFA. So definitely in early HCCs, SBRT is definitely a very useful modality. We may not get those referrals, but it's important to know. What we may get are these, which are no one wants to touch, which are very big, large lesions, and they are almost large lesions up to 15 centimeters, some even up to 20 centimeters. So how many will you treat? So usually one large, there is no size cutoff. So even in whether in the IEA or the RTOG study, they have taken even the largest lesions, even up to 15 or 20 centimeters. As long as you're able to spare adequate liver volume, that's sufficient. So those are the only 2 things that you should remember, that you have enough spared volume, more than 700 cc, and the child performance status should be A and B7, because it's known beyond B8 they will not do well. So the option here is either you do SBRT alone or you do TACE followed by SBRT. If you're thinking SBRT alone for these larger lesions, these are some prospective studies which have shown that there is some good local control. And if we want to mainly compare TACE with SBRT, these are 3 a good long-term series which have looked at comparing TACE with SBRT. Here I want to just highlight and look on local control. Two series show that there is significant improvement with SABRE versus TACE, whereas the first study doesn't show. And now we have recently this trendy trial which got published, again poor accrual, but what it shows that good done, well done SBRT, there was significant benefit in time to progression, significant benefit in time to local recurrence, as well as local control. You can see the local control at 1 to 3 years was all 100%. Of course, people will say these are plagued by low patient numbers. But when people are not ready to accrue to such trials, what do? Do you still wait for evidence? I don't think so. It's not possible to always sit and wait for evidence. And there is not much toxicities at all which were seen in the SBRT arms. In larger HCCs, TACE alone is not going to be sufficing. So if suppose one TACE doesn't show good response, possibly one should move on to adding SBRT. And these are some series, and I would just highlight the first one, that is the Buckenstein et al., which is a single study, again published in Red Journal, which shows impressive. That means one TACE, there is residual. You should start planning SBRT for these cases. Again, one more randomized trial, again impacted by poor accrual, but whatever they could accrue showed significant improvement in local control and progression-free survival. Impacting overall survival is difficult in HCC because there are many other factors which impact survival. It's not just the treatment alone, and there are ongoing trials for this as well. So recurrent HCCs also, when they're smaller, following previous treatments, comparison, this is a randomized trial with RFA, and this also shows significant improvement in progression-free survival. And this is from the ASTRO consensus that you assess those with liver confined, whether they're feasible for surgery, transplant. If not, among the different therapies, that is thermal ablation and catheter-based therapies, definitely radiation has its role there. What about when there is presence of macrovascular vein invasion? In this setting, this trial actually compared sorafenib versus addition of TACE plus SBRT, because TACE alone won't be sufficient when there is involvement of portal vein thrombus. Showed significant improvement, and this is more of conventional RT that they use rather than SBRT, but it showed good control. This is the largest series from PMH, which showed an impressive survival of almost 18.3 months, and those who actually ended up receiving sorafenib had much longer outcome. We all know, and we are eagerly awaiting the full text results of RTOG 1112, and this is the study which actually randomized sorafenib versus SBRT followed by sorafenib, presented at ASTRO last year. And if you look at here, it shows that up to 20 centimeter HCCs were considered. You can assess them for doses right from 27.5 up until 50 in 5 fractions, depending upon whatever may be the constraints that you can achieve. And what did it show? It showed that there was significant improvement in overall survival, significant improvement despite controlling for other factors. So all endpoints were met. How about toxicity? Toxicity rates were very, very similar. So definitely in patients with macrovascular invasion, radiotherapy has a role to play. You start with radiation and then add systemic therapy. One may question, in the presence of immunotherapy, does this trial still have relevance? I think it still has relevance. There are many trials which are ongoing looking at combination of SBRT with immunotherapy. But until then, if patient is not controlled locally, patient is not going to be fit enough to receive any systemic therapy. So it's important for you to do that. And now what doses to use, what dose and fractionation to use? Well, HCCs are very sensitive. So you have to remember, you do not always have to jump to treat up to 40 to 50 gray in 5 fractions. Depending upon whether they're cirrhotic, non-cirrhotic, what is their child status, you can decide different fractionations. You can drop from 5 fractions to even 6 or even 10 to 15, depending upon what mean doses that you're able to achieve. There is always a talk that in HCC, as we think in liver mets, should it be required that you give very high dose, more than 100, like in lung, how you would want to give. Now, this is a retrospective series, of course, and if you see, they've divided into 3 groups. And in all ways, actually, local control and progression-free survival got improved with more than 100. But this is another one, which is from ORI, and as well as the recent meta-analysis by Bay, they haven't found a similar dose response for HCC yet. There is our group, we are working on a systematic review and meta-analysis on this particular topic, which maybe in another 6 months you would hear from us, where we look at whether higher doses are absolutely needed, which even the liver giants right now do not recommend, as long as you are able to achieve a fairly decent dose. Very important is the critical planning. There is a lot on planning which I cannot probably cover in one talk, but what important is to stick to your institute, what's comfortable for you. You have to realize that liver has significant motion, so motion assessment management would be very crucial. Whether you want to stick with ABC, whether you want to sit with tracking, whether you want to do with 4D, you know your environment, stick to that, create your volumes. And adhering to dose constraints is very important, most important being the liver dose, because the liver minus GTV is very crucial. A lot of times people do not contour the liver appropriately. There are a lot of things which are included in the liver like IVC, gallbladder, which is not required. So maybe those understanding is important, as well as proximity to GI structures. You may want to reduce the dose that goes to the periphery and give a higher dose in the center, provided you are able to meet all the constraints. And these patients have cirrhosis, they're going to bleed from varicose bleeding too. So you have to think that you should not be adding to that bleed. So important is that you do your planning meticulously. We are always thinking about toxicity, but I think toxicity, particularly with the now current rates, the rates of RILD have dropped significantly. Even in the recent ones, they could just find maybe 3 to 5% if you've done it well. GI, again, 5 to 10% are the rates, depending upon what doses have been achieved. Lot of advances happening. MR guided treatment is able to adapt the dose and particularly give a higher doses to these cases, even single fraction. Excitement about immunotherapy, definitely, but we don't have enough data and a lot of studies going on. This is very early, and there's one in the Red Journal which is published on 14 patients, which shows some amount of partial and stable responses, but not those typical expected abscopal effects yet in HCC. I just want to show with one case where, you can see this is a big HCC in the liver, where involving the segment 2, it's like kind of like a hanging growth from the liver, and it's like an A5 patient, but the patient wasn't very fit to go enough for surgery, and they had already started this patient on sorafenib, and this lesion you can see here is touching onto the stomach, and he had issues feeding and hence got referred to us for radiation. So we said, okay, it has significant proximity to stomach and duodenum, but that does not mean I turned away this patient and said we're not going to do SBRT to this. We did do SBRT, but in a very different way, where we ended up prescribing 20 to the periphery and gave much higher doses at the core of it. And this is at 3 months, and you can see the entire lesion underwent kind of a necrosis. There is no more enhancing component remaining, and you can see the dramatic response that happened in this particular case. So the larger ones also do respond very well to SABR. So the conclusion is that the SABR in HCC is safe and effective. It is applicable across all stages, but I think the most important is that you select your cases well, do good meticulous planning, and respecting the tolerance. I have a lot of slides on my own cases and pictures and planning, and I'm happy if anyone wants to come and see them with me, but I right now cannot show all of them in interest of time. Thank you. This is my team.
Thank you very much for very interesting presentations, and I believe that some colleagues has questions, but please write down or keep in mind these questions until the section of discussion. Thank you very much.
Thank you.
Our next talk is on the overview of SRS in gastrointestinal indications by none other than Professor Rahul Krishnadri. He's very famous. He's a professor in Department of Radiation Oncology, Tata Memorial Hospital, Mumbai. Dr. Krishnadri, please.
So good morning, everyone, and thank you for inviting me for giving this talk. And I think both the speakers have done real justice, but it will be still a difficult task for me to cover and overview everything. And what I represent here is a huge body of work for last 10 or 15 years from the whole team, primarily Dr. Reena, who's not here today. So this is our department, and we have 3 radiation oncologists looking at GI malignancies only in radiation oncology. And what you see is a tremendous change of almost 3 times the number of radiation treatment that we do in a year from last 10 years. And that's the growth and the potential. And if you look at the numbers, so pancreas and liver, almost like 60 to 70 patients in pancreas every year. And liver, we have just put up our team again to revival, so we are again getting referrals and we're doing more at them more commonly. And a huge number of SBRTs, right? And they include patients beyond what is liver and pancreas also, and I'll show you some examples. So today's overview is just to focus on pancreas, liver, and then a broad category of oligoprogression, oligometastasis, oligorecurrences, whatever way we want to classify them. And they can be primarily from GI cancers or other cancers coming to the GI sites. So I'll not go into these definitions, and I think I can skip few slides just to do the justice to the time. So we know where we are needed, probably in borderline and locally advanced. And we know that R0 resection is critical to have impact on overall survival. And to impact R0 resection rate, we need something new adjuvant. Adjuvant probably cannot help it always. And if we look at autopsy data also, local control is an important factor itself to control the overall survival in these patients. So almost 30% of the patients will die of local progression itself. And so it's an important factor. Second, almost 80% of the patients who are R1 resected, will progress locally. So again, it is important to emphasize that local control has to be strengthened. Now this is previous alliance in which FOLFIRINOX versus CTRT was compared. And what we see that if you do not give chemotherapy, there are 2 times the distant metastasis. And if you give radiotherapy, the local controls are 3 times better. So you really need a balance, what my even previous speaker said, that you have to optimize both chemotherapy and the local treatment, both either in the form of surgery or radiation or whatever type of radiation we want to use. Now these are the guidelines which I don't want to emphasize, but what I want to say is broadly, but guidelines do mention radiation oncology role, but they still do not go in detail whether you want to do cyber or you want to do fractionated, because still it's a controversy. Now if we broadly look at the data, so I think the previous speaker showed you LAPC, and thankfully I'm showing you BRPC, so it's good. So this is the data for all the BRPCs, probably what you have for chemo. So what I'm trying to show you is best of the gemcitabine data, right? So that's around 26 to 24 months. They can be poor also, and that's because the heterogeneity in which we have been defining our BRPCs and LAPC. It's a huge thing, and we might soon get a newer classification which incorporates CA 19.9, whether we understand well or not, but there will be something coming up soon. And if you look at FOLFIRINOX, again from the alliance, it's again same 27 to 26 months. So can we say them equal or not? I don't know, right? Because there's no head-on comparison, but we can presume to be. And then if you look at the CTRT best data, it's again in the same range, right, for the BRPC. So does the local RT helps or chemotherapy? Any chemotherapy regimen is similar to CTRT, is similar to new adjuvant followed by CTRT? We don't know those answers. And probably we need better trials, and I think we should not jump the gun as well. And it's a journey, right? So it's a difficult thing to learn, to reach there, to be comfortable doing cyber. So today I say if I do a standard trial and prove that cyber is better, it may be better in my settings. It takes a whole team, right? So you need to develop a program from where we started doing in 2008 with 3D CRT, we got with IMRT, and then over almost 5 to 7 years, it took from the dose of 30 gray in 10 fractions to what we are doing today as 45 gray in 5 fractions CT-based, right? And the patients who are not that suitable, we go to 12 fractions or 15 fractions, which you have MD Anderson data, as well as now European guidelines. So there's no strict line, but you have to reach there. So again, this is our preliminary data, which even Shirley was there with us in this development when she published this, our initial data at TMH. So what you see is very encouraging early data, which is BRPC, almost 77% R0 resection rate. But again, it's a definition of BRPC, which kind of patients got selected there and what you saw there. So why SBRT? Because the treatment is quicker. A disease which has such a systemic component, distant metastasis, you don't want to hold patient for 1.5 months on a local therapy. So probably you can get quicker. It's a radio-resistant disease, so you won't want a higher BED, and that's the only way, but you have to be safe with that. And you want almost similar toxicity, probably in a safe hands. Maybe a learning hand, you have to learn slowly, otherwise you will burn your hands. Now, this is something that I want to show from our learning curve. So this is our initial part where we figured out whether we want to do DEBH or DIBH, and there was some dosimetric advantage by DEBH. So that's how we continue. For all GI tumors, we do DEBH. And for the uniformity of care, so that there's no confusion on the board for liver and pancreas, we routinely do only DEBH. We don't individually select those because that's easier for a large academic center. Quality training. So I don't think you can see the lighter lines, but those are in the local language. So these are the patient instruction sheet, which are in English as well as in local language of patient's choice. And then there's a complete feedback loop from the clinic to the trainings unit, and from back to the training clinic, and then to the simulator. So there's a complete loop of information of the training and the compliance of the patient to the protocol. Then next is how better you may do as a planning protocol or your fasting protocol. You will have bad days, right? Only thing you can do is probably minimize those. And that will be a big boon to the department also, because you will waste less machine time, there'll be less peer pressure, and there'll be better outcomes for the patient because you can actually match them in a perfect way. So these are the better examples which have come after we started working constructively in a positive way with these issues. So this is one of the few early data that we looked at a higher dose in SBRT. So when we tried to reach from 36 to 40 gray, and what we see was mainly the patients who underwent surgery, that we know from other data also. Like for BRPC, the patients who get operated, they have a better outcome with SBRT as compared to who cannot. But still, their outcomes are almost similar to what if they would have got chemo alone also. This is one of the examples of the response in locally advanced. Now this, I think no talk on pancreas can get over without talking about this study. My previous speaker also spoke about it, and this is one of the justifications that they have published just after that study. Some of that is probably what we know is, the dose of radiotherapy, which is probably homeopathic as compared to what we are talking 45 to 50 gray BD of 100. And then chemo differences and all those, but I think it was too early to be analyzed at 30 patients. And there was more to learn. And most important point that I think most of the reviewers or the editors have missed out is the timing of randomization. And why we say that? Because we are wiser with our own data. If you see this is whole BRPC population that we saw from 2016 to 2021, and almost 30% of the patients, right, they progressed after 4 cycles of chemotherapy. So if that is happening there at randomization, and you have not stratified yourself for that, you are in a big danger for 20 patient sample size, right? And you need to know what doses we need. We need to reach 100 gray. And this is what I think one of the slides that I've stolen from Astro. So what they've shown here is 1.5 years BRPC outcomes with higher doses, 83%. Never heard of that, right? And then LAPC 68 or 70%. So they may have more updates, but higher dose is definitely going to do something. That is what we want to imply. Now this is our LAPC data, and when we did a match pair control, so I've not shown you the match pair outcomes for the BRPC because there's a huge bias which we cannot negate. We can discuss if you have a question for that. But for LAPC, if you do a match pair control, other than the anatomical factors, the most important factor is radiation dose, which is 75 gray over here. And then if you look at the outcomes of chemo alone is standard what you get 18 months, and with radiation, it's almost touching BRPC, a good BRPC. Although I can assure you, nobody will give a good BRPC looking like a LAPC to a radiation oncologist in any good team, right? So this is just one example that I wanted to show. It's a locally advanced LAPC, which is deemed as unresectable because involving all major vessels. They cannot do any kind of a grafting or bypassing that they can imagine. And that's why it's sent to us. After chemotherapy, there's some response, but still unresectable. And then this is a standard contouring guideline that we do, which is GTV plus TVI plus 3 milliliter margin to a lesser dose, and then you shrink it inside as per the guidelines. This is what we are looking at currently to do 2 prospective randomized trials. And we are trying to learn from what Alliance had done. So we are going to randomize after a few courses of chemotherapy when biology has told us that you have bad disease out. And the second thing is, basically it will be not a multicentric because there are challenges with that. And I think others will agree to it or we can elude later. Recent advances, so we just started incorporating MRI for our at least planning purpose for all patients. And there are some things that we are learning, how to identify tumor or maybe make a tighter GTV identification. Whether that will be helpful or not, we're not sure, right? But we're still learning at present. But what I can show you here, if you look at the PubMed for last 10, 15 years, SBRT is now almost mirroring all radiotherapy publications related to CA pancreas. So it's coming in a huge way whether we like it or not. So better we start learning it. We may not be able to do 50 grade tomorrow, but I think it's the way to go. Now coming to the next topic, that is HCC, I think Shirley again has covered very well. I just will highlight there are issues, and it's a challenge because it's a dual challenge. That a tumor is embedded into the most critical tissue, which is liver itself, and the luminal tissues are also not very far. There are too many choices, and that's why the conflict. And it's very difficult to resolve that conflict, whether it is a guideline or running a trial. So if you look at the timeline, we have SBRT almost from 2005, which it is published, and it is quite available in the literature. But if you see the publication graph, it's lagging. It's not somewhere close to what we saw in the pancreas, right? But it can be a bias because radiotherapy has taste and tear also, and most of the quotations will come like that, but still it's lagging behind. And which reflects in the poor reflection of radiation oncologists as well as radiation as a modality in the major guidelines across the globe, right? So BRPC, I think this all Shirley had mentioned, so I will go faster. And most of the trials have not either finished their accrual for 7, 8, or 10 years, which is a very poor show, but because probably the team doesn't like us too much in the liver side, right? Yeah, and the trendy trial, I think Shirley also showed, very poor accrual, and this is just one example. I think the literature is full of such examples. Even RTOG 112 closed early because Etizobev had come up, right? So the challenge continues, and some guidelines are making it better, and I think Astro, Korea, and NCCN, and then again, Indian ICMR guidelines still just mentions SBRT. This is something that the consensus meeting we had at TMH a couple of months ago. It's a manuscript in publication, but we still mention SBRT, and we enforce that it should be a part there at the relevant places. This is the current paper that Shirley also showed, and they have also emphasized that SBRT should be brought up so that at least some data, background data, is generated in the ground. And if you look at the guidelines, I think most of the people will still agree, or if you combine everything that you have as an evidence, that there's no possible tumor in HCC classification that probably you cannot fit RT as a role. So, that's something that we all need to understand and recognize. So I'm just showing you some fancy stuff here after this, because I think papers and everything has been all broadly covered. So we just added MRI to HCC also. So apart from, giving some wrong tumor signals to be identified better on MR, which are mainly arterial artifacts in angiography for liver, there are other advantages also. So what you see here is the bilobar disease, multiple tumors. So we thought we will cover one side first and the second one later on, because we could not have managed to save the normal liver. So we went with the first side on the right side, which was almost 55 grain 5 fractions. And then after 6 weeks, when we repeated the MR to look at the tumor, there was a new tumor identified in the middle, right? So, and that was missed on CT scan. So we could not have seen this new tumor if we would have just gone with the CT planning, right? And then we treated both the tumors, and now we will be just waiting for next follow-up for what happens to him. Now, immunotherapy is coming big way, and there's some data which is showing very promising to combine SBRT with immunotherapy. There are some dramatic responses, and hopefully there will be a good trial in coming future for that. Proton, so I think NRG is already conducting a trial for comparing proton versus photon IMRT, SABR, and I think there should be a good deal with that. And proton, we have just done the dosimetric studies now for that, and we'll be moving for the clinical part also soon. Now coming from liver to the metastasis from whether it is, or the recurrences which are from the GI cancer. So there's a large body of data, but I'm not going into detail. Largely it is from pancreas. So you can refer to them, but all patients are not for that. The oligoprogression has to be defined very clearly, and there's a limited benefit. So you have to justify what you're doing and when you're doing it. So, but what I can show you is probably what we did in stomach, and they had come significantly good, a benefit or improvement, especially for the lymph node recurrences for the stomach cancer post-surgery. And many of these recurrences were within 6 months to 8 months when they were on adjuvant chemotherapy. So the lymph node recurrences really do better as compared to, the luminal recurrences. Now these are the few examples of other tumors coming to GIT sites. So this is an RCC of head of pancreas metastasis. So we did SBRT for that with some margins. And this patient is locally controlled for 2 years, but had other sites of metastasis at progression. Now, this patient is another one, similar one, but it has multiple pancreatic deposits. It's not solitary deposit, so it's multiple, and we had to treat the almost whole of the pancreas with boost to all individual sites that we could identify on the CT scan. And he's also pretty well, doing well after 4 months right now, but we'll see how it goes unfolds in the future for this patient. This is one of the lung mets for the colon cancer, brain met, which I think you are already exhausted, so that's why I kept it in the last, because I think you've been listening that for long. But that's one of the examples that we can do. But at the end of the day, it's a village, it's a city, which takes, to develop a GI SBRT program. It's not something, that we alone can pull off. It's need support from surgeon, from medical oncologists, med GI, your radiologists, pathologists, everybody. So, and this is the GI Oncology Society that we have recently started, and I would request everybody to support it. Thank you.
Thank you, Dr. Krishnatri. Very crisp talk on the very interesting GI SBR. I also support your mention regarding that point of randomization. That's very important. We all know that pancreatic cancer is a chemo-resistant and radio-resistant. But we have got things like SABR to overcome that radio-resistance. But I don't know what the medical oncologists have to say, because they are still continuing with chemotherapy. And in the future trials, I saw to my dismay that almost all the trials are having chemotherapy plus SABR. Anyway, any discussions, we can have it now.
So you need to make a team. You have to have beer or something that they like.
Yeah.
Very interesting presentation, Rahul. So in multifocal HCC, is there a number to which you can irradiate, or as Shirley said, as long as you can irradiate?
We're just exploring our limit. I showed you that we were not able to meet our limits in the first go. So we waited for 6 weeks, which is now very common for brain mets. Now they are exercising. So we thought, why not explore it in liver? So we did one side and then waited for 6 or 8 weeks. So that there was no toxicity even with the first course, but we still waited for 6 or 8 weeks so that, there's some recovery in the normal liver function, which if it has been subtle, which we cannot monitor by labs, and then we irradiate the other side. So that is very commonly that we are now doing, because that's the patient population who comes to us.
And now with Atezo-Bev becoming the standard of care in terms of systemic therapy, how soon can that be started after completion of radiation?
So we've done very few, because not many patients afford that right now. But we don't hold Atezo-Bev until unless medical oncologist is scared, and they have come out of their fears because they've seen few patients doing very well, continuing the Atezo-Bev during that. But there can be various philosophies to, the
allow
sequence
that
it.
during radiation therapy as well?
Yeah.
But then would you not be concerned about fistula bleeding with BEV and luminal strictures of...
So all that we take care with the plan, so what, I'm trained from brachy to SBRT, so I don't like uniform dose. Yeah.
Wonderful.
Yeah.
I generally don't do it. There was a lot, there's I think 1 or 2 phase 2 studies which were looking at liver, especially combining immuno with SBRT for liver. But it's okay to not have it concurrent. IO probably okay, but not the BEV part. BEV is one which is very tricky. There's a lot of work coming in lung also, which says that even up to a month it's not safe. So I think it's caution right now because no one knows. There's a good paper which has looked at sequencing of various chemotherapy with, it is published in Advances. One can look at, especially different drugs when they're combined with liver SBRT. But especially in the metastatic setting, people have gone ahead concurrent. But in HCC, no, I think it's a little tricky. We don't know what may overwhelm the liver.
See, it doesn't matter in brain.
Yes.
We give it with even DIPG. So,
yes.
I mean, it's you want to be cautious. I'm for it.
And
Be
also
cautious,
for the thing of what may be the number of lesions that you want to treat, I think it will be depending upon how much you can spare and also how many are there. If they're all very small, then up to 5, your typical criteria, I think that would be fine as well because you have enough liver remaining. But you had, like the one he showed, he had a big one. I think when you're putting such sequential RT, it's also very important that you look at what is the V20 and the V10. because your subsequent doses of radiation cannot be overlapping onto the V20 of the previous one. Patients will end up in decompensation. This was at very short time. I have burnt finger with one patient who I re-radiated, was in a totally different lobe, small lesion, just 2 centimeter. 2 centimeter was in the segment 4, which I treated with SBRT, completely did well for a year. Came back in a left lobe lesion, which I treated, but decompensated within 3 months. This is all with full.
So re-radiation, even I had a patient
very
who's-
difficult,
who,
so-
you know, but he passed off because of a cardiac failure, not due to the liver failure, but they are challenging. Re-radiation is challenging. If you do it early on, it's acute change still happening, and then you
There's
can
not
pass that.
much
Yeah.
work
Rahul,
done on this.
always, whenever we irradiate, be it a liver, be it any other place, previous radiation
Yes,
dose
yes,
has
it's
to be
very
taken.
important. It's very
More
important.
so here, what
Yeah.
is,
Yeah.
Shelley is telling is absolutely right, and we can't really forget that. Huh? That's true. Any other questions on either to Shirley or to Rahul?
So I'll just.
Yeah.
Yes,
Um,
please.
Is there a role for, in intrahepatic cholangiocarcinomas, we have a lot of unresectable carcinomas which go for palliative chemo. In some cases, you do find really good responses. In such cases, is there a role for SBRT in intrahepatic?
So I think that we have missed over here in the overview, but yes, we have an ongoing randomized trial comparing SBRT in those unresectable chemotherapy patients followed by chemotherapy followed by SBRT versus chemo alone. And we
Doses would be similar to what you would give.
so
in
we try
itself.
to reach 100 gray, but again, you can't reach it
Depending on
all
the
the time. Depends on the location and all the precautions that I would like to re-emphasize for the course.
Thanks.
Thank you. Thank you so much. Thank
Sure,
you,
thank you,
Rahul. In fact, I know these 3 talks were really enlightening and very good one, and we have really learned. And in the first one, started with the first pancreatic the tumor, and how difficult but how careful we should be, and using a clinical trial only we should try, and what are the future MR-guided treatment is going to help us. And also, we heard from Shirley, and particularly the TACE. The only thing, Dr. Shirley, is this. I really prefer when TACE doing people are here, and when we raise this question and have a good debate, that will be the good, know the audience to listen and come to conclusion. Otherwise, it becomes a one-sided, and because we love radiation in any case. And the third one, of course, in the GI, particularly with the use of immunotherapy, that's also, catching up very well, and we must keep our eyes and ears open on how do we really harness it and leave it, everything to the medical oncologists, not the way to go at all. With that, and the first session of the, we will conclude, and thank you so much, and to the moderator and to our co-chairpersons, and then we'll proceed to the plenary lectures. Thank you so much.
Our next lecture will be on the SRS and SRT of renal cancers. I would like to call upon the moderators, Professor Apu Thomas, Professor and Head of Department of Urology and Renal Transplantation, Amrita Hospital, Kochi, and Dr. Maris Mezikis, Senior Radiation Oncologist, Stereotactic Radiosurgery Center, Sigulda Lativa. I request our moderators to introduce the speakers for the session.
Dear colleagues, we should move to the next part of our educational course, and next will be a plenary lecture, Stereotactic Radiosurgery and Stereotactic Radiotherapy for renal cancer. And we would like to invite Professor Apu Thomas, Professor Vedang Murthy, Department of Radiation Oncology, Tata Memorial Center, Mumbai.
After that breathtaking session, where everybody was holding their breaths, including the patients and the doctors, we can now relax. And as we go down the body in the ISRS meeting, we reach some very exciting possibilities for our field, the kidney. And there are many questions that we as radiation oncologists have about kidney SRS. But let me get down to the most crux of the issue that most of you probably would want to ask. Can I do it? The simple answer is yes, you can do it. In keeping with the NMC now retracted guidelines, with any of these generic radiotherapy machines. But what do I need? You simply need conviction that you can do it, and you need to be able to convince your urology colleagues that it is possible to be done and there is a case for this. You just need a modern LA with good image guidance, and you should be able to deliver about 40 to 50 gray in 3 to 5 fractions with good physics support. I think that is the minimum we can expect in a good department. So that's what you need. Let's try to answer some questions that you may have as radiation oncologists or your urologist might have to ask you. You can ask, what is the local control? Is it really safe? Can I really pull it off? I have a standard LA. I don't have the, the most glittering machine. What fractionation should I start with? And what are some of the issues with planning and motion management? Your urologist may have a different set of questions. Patient doesn't want surgery, not suitable. Why not RFA or thermal ablation? Patient has only one kidney. He had a kidney cancer 5 years back, other kidney is gone. It's a big tumor, are you sure you can do this? And how do we follow up the patient? Since time immemorial, the conventional wisdom has been radiotherapy doesn't work in RCCs. We all know this, there's no doubt. But that has been because of an obvious problem. The clinical part of that problem was in the 70s, 80s, 90s when it was tried, there was no benefit, there was detriment, and there were relapses. Really, it was not a pretty picture, and of course, it was not working. There was also the problem of technique that we don't have today. This is how they were treated, and of course, it's not going to work. There was also a not so obvious problem of radiobiology. This was picked up initially in the classical paper of Deacon and Steele. They said that kidney cancers might be more radioresistant. And much later, it was also suggested that kidney cancers might have a low alpha beta that we all hear about prostate. So, this is what high dose per fraction does to a kidney cancer, and I am sure you cannot make out what that actually means. So I'll try to explain it to you as I understand in a simpler manner. When we give fractionated radiotherapy with normal fraction size, there is tumor cell damage directly, and there's also microvascular dysfunction. But in the presence of hypoxia, the endothelial apoptosis, that pathway is blocked because of the VEGF and HIF1 translocation pathway, and that mechanism gets obstructed, and 90% of the kidney cancers are thought to be hypoxic. Main reason why it doesn't work. But what a large dose per fraction does, 7 gray, 10 gray, 12 gray, is the hypoxia becomes irrelevant. A different pathway, again there is direct tumor cell death in red, and the different pathway takes over called the ceramide pathway. Acid sphingomyelinase is activated, and that damages the endothelial cell. So basically you overcome hypoxia. Now leveraging all the technology that you have in all your departments and you've heard over the last 2 days, and leveraging the biology I have just showed, we can challenge the conventional wisdom and say that radiotherapy does work in RCCs. Is it effective? We have known for many years now that for intracranial SRS, and you heard for the last 2 days, and extracranial, in metastatic RCCs, it works very well, but that is not our problem today. We are only talking about primary RCCs. This is a snapshot of what has happened over the last couple of decades now. Largely the work on SABR or SBRT or SRS in kidney cancer has been led by Shankar Shiva from Melbourne, and a consortium called the IROC has been established over many years. In 2006, you can see in the center something happened, a small prospective trial in SABR was published. And since then, it's kind of taken off. You can see conventional versus SBRT, and it's expected that there will be more and more SBRTs that will be treated. The first consensus guidelines of IROC came, that established many things for us radiation oncologists, came in 2016. And a lot of the data I'll show you comes from this IROC consortium. In 2019, a large 372 patient study, this was a meta-analysis, median follow-up of 28 months, number of studies were put together. Median tumor size was 4.6 centimeters. Forget all the little details. You can see at the bottom, well, 97% local control, which is pretty high for a primary kidney cancer. At a 1.5% grade 3-4 toxicity. So from so many studies, one has to believe that it can control and it is safe. The most recent paper is, I think, quite a benchmark in this field. Again, from the IROC consortium. This was in the Lancet Oncology. 190 patients who had a 5-year follow-up. Many of them were medically inoperable. You can see the tumor dimension was more than 4 centimeters, the mean, and a third of the patients had actually a single kidney. What did they find? At 5 years, 92% patients had a cancer-specific survival. 5% had a local failure, and 11% had distant metastasis at 5 years. So this is very robust, and these are all comers. Many of them are frail, many of them are older, many of them cannot have surgeries. The other thing that we talk about when we talk SBRT is size. Is it suitable for larger tumors? This was a paper again from IROC, focusing only on T1B. T1B, for those who may not know, is more than 4 centimeters in size. 30% were solitary kidneys. Imagine, more than all of them are more than 4 centimeters. 30% are solitary tumors, solitary kidneys. Again, fantastic outcomes, even in larger tumors for local control. Of course, if the tumor is larger, the outcomes are not going to be as good as for a smaller tumor, and that is true even for surgery. So, on multivariable analysis, cause-specific survival, cancer-specific survival, PFS, of course, will decrease as the tumor size increases, but for smaller tumors and larger tumors, there is no difference in local control. So, SBRT is still doing its job for larger tumors. Solitary kidneys, I talked about it recently, again from this most again from the IROC meta-analysis. This was a paper of 81 patients who only had one kidney for whatever reason. Mostly it was previously, it was a metachronous RCC. And not a single patient required dialysis, which says a lot. First, we have to believe that it is possible, then our urologist friends will believe that it is possible. So, you can pull off SBRTs in single kidneys provided you select them well. It should not deter you from going ahead. The choice is between removing the kidney, doing an NSS, which again will have a lot of loss of nephrons, or SBRT. The guidelines talk about other ablative therapies, basically thermal ablation, cryoablation, radiofrequency ablation, microwave, HIFU, etc., etc., etc. And they say that the eligible patients are as follows: small mass, elderly, comorbids, multiple tumors, solitary kidney, etc. And lo and behold, this is exactly the patients that are suitable for SBRT. But what SBRT also does, and these other modalities are not suitable for, are larger tumors and those that are located proximal to the hilum or near the ureter. That is not a contraindication for SBRT. There is no randomized trial between RFA or SABRE. There's one that is being ongoing called RADSTER, led by Dr. Swaminath in Canada, and that should be very interesting. This is what SABRE does over thermal ablation or other modalities, and I think this is very important to understand when you are counseling your patients and you are speaking to your urology colleagues, that this is what we can do that other modalities cannot. We've already shown 95% control. We've already shown safety, and this is where we need to make our foray into this field. Assessing the tumor response is a tricky thing. Broadly speaking, the response is slow but continuous. Slow and steady is the word. And this is how it looks. Mostly it goes down. It can go up sometimes. Beware of that. Just like I'm sure you must have heard about all pseudo progression yesterday, it can happen here as well. Don't biopsy. I'll tell you that in a minute. So, over years, you can see that it takes years for it to reduce even by 50%. Should we biopsy this on follow-up? How do we know it's worked? Even patients ask, how do we know it's worked? Normally we use MRs for monitoring size. Very small study, I'll give you an example. They looked at, very brave people looked at dose escalation up to 60 gray in 3 fractions. But that's not the interesting bit. 5 of them got a biopsy in 6 months. All were positive. One had a cryoablation, somebody panicked, I think. One died of an unrelated cause, and 3 of them later were all disease-free and progression-free. So clearly there is a disconnect between the biopsy positivity and the disease outcomes in kidney cancer. So don't biopsy. I have spoken to my pathologists also, and it is really, we do not know the reproductive viability of a cell on H&E is not clear. Nobody knows about it. So I would really insist on avoiding a biopsy. The other thing we monitor is renal function. So we've done the tumor. Of course, renal function will drop. It will drop. There's no question. You've treated. How much does it drop? In about 3 years, it drops by about 10 mil per minute, the GFR. And in about 5 years, on an average, it drops by about 13 to 14 mil per minute. So that is the margin you have to keep. If the patient has both kidneys, I think it's an absolute no-brainer. It doesn't matter, especially in a single kidney, this becomes important. It's crept in the guidelines. Well, NCCN, EAU, they are all talking about it, not in any great or effusive manner, but they are still talking about it. And I think it's our job to make sure that we talk about it more often. Now, where does it fit in my practice? What do I tell Dr. Jinil Kumar here as who are the patients who are suitable? I've already shown you what the alternatives are. So, old man or woman, inoperable or doesn't want surgery, single kidney, too big for RFA, NSS, close to the pelvis, close to the ureters, maybe detected as a synchronous or a metachronous tumor. Has many times we see patients with see a cervix, see a this, see a that, see a breast, get a CT scan and a small tumor. It can easily be ablated. Let me talk about some techniques. Before we start, it is important to make sure we get a biopsy. Surgeons don't do a biopsy, they take it out and then look at it. It's easy to forget to do a biopsy. Make sure you get a biopsy before you do SABR. Check GFR at baseline because we know we want to monitor it. Now, simulation is pretty standard stuff. I would use a body bag or a vac lock. We tend to give a slow IV contrast if the patient doesn't have allergies or there are no other issues with contrast. We give peroral contrast also for the small bowel. Small size thickness, I don't have to tell you, pretty standard stuff. MR can be used with GADO if contrast is not possible. MR can, if CT contrast is not possible, MR can be really helpful. Somebody was asking me what motion management. Choose whatever you want, right? Keep it simple. If you have 4D CT, making an MIP, do it. If you have a breath hold, Rahul spoke about expiratory, you can do inspiratory. Whatever is suitable in your system, do it. If nothing is suitable, don't do it. It's fine. There are several instances where there are no significant bowel around it. Don't do it. Just give a slightly larger margin, superior, inferiorly, 7 mm, and go for it, I think. So don't fuss. If you're using things like intra-tumor tracking, please, of course, you'll have to use fiducials. On planning, we insist on using FFF because it reduces the treatment time. Sometimes our physicists in their own little world and their hurry, they would do with a filter beam, and then I have to say, no, please use a filter-free beam. We give 15 gray, 12 gray. It takes time even on a machine like TrueBeam. So filter-free is absolutely important. And if you are not sure, build in a break in between. Make sure there is a CBCT that you do intrafraction. That's absolutely fine. We have used to generate ITV something called a CineMR. I hope it works. This is what a CineMR sequence looks like. We see the tumor and we estimate based on that what ITV margin to be used when we were not doing breath hold or other things. And if you've got friends in radiology, please make use of this. Target volume delineation is pretty standard. You see, if you're using 4D CT, use the MIP, give a margin that is ITV, and then give 3 to 5 mm for that for the PTV. One question that comes up is renal pelvis and OAR? See, it's very often close to the pelvis. It is not known to be an OAR, but I would still plan tight around it. There are theoretical complications possible if you treat the pelvis or with a higher doses of pelvis, like hypertension, vascular stenosis, or ureteric stricture, but that is not something that has been proved to be an OAR. Bowel, especially small bowel, separate it out, large and small, because there are different constraints. Use and the recommendation is to use a PRV around the small bowel of 3 millimeters. This is in one of the protocols called Fast Track. You can see if you want to do that. Now, what fractionation? Again, from this Lancet paper, there are two schools of thought. Of course, you can do multifraction. I mean, we are not talking of less than 3 or 5 fractions. We are only talking of 3, 4, 5 fractions versus a single fraction. 81 patients had a single fraction, 25 gray single fraction to the primary, 81. And 109 had 42 in, well, average 3 to 5 fractions. Okay? We at TMH, we do 45 in 3 for some time, and we've been fine with it. You can see here clearly the BED, if you believe that the alpha beta of kidney is low, would be much higher with a single fraction. And expectedly, the outcome was also better in this hypothesis generating data. Single fraction may actually be better. So, food for thought. Some tumors are suitable for a single fraction. They are away. There's nothing there. It's almost like space. Suitable for single fraction or multifraction. And some tumors that are much larger, necrotic, hypoxic, are only suitable for multifractionated. And these are all patients that have been treated. They are big kidney masses. Dose constraints, look it up. Standard plan evaluations, these are just some pretty pictures, but you know what you need to do in terms of evaluating the plan. Can we increase the dose in the center? Certainly, you can make the center hotter, especially if there's bowel close by. Make the center hotter and peripheral cooler like you would do with standard SRS. We have some very exciting things coming up. There's a fast track 2 led by Shankar, is a prospective trial of single versus multifraction SRS. Combining with immunotherapy is a whole new story. I'm not covering much of it, but there is a role for cytoreductive SABR instead of cytoreductive nephrectomy coming up in combination with ICIs. Maybe for certain patients, certain selected patients. And I told you about RADSTER of SABR versus RFA. Sometimes you need to back off. Too much of Bravado is also not good. Just last week, I saw this patient in the JC, and patient had fit, 67, single kidney, had a 5-year back, had an RCC removed, all controlled. GFR is 60. I was so happy, salivating, got this, and saw that the bowel was so close. Then I said, let's do an MR. Maybe things will move a little and bowel will go away. It didn't move away. So we cannot really treat this. It would be unsafe to treat this, so back off. And I leave you with this final exciting possibility of using SBRT for neither primary nor MET. This is in between, like Trishanku. It's a tumor thrombus, a very common problem our urologists face, sometimes previously treated, sometimes difficult surgeries, sometimes difficult to go back in. Recanalization rates of more than 50% have been reported in small series. So something again to think about in your practices. So in summary, it's a real option in clinical practice. It's safe with 1% toxicity. It can be done on any standard linear accelerator, generic radiotherapy. It can be done for large and solitary kidneys. Don't biopsy. Outcomes will be slow and steady, and there will be some drop in the GFR. Well, this is on behalf of my team, and I must thank my research fellow Manish for helping me with this presentation. We have a lot of fun, and we also do some uro-oncology at TMH. Thank you.
Thank you very much for the lecture. And we have to close this session, and I would like to ask to prepare moderators for the next session, which will be devoted to irradiation of gynecological cancers.
I think we can have a few questions.
Okay. Okay.
Vedang, for evaluation purpose, can we use a PET if we don't want to do a biopsy?
No.
Why?
Before you want to hit the kidney with 40-45 gray, you want to know there's cancer there. PET can have some false negatives, false positives. I wouldn't. You mean PET? And if as response assessment, I'm so sorry. I thought for initial assessment. I don't know. I don't know. I don't know. There is no data. I don't know. It may be a good idea. I don't know. You mean FDG PET? FDG PET.
Sir, for the urologists, we have taken this idea
Thank
that
you.
it works. I mean, that we are, but the second part,
Yes, sir.
whether it responded or not, is the most
Yes.
complex thing.
Yes.
Because immediately after this saber, the patient and the bystander ask, am I cured?
Yes.
What answer can you give? See, we can't go by any of those criteria, resist
Yes.
criteria. We can't ask for a biopsy. Our pathologist will say it is still holding tumor. So how do we, you can't take an MRI and tell, well, you are cured, you are not cured, rather. So that is the most perplexing thing.
I agree, sir. That is a problem, and that is why it is important to talk to the patients that the mass is going to be there. Now, it's the same with prostate. You take the prostate out, you say, patient asks you, am I cured? What do you say? How can you say that, am I cured? And same thing with radiotherapy, the prostate is in there, and we monitor.
But nobody demonstrates the prostate becoming bigger and bigger. But
It
renal cell
becomes-
carcinoma, every sonologist will tell you your tumor is still there. Your tumor has increased.
But even the prostate is there.
PSA.
So,
Yes, see, that is the best part with the prostate. We have a marker, excellent marker. Here there is no marker, absolutely nothing.
So it's the same thing for any radiotherapy, because the tumor doesn't come out from the organ doesn't come out of the body. This challenge will always remain. It's the same thing with bladder. We have to monitor, and we have to tell the patients. I guess that's what we have to do. That a mass is going to remain there. We don't know if it is active or not. It may very well be dead cells. And but I take your point. It's a challenge. It's a challenge. But first, you must believe that it can be done.
Yeah, we have believed.
That's
So although, at least for, unlike, for example, lung SBRT, where you actually see reductions with time, you don't see this as much with RCCs. There isn't any data, though, to support doing a PET scan as a responsive treatment, and the trials that have been done didn't actually identify that as a biomarker to treatment. And so actually the ISRS has the official RCC guidelines. They got submitted about a week ago. But the recommendation is actually going to be a CT only with contrast every 6 months. Although even the contrast changes can actually fluctuate. You can actually get increased contrast in the 6-month period after SBRT because of inflammatory changes as well.
Yeah.
So to not use the contrast pattern, but the control rate is like 95%. I mean, some of the series are 98%. So the question is, why do you even need to do PETs and all these other things? Because the control rate is so high.
But that doesn't happen with a pseudo progression and all. Your contrast enhancement is still there. So the answer should be from the pathologist, from the immunohistochemical.
Yeah,
Something like a
there's no
Ki67
correlation.
or
Yeah,
something, which
there's no-
should tell us.
But
You
th-
take
there
a
has
needle
been-
biopsy, if they say,
But they've done the biopsy, like there have been studies that actually have been done. So at Case, they did a study where they did biopsy all those patients. It had zero correlation with actually eventual outcome. So the official ISRS guidelines are going to be to not do a biopsy in those patients, do not recommend doing it.
I think we'll
And the
have
control
two
rate
quick
is just so
questions
high.
and
One small comment.
ultimately we have to use a criteria. That is not forthcoming. That's the drawback.
yeah, I think it's
True, true. Maybe by the next time we have the ISRS
Vedant,
2024.
one comment and one question. My comment is that I think motion management still would be very critical. It cannot be underplayed. I agree that we have to look at whatever resources are available and accordingly choose. And my question to you is that, is there any GFR limit for a patient with solitary kidney and a RCC beyond which you would say, not possible, or the risk of being on dialysis would be too high?
30 is what many people consider.
Okay.
But we have treated under that. I do not have long-term outcome. But if there's no other option, what do you do?
Correct.
So I would, yeah, but mostly 25, 30 is.
Thank you, Vedant, for this topic. Actually, we as a surgeons, we are so excited about SBRT in renal cell carcinoma because we were initially thinking that it is not radiosensitive, and now we know that at higher doses it can be. But this is an exciting topic. At SOGO, our uro-oncology meeting, we are discussing a lot about that. Few areas where the surgeon's perspective, there are a lot of lacunae we want to fill. One is actually where we can fit this modality in our practice, because we have to refer majority of the patient. So where I usually refer is the patient who are actually cannot undergo a surgery, like liver disease, cardiac disease, not fit for anesthesia, and large masses where the patient may go for dialysis, but the patient don't want to have a dialysis as an option. We can give this option. These are the areas where we usually will prefer to have, because we are concerned to have a large masses, we cannot do a cryoablation or anything. Then small masses, anyway, for RFA also, we have to go for a anesthesia in majority. So these cases, if we can have, this option will be wonderful. So we are excited about this option. Where we don't like to have this patient, this modality is where we think that we can do a partial, because partial is the standard of care now. And if we feel that we can do a partial, we don't want to, because after a radiation, we don't know how the surgery will be later. The planes will be not good. And we prefer to have enucleation for like a lot of cases like solitary mass and multiple mass, and that enucleation plane may be lost if you are doing a SBRT. And those kind of patients where we can go for this one, if there is a failure, then we prefer to have a surgery rather than going for a radiation at the first go. Single kidney is not a contraindication and is very subjective. Different surgeon will take different criteria for operability, and we are developing new techniques like 3D reconstruction, all these things to improve our surgical capacity. So actually still we have to define now which patient has to clearly go for this patient, this treatment, and we can probably think of trials, and then we have to evolve the modality, and it's very exciting for us also. Thank you.
Vidang, are you doing this in a trial setting, or it's whatever?
No, we are not. In TMH you're saying, or generally? We are not doing it. We are going to be part of the IROC registry very soon. So all our patients are going to go into IROC from now.
Sir, last question. What about the role of functional MRI, sir? ADC mapping will be useful in responses.
For follow-up, you mean?
Yeah, follow-up.
I don't know. It could be, I don't think there's a lot of data looking at functional mapping using ADC, and it's not there. Because there are such a small cohort of patients, all of them have not had an MR. Maybe it's something worth doing it as part of a study.
Just one comment and one question, because the original question, what can we say to the patient? It hasn't been answered. Indeed, we have to say the same. So we have to prepare the patient beforehand to treatment, and the urologist and the radiation oncologist must communicate in the same manner. I think this is the most important one. And just one technical question. We're playing a lot with the combi, and okay, you have a case, you have a PRV, and okay, just before the treatment, you have a combi CT where there's displacement of the bowel loop, so it's pretty violated your PRV contour. What you will do?
I will have no hesitation in taking the patient off. Absolutely. I mean, it's just 3 fractions. I mean, you can always take the next day or the next day after or the next week. I mean, who knows? I would not compromise with safety of the bowel, for sure.
Both of them at the same time? Would you stage it? Would you give a single fraction or fractionate it?
You mean newly diagnosed kidney cancer? There are 2 of them.
Synchronous medically inoperable.
In the same
oligometastatic.
kidney, oligometastatic, we wouldn't. In this is all primary non-metastatic that I showed. If there are 2 kidney cancers,
No, I meant synchronous oligometastasis, which means there's a tumor in the kidney, which is the patient is medically inoperable.
yes,
And there is an oligomet that you're planning to treat with SABR.
okay.
Would you do the kidney first, wait, hope and pray for an abscopal effect? Or would you do a synchronous, would you treat both of them at the same time? Because in our setting, systemic therapy is hard to come by, it's expensive, people don't go for it.
Even TKIs?
Except for TKIs.
So I would certainly offer TKIs to these, anybody who's metastatic. The option of treating the primary or the MET will be secondary to that. I think TKIs will have to form the backbone of the treatment. If they are not tolerating, they are not able to treat, then I would certainly treat the MET. It will have to be individualized. I really cannot. We'll have to see the patient and see so many things. But I don't think there's one right way to do it. But you can treat both.
Right, I was just trying to get
Sure.
your answer.
You can treat both. Sequence and all can be
Because
individualized.
RCC is one of the areas where abscopal is known to happen. So would you wait?
It's known, but it's not been shown. That's the problem. It's really not been shown by anybody in any convincing way that it happens. There's one trial that's going to come out that has shown that there's no such abscopal effect.
Thank you.
Dear colleagues, we have to move really to next session, and if some other questions, we can continue in tea break.
We'll be moving on to our next session on irradiation of gynecological cancers. I invite the moderators, Dr. Kinjal Jani, Director and Head of the Department of Radiation Oncology, HCG Cancer Center, Ahmedabad, Gujarat, and Professor Suresh Kumar, Professor and Senior Consultant Oncologist, Government Medical College, Kottayam, Kerala. Please be seated on the dais. I request our moderators to introduce the speaker for this session. And just a small announcement, refreshments will be served simultaneously in the common hallway. Please do feel free.
Oh, this is not the original one.
So, for the talk on irradiation of gynecological cancers, we invite Professor Ferenc Lakosi. He is from Hungary, and he's going to talk about the irradiation of gynecological cancers.
So I would like to continue with the gynecological cancers, and I would like to focus on SABR as well, because these stereotactic curves. So here are my outlines. So first I would like to talk about a little bit the place of SABR as a boost for cervical cancer in the frame of the definitive treatment. Some words about recurrences, that of course the dominant indication would be the oligometastatic disease. I think beforehand I could say that we have a very limited number of prospective series. We have this fantastic SABCOMET trial, but only 2 patients represented the gynecological case, so we need for more prospective clinical trials. So let's start with the boost. I joined to the previous speaker, so I've also started my professional career with brachy, so I'm a big fan of brachytherapy, especially in the field of gynecology, so I'm not against the brachytherapy, because this is the standard of care. So we have to do this currently. However, we have some reports on that we have some patients who are not suitable for brachy, and we have to do something. I'm pretty sure that it has already been occurring in your practice. What are the reasons? Medically unfit patient, maybe volume problems, technical insufficiency. So sometimes it's very hard, and we have to know that the great success of the brachy is coming from the implantation geometry, and it is not always easy. If you have a very narrow vagina and a very wide tumor. Of course, experience is also very important, whether it is available or not. Right now in the Western countries, we have a survey which shows clearly that the new generation of radiation oncologists that don't want to learn and practice brachytherapy. This is the true. Patient could represent with fistula, and of course we have some patients, for example, Jehovah, who refuse, for example, a transfusion, and in this case you can also indicate external beam. But again, very limited number of publication and a number of patients. This is a very challenging situation. It's quite similar to the pancreatic cancer. Why? Because, you know, we have a very complex movement of the uterine cervical axis. Indeed, it's highly dependent, the movement patterns, on the surrounding tissues, you know, bladder filling, rectal filling, sigmoid. Even the pelvic floor muscle contractions could provoke a huge movement. So the uterus and the cervix could move totally independently. And you know, there is a very high variability of the positional and volumetric changes of the organs at risk. So interfractional variability is an issue. Okay, on the left side you can see one of my patients, and on the right side you can see hemaguided brachy. Brachy, from this point of view, is the best scenario. Why? Because, you know, you have an applicator inside, so the whole axis is fixed. With the Foley catheter you can control your bladder volume. With the tamponade and with the preparation protocol you can control the rectal volume. So this is a best case scenario indeed. Two organs couldn't be controlled, small bowels and the sigmoid bowels. However, if you're using external beam as a boost, it's quite challenging. I have just only contoured the sigmoid. It's 28 fractions, and this is the result based on COMBIM CT. So it's really a tricky one. Okay, we have 3 nice publications on that. The first one, as you can see, included 31 patients. The indication was, again, ineligibility for brachy. The dose was, I would say, yeah, it's acceptable 5 × 5 and 6 gray after chemoradiation. It was an inhomogeneous plan. It was a cybernite boost, no adaptation, and of course there was no availability of COMBIM CT. The predominant stage, figure stage, was 2B, and it's a very important message because I will show you the next 2 trial. The median follow-up time was quite long, it's 40 months. And as you can see, the local control rate was very high, so 92% after 3 and 5 years, and almost no serious side effects. So maybe this could be an option. But we are talking about small tumors. Let's move towards. This is a prospective trial indeed, a phase 2 trial. And the planned number of patients to be included was 21. But the trial was closed earlier due to high rate of significant toxicity. So indeed, as you can see, the prescribed dose was 4 × 7. So it's totally the same what we're using in Adria brachy. But the stage was totally different compared to the previous study. The 53% represented with stage 3 and 4 disease. The volume was pretty high. The median PTV size was 139 cubic centimeters. And as you can see, the local control rates, it's pretty inferior compared to the brachy. And as you can see, the 2-year at least grade 3 toxicity exceeded the 20%, and it was predominantly also a fistula. And this is also a recent trial. We're talking about 25 patients between 2012 and 2019. Again, the big proportion of the patients were represented with advanced stages. The dose was 5 × 5 gray. It was also on LINAC. The PTV volume was again quite pretty high. The free local control is not so bad. However, 20% of the patients experienced again grade 3 toxicity. So volume and dose as a consequence does matter if you use. But again, in these cases there was no adaptation. So maybe amylina could be also a solution for that kind of problem. But again, brachytherapy is the standard of care. But in these cases, maybe amylina, you know, hold a promise and, you know, could maybe provoke a good benefit. This is just 10 patients. As you can see, the dose is quite moderate. It's 21 gray in 4 fractions. It's quite careful. And the PTV volume is definitely smaller than 100 cubic centimeters, is less than 50 cubic centimeters. and the cumulative dose is not 95 gray. Instead of the 95, it's only 73. So no great toxicity. So from technical point of view, it was feasible, and we will see what the future brings. So this is just a very blazzy slide about the results, the free local control range between 78 and 92%. And again, volume does matter, and when we try to deliver the same doses as with brachy, we can provoke serious side effects if we have a very large volume. I will show you some cases from my practice. This is somehow a hybrid approach. The first case was a stage B proximal, it's a very young lady with proximal bilateral prometry spread. And of course, we have planned combined intracavitary and interstitial implant. It was a very hard intervention because there was no visible cervical os, and the cervix was really, closed and very rigid, and there was a systemic deviation of the needles. So the implant was not favorable. It was an unfavorable implant, and as a consequence, suboptimal brachytherapy plan. So as an alternative, just handle the best case scenario. We didn't remove the applicator. Indeed, instead of this, we remain in place indeed, and we made a scan on the same day, and we prescribed 3x6 gray. The treatment verification was COM beam, CT, and interfractional triggered imaging without a beam hold, and right now it's more than 4 years follow-up, complete remission, no evidence of disease, any toxicity. She is sexually active, so it was a good choice. This is the plan, and this is the COM beam CT verification, on the same day. As you can see, even the bladder filling is the same. It's almost the same cubic centimeters. There is a little variation of the sigmoid, but never mind. And of course, it was an applicator-guided CERB indeed, and as you can see, we insert a copper wire in one of our catheters, and of course we use outer beam hold. I'm trying to push the button, so it doesn't work. Maybe right now it works. So in every 3 sec, we have a kilovolt image about the position of the applicator, but indeed it doesn't move at all. So we were satisfied with treatment. We have also another case. It was a very large disease, so definitely a T3B with a left distal perimetrial spread, not only perimetrial, but infiltration of the pelvic wall visible. And after 45 gray chemoradiation, there was no remission at all. There was a slight progression. So it was a very huge volume, so there was no possibility to cover this even with hybrid approach. At the time, we do not have access to oblique needle implantation, only Perla, but even with Perla, it was, a mission impossible. So, and of course, there was a suspicious of a vesicovaginal fistula, so we prescribed 4x7 gray, exactly the same method as I have showed before. It's a very large tumor, as you can see. Again, COM beam CT verification, it's quite nice. Nothing's moving. It was really a safe treatment delivery, but the outcome was totally different. The patient progressed, unfortunately, after the treatment. So, and within 6 months developed distal metastasis as well. So it was not a good outcome. And it has been also published, I think it was in 2014. It also a hybrid approach, but in this case, the patient has been treated with brachy, and they were using the sabre just for, adding the coverage to the distal perimetrial spread. So it was not, exclusively a sabre. It was a really hybrid with high-tech brachy and high-tech external beam, and it worked indeed. But again, the message is, this is very rare cases, and indeed, it's somehow an improvisation, and the results are quite heterogeneous, I would say. Okay, what about vaginal wart recurrences? Again, the first choice would be brachytherapy. It's a very challenging case because after surgery we have, a lot of bowels, adder to the vaginal wall, and this is the same street with the bladder wall. So it's quite difficult to handle this with external beam. And of course, we're talking about mostly the endometrial cancer, so obese patient, so with a lot of comorbidities, complex situation. But if you do not have any access to advanced brachy, you can also try some external beam. And as you can see, the local control range between 50 and 73%. There are very nice solutions for that. I have seen one procedure in Aarhus. So in these cases, what they have done is it's a hybrid approach. So laparoscopic surgery and from the bottom transperineal implant. So the surgeon remove indeed during laparoscopic guide the small bowel lobes from the vaginal wall. So the brachytherapy specialist could insert needle, without any, issues, and they can also verify visibly, on the screen, the end of the catheters. So a very elegant technique, but of course you need resources to do this. Okay, oligometastatic disease. I think this is the most common indication, even in gynecological cancer as well. There is an Italian group, it's very active in this field, 2 retrospective series, one for ovarian and another one for cervical cancer with oligometastatic disease. Very good results, 2 local control, it's quite high, no grade 3 toxicity. The same group, it's a recently published trial, 83 patients, and they have shown that if we can achieve a complete response, the 2-year local control, progression-free survival, and 2-year overall survival could significantly increase without any serious toxicity. So, yeah, but we know that, okay, SABR works in oligometastatic disease. And of course, we have a multi-center Korean trial for cervical cancer oligometastatic disease with the same results, with very low rate of serious toxicity. We have a lot of trials currently running, combined with immunotherapy. So my conclusion would be that we have growing evidence to use SABR, especially for oligometastatic disease, but again, prospective trials are needed. Maybe stereotactic boost could be a viable alternative to brachytherapy if the patient is not eligible to such a procedure. And when we apply this, we have to be aware of the toxicity if we have a large volume, and if we would like we would like to apply the same dose fractionation as in brachy. Again, MR-Linacs, could be also. I didn't say the game changer, but it's a very nice indication for MR-Linac as well. And thank you very much for your attention.
Thank you, Professor Frank, for the excellent presentation. The topic is open for discussion. Professor Bilimanga.
MR-Linac, I agree that it gives a very good, the imaging wise. The other one, that we tried, of course, where brachytherapy patient was not agreeable, but we could have even convinced them, but we want to see whether how it works as a boost. We have an adaptive therapy machine. Use that adaptive therapy machine to give an 4.5 times 5. And these patients are relatively doing well, 5 patients, and they're okay right now. But we'll have to see whether this can we use this as a boost therapy and with external treatment. In adaptive therapy.
Yeah, adaptive.
Yeah.
Again, very few evidences.
Yes, that's right.
Only 10 patients, something like that. But I think in the near future, right now, no concurrence of modern image-guided cervical brachytherapy. But I'm pretty sure that there will be. This is a huge potential. Even, within the Embrace group, we have some patients based on the clinical findings that they escalate the dose. So maybe we don't have to treat each patient up to 95 gray. And I think it's a quite complex question. I think Embrace group is a fantastic group, really a lot of centers doing the same things, a lot of enormous homogeneous data. And in the field of external beam, yeah, it's very difficult to reach the same level. Maybe Amalina Consortium again, but right now they are focusing rather on pancreatic cancer and prostate cancer, so not for cervical one. But yeah, I think, yeah, I don't want to say that brachy is a dying technology, but because it's, but right now we have to be aware that technological revolution is coming. Yeah.
Professor Dev, you might.
Yeah, thank you for the talk. See now, for gynecological malignancies, brachytherapy is standard for last maybe 100 years, and we have extensive data on that. With SBRT, trying to replace brachytherapy or partially replace brachytherapy is something new. You don't think it should become a standard practice or recommendations or something? It should go through a grind of a clinical trial and trying to randomize. I understand that brachytherapy is not available in many centers, or interstitial brachytherapy is not there. So it is easy for us to replace. I do cyberknife here, but it is so tempting to do a brachytherapy-like treatment with our SBRT because we can give the same kind of dose distribution parameters. But we should understand that with brachytherapy, the dose come from inside out. But in our cyberknife or any kind of SBRT from outside in. So we'll not get that high dose, 200% we'll never get. So what is your comment on that?
I think the key answer would be really the clinical outcome. We know well that there is an intermediate dose inherently linked to the external beam treatment. But again, the message is not to replace brachy. The clear message is brachy is a standard of care, even with advanced disease. But we have to be aware that there will be some patients, who are not eligible. I think we have to judge these kind of cases on an individual basis. And as brachy society is very dominant again, and it depends because in the Western countries there is a clear decreasing rate of cervical cancer. So it's very difficult, organize such a prospective randomized study. We have a lot of studies, dosimetric comparison between advanced brachy and advanced external beam. And of course, from dosimetric point of view, the Oscar goes to the brachy. So yeah, this is true. This is the same street in prostate, but a little bit different. So I'm a big fan of brachy, and again, don't miss it. Brachytherapy is the standard of care, and this is just an alternative, if you struggle with such a patient. And that's all, that's it.
Yeah, one question I have. What dose constraints are you seeing for the bladder and the rectum when you are doing SBRT for the...
They are using the same constraints as in brachy, but as you have seen, in these trials, there was only one trial, the prospective trial, who tried to deliver the same dose 4 × 7 as in brachy, and it was a homogeneous prescription, not inhomogeneous. It's very important. The other trials decreased the dose a little bit, or even more. The trial included 10 patients with Amalina. It was only 74 gray BOD. When adding with the conventional chemoradiation, so it's difficult to compare. And we know that we need the large doses for advanced disease. And that's why the clinical outcome was not so, I would say, bright in this trial. And the huge volumes, it's very huge volumes. So I do not have a recommendation on that. These trials use a little bit less dose than in brachy, and again with homogeneous dose distribution. But again, adaptive planning bring all the promise, because you can't be more aware about what you're doing during the treatment and what is happening with your organs at risk. And again, returning back to Amalinac. Yeah, right. Amalinac. Yeah, again, Amalinac. It's too expensive. Yeah.
Regarding the para-aortic radiation, what is the dose you recommend for especially delayed relapses?
For?
Para-aortic.
Para-aortic lesions?
Nodal relapse.
So nodal relapse. It's there is a huge heterogeneity. it is, you know, you can do 3 times 9, you can do 33 gray or even 40 gray in 5 fractions, or 5 times 5. Some centers using 5 times 5. If you're talking about SBRT. But sometimes, you know, there are also many groups, because sometimes we are not talking about, you know, just, you know, individual nodes. Probably the whole region is affected. So a lot of centers use fractionated treatment with intraocular boost approach. And I think it's a quite smart approach, 5 times 5 with an SIB approach. I like it very much. Or even, you know, what we're using for cervix, you know, this is the same. 45 with integrated boost, 57.5 like in the Embrace, so it works as well. So yeah, we see clearly that we try to, you know, reduce the number of the fractions. But I think as in the pancreas, you know, 5 fraction treatment, it's, you know, a lot of, it's you can hit the same results with more prolonged treatment, you know, even with 15 fractions. With 15 fractions or 20 fractions, you can treat the region as well, not only just the primary. So yeah, briefly, this is my answer.
So, thank you very much, Professor Lakossi, for the wonderful presentation. And thank you for the discussion. And thank you, Dr. Deb and Shruti, having us here. Thank you very much.
Our next session will be on radiosurgery of prostate cancer. I would like to invite the chairs for the session, Professor Jinal Kumar, Department of Urology and Renal Transplantation, Amrita Hospital, Professor Makuni Dinesh, Professor and HOD, Department of Radiation Oncology, Yenapoya Medical College, Mangalore. The moderators for the session would be Professor Francis James, Professor and HOD, Department of Radiation Oncology, RCC Trivandrum. So we're having a refreshment served simultaneously. And Professor Ferenc Lekoski, Head of Radiotherapy Department, Samoji County Kaposi More Teaching Hospital, Hungary. We also have refreshments being served outside. I request the moderators to introduce the speaker for the session. First.
We shall go to the next session of the day. This is mainly urology session, and first speaker, no need for any introduction to our community, Vedang Murthy. I invite Francis sir to the stage as a moderator. So Dr. Vedang is discussing about radiosurgery in prostate. When the term surgery is used as a surgeon, I am a bit confused, but I know that he is so precise, and we can coin the name for the new techniques, the surgery itself. Radiosurgery for prostate cancer, technical and technological aspects from Vedang.
Thank you once again. Thank you, chairpersons and moderators.
1 second. I also invite Ferenc Lekoski from Hungary as the co-moderator for this session. Thank you, sir. Over to Vedang.
This is probably the first time I'm using radiosurgery in context of prostate cancer, but we have to adapt to the times. So there you go. This is radiosurgery or SBRT in prostate cancer. And I am actually standing in for my friend and colleague Sean Collins, who was not able to make it. So Devnarayan asked me to talk about technology and technical and techniques and technological aspects. And I'll disclaimer that I do not have experience with some of the stuff that is here. There are experts in the audience. And the other thing is the technical aspects of SBRT of prostate are really no different from technical aspects of non-SBRT of prostate. So what I will try to do instead is to make it more practical, focus on the Indian practice and Indian patients and see how we can adapt radiotherapy to SBRT to prostate in India. These are the stuff that you know. There are so many techniques around available to us. And this is again not something I'm going to talk about. It is really selecting what you have. It is really selecting the expertise that is available and the cost involved. And in my view, and I strongly believe this, I tell this even to patients, there is no one that is technique that is superior to other in terms of hardware, etc. So let us see what the Indian radiation oncologists think about SBRT. We did this survey about almost 5-6 years back now. I think many of you might also have participated in this. 100 radoncs who do treat prostate cancer, 15% said that they do SBRT, and 5 centers were doing SBRT in more than half of their patients. Clearly much has changed. Yesterday I was so happy, Vikas told me, sir, I have done 50 SBRTs in Pune of prostate. So clearly things have changed in the last, 40 maybe. Clearly things, people want to do it, and we hopefully I can, when people said that they were not doing it, the main reason was they were not technically equipped. And I think my job today would be to show that that is probably not the case and that is a misnomer. No talk on SBRT can be without talking about the low alpha beta. But what does it actually mean for the students? This is what it means. As we go from conventional to moderate to extreme hypofractionation in prostate, because the alpha beta is 1.5 as compared to the rectum that is 3, you get this therapeutic window, which means as you go to a higher dose per fraction, the effective dose to prostate increases. That is expected, but the effective dose to the rectum actually decreases. You can see that there. That is why the difference happens. These are some slides from my talk at Estro earlier this year. You will see evidence for prostate SBRT in the next couple of talks. So I'm not showing you that. A lot of people around the world are trying to prove that it is good and it is effective, and there's going to be level 1 evidence soon for from these trials. But can we really sit in any of our clinics, most of us, and say that we will use this data and recommend SBRT in prostate? Many of our patients are high risk, many of them are node positive, and can we do it? And that is where this ongoing trial will answer many of the questions. Many of you are aware of this, and I'll show you some results from this shortly. It's called PRIME. It's a multicentric trial being done in India. So what are the questions we want to answer? Is it safe and effective for the high risk and very high risk and node positive patients that we see in our practices? Can it be done with large prostates and when there are TURPs that we so often see in India? Should we treat the pelvis? And finally, does it need any special equipment? Can I do it in my practice, like I said in the kidney talk? Safety, the prospective data from a SHARP consortium called SHARP, this was led by Amar Kishan, we were part of this, nearly 350 patients, the grade 3 toxicity is about 2%. So it can be done. Some of them all these patients were high risk, but this is not prospective data. This is clubbed from many places. This is the latest update on the PRIME trial. This is a trial it's a multicentric study, non-inferiority randomized study comparing moderately fractionated radiotherapy and SBRT in high risk, very high risk and node positive prostate cancers. TMC Kolkata and Apollo Proton Center are collaborators. Multiple primary and multiple secondary endpoints. This is the design. These patients are randomized to 68 in 25 and 50 in 25 to the pelvis, or 36.25 in 5 and 25 in 5 to the pelvis. They are randomized. We have an option available for a moderate 62 in 20 also, and everybody gets ADT and everybody gets a boost to the nodes if they are positive. What did we find? And I presented that at ESTRO. Acute toxicity in the first 300 patients, you can see grade 3 toxicity. This is prospective randomized data from India. Grade 3 toxicity is 1%. GI toxicity is 1%. So clearly it's safe. The grade 2 toxicity is in line with what we have seen in the literature, ranging about 30% for urinary and 15% for bowel. Treating the pelvis, you all know this story from recently, whether we should treat the pelvis or not. This is the POP-RT trial. The question is, what about SBRT? Should we be treating the pelvis in SBRT? There is no obvious biological reason that you shouldn't. The best data comes from in comparison of 2 studies in Canada that have looked at one. They were both 30 patients. One had nodal irradiation, other did not, and the outcomes in the trial that had nodal irradiation were better. There's a trial called PACE nodes going on in the UK, but that is another matter. I think with SBRT also, we must treat the pelvis with 25 in 5. And I have showed you acute toxicity from a randomized trial. It's safe. Now, what is the published evidence that obviously if you treat the pelvis, it's not, something is going to happen. There will be some side effects. There's no denying that. So what is that? This work was led by one of my fellows, Ketki. We looked at about 220 patients. All of them got SBRT curatively. 116 had prostate only and 102 had pelvic SBRT. This is retrospective. This is our prospective database. After 28 months follow-up, the grade 3 toxicity was again 2%, which is fitting with what we have seen in the literature. Now, what about grade 2? What would you expect when you treat the pelvis? Intuitively, you would think there will be higher bowel toxicity. Yes, there was higher bowel toxicity, thankfully, which means our data is robust. Acute GI toxicity was double, 15% to 30%. This is acute bowel toxicity, some diarrhea, some needing some small amount of medication, not serious. But what we had found in POP-RT is treating the pelvis increases late urinary toxicity. And that is what happened here as well. There was no difference, significant difference in acute urinary, but late urinary toxicity actually increased by treating the pelvis. And this is the cost of treating the pelvis that you must understand. And you must do everything possible to reduce this urinary toxicity. I think treating the bladder that comes in the pelvic field is the cause of this acute toxicity. And keep that thought. I will show you something very interesting at the end. TERP is the other problem that we see. On POP-RT and in our own data, 25 to 30% of the patients who we see for radiotherapy have had a previous TERP. Now, this was done by Shwetab. He was a resident then. 100 patients, all of them had SBRT. 50 had a TERP and 50 did not have a TERP. They were matched for various factors, and we did find that Those who had a TERP had a slightly higher severe urinary toxicity. Again, expected. It's not all doom and gloom, but what is expected. This taught us a lot. And now if there's a TERP, we are extra careful in assessing the patient in terms of their urinary obstruction, any pre-existing. What happens is if you don't assess a stricture after a TERP, of course it will show up after radiotherapy, and that will be called as a radiotherapy toxicity. So avoid doing SBRT. It can be done. Avoid doing it. Give at least 6 months. Make sure there is no stricture. Do a little scopy and see. And if there are multiple TERPs, then avoid it. That would be my takeaway. So the other way to look at the TERP problem, this was presented by my colleague Priyamvada at Estro. We looked at 204 patients. This time that was all SBRTs. This is all TERPs. Some of them had moderate fractionation and some of them had SBRT, 116 and 88. You can see the grade 2 toxicity was the same when you change from moderate to extreme hypofractionation, that's the lase. So we were trying to look at the effect of fractionation on TERP. There were more grade 3 toxicities in moderate hypofractionation, and probably the reason for that is a longer follow-up. What we did is made a swimmer's plot. All these patients had grade 3 toxicity. So there were 13 of them and 2 of them in SBRT. You can see the duration of grade 3 toxicity, even if it happens, is about 6 months median. Some of them is just one little dot there, one event, and you call it toxicity and that calls. So it's important to understand that even these toxicities are limited in time. Okay, node positive disease. Can we do it? I think we can. Is it safe? I think it is. This was published, they were all node positive patients. This is what it looks like on a PSMA PET. You've all seen it. All patients got SBRT. This work was done by my second research fellow, Tejashri. They all got pelvic RT, and we gave a nodal boost based on the response on a PET, and very briefly, the outcomes were quite promising, and it was quite safe. I have to talk about techniques, so let me talk about simulation. This is no different from what you would do for any other prostate radiotherapy. Bladder, I think this is the second most important thing in prostate SBRT. I'll tell you what the first is next. Have a bladder protocol, make sure the bladder is reasonably full, not over full, not less. Empty rectum is important. It can wreak havoc with image guidance during treatment. We just treat comfortable supine arms folded on chest. Just use a knee rest. We do not use Orfits. We do not use VAC locks. We do not use gold markers, gold seeds, rectal balloon spacer, or IV contrast. So none of that is critical. It may help, it may aid, but if you don't have it, you may avoid it. IPSS is something that we must do before starting treatment. It looks very simple, and I wonder, the people who designed it, how do you ask, you have half the time, less than half the time, more than half the time, less than 1 in 5 times? I don't know, how do we ask this to patients? It's an art form, I think, to ask an accurate. And I can bet that if 3 people ask the same patient same time, they'll get 3 different answers. I really do not believe this. That's a personal issue. But we still do it. It will tell you whether there are obstructive symptoms or irritative symptoms. It's important you address these before you jump in with your SBRT. Contouring is no different, absolutely no different from your standard RT, and this is standard guidelines. You can look it up. CT has some problems in contouring for SBRT or otherwise. You can't see the apex properly, you can't see the prostate properly, you can't see sometimes the muscle versus prostate and seminal vesicles. So MRI is really a useful tool for your contouring. Again, CT-MR fusion for immobile, not mobile organ like brain, well, not shrunk, it is still mobile, but yeah, for prostate, it's not as easy as for brain. Again, I think it's an art form to correctly fuse CT and MR. And you can see the apex so beautifully, you can see here that it cannot be seen on a prostate. And this is where many times we go wrong. When you fuse it, make sure you see it on all slices. You can easily be correct on one slice and then you may be missing somewhere else. So make sure. Again, it takes practice to get this right. It is not easy at all. But I recommend this for when the posting changes, we start doing MRs for all patients. When the residents get better at contouring, then we stop doing it. So we adapt. Image guidance is mandatory, and I think this is the most important thing in pulling off good quality SBRT. Bladder and rectum seem to have a mind of their own, and how do we deal with this? What we have done, we have currently approximately 10 or maybe 12 SBRT patients on treatment at any given time in TMH. So a lot of things can go wrong in such a big department, and so many. So we've made an online module, a tool that all the residents go through. I can share it with all of you if required. I'll show you some pictures what we do. What is right, what is not right, you cannot keep training. I mean, we have trained the technologists, but this is a very useful tool. We have defined what an acceptable or an ideal match is in terms of what a bladder and a rectum looks like. We have also defined sometimes the rectum is distended. What should be done? Is it acceptable? You can see here the rectum is distended, but still there is no PTV miss, and there's very little rectum that has come in the PTV, and you can go ahead even with SBRT in this case. Now there are sometimes the recti, I think plural of rectum, are distended, and it's not acceptable. You would not go ahead with either moderate or SBRT. But sometimes there are scenarios wherein the rectum is distended just enough that there's more of it in the field, and for a patient undergoing SBRT, you wouldn't go ahead with this. But for those who are undergoing moderate fractionation, it's possible to go ahead, and you do not have to really take the patient off. So these are the subtleties that we have made in this module, and hopefully we'll publish it. Same thing with bladder. There's an ideal, there's an underfilled bladder. You can see here seminal vesicles just outside. You match it, it goes in, you treat. It's an underfilled bladder, but you treat. Overfilled bladder, you can see it's gone out, match it, it's come back in, treat. Both SBRT and moderate. Sometimes it is so underfilled that you wouldn't take the patient out and don't treat. Plan evaluation sheet, this has evolved over many years. This is something that is part of the PRIME trial also. Some of it came from POP-RT, some of it came from our own experience. This is available, is published. We have scripted it nicely into Eclipse, and on a click of a button, you get these things, and it's very convenient. Does dose matter? Yes and no. Many people have treated 36.25, 40, 45 gray, especially MSKCC, clearly a higher dose. And in this dose escalation study from MSKCC, it was seen that if you give 37 or 40 gray, the biopsy positivity rates at 40 gray fall, which is all fine. But the question is, so what? So what if the biopsy positivity rate falls? The toxicity goes up from 20, almost 30%, and we also do not go beyond 36.25 gray, especially for the high-risk patients, larger patients, SV being treated. Even on PRIME, we have kept it at 36.25 only. That is a safe dose. We talk about spacers. All of you know what these are. They are a polyethylene glycol hydrogel that is inserted between the prostate and the rectum, and that is what it looks like. Do we use it? No, we do not use it. The space OAR is not available in India, but what is available and may be considered if you want is hyaluronic acid. These are used by ophthalmologists and orthopedicians for fillers in the eyes and joints respectively. There's a small phase 2 trial that has looked at acute toxicity, and it goes down from 14% to 2% grade 2. If you want to add the cost, the invasiveness of this technique for that reduction, I think it's fine, but we do not normally use it. It's not, it's difficult in high-risk patients, it's difficult with extracapsular extension, it's very difficult in re-irradiation. So you must think carefully about whether you want to use it or not. Balloons are something from the past. We recently started using them just to get our systems in place for the proton therapy. It has its own challenges. I do not know whether they help or not. What they certainly do is change the shape of everything. And if you do a planning CT, you must also do a planning MR if you want to fuse with the balloon, and that adds complexity. What it does is it fixes the prostate. If you don't have tracking, this may be something you can consider. Contouring becomes difficult because you are not used to the anatomy. This is what the dose distribution looks like with the thing. The posterior wall goes away, anterior wall goes closer. So I don't know what the sum total is. Can we go less than 5 fractions? People are trying very hard to go less than 5 fractions. I would not try it at home. It needs a lot of expertise and a lot of involvement. So no. And I'll leave you with this. I told you I'll leave you with something interesting. This is challenging the dogma. The dogma is that prostate radiotherapy, SBRT, needs a full bladder. We don't know why that is. We think it is because the bowel will come and increase this, that, etc. There is data that empty bladder is also fine, and for our system, filling up so many patients with so many bladders and sometimes having accidents on the machine is very, very difficult as a system. So this is being led by my student Simran. We are doing a phase 2 study to see the toxicity with an empty bladder in prostate SBRT, and we are treating both prostate only and pelvic radiotherapy also. So the 100 patients we are going to simulate. We just started, first 2 patients done. We've done a little pilot before. The constraints can be achieved with an empty bladder in more than 90% of the patients. And the constraint sheet I showed you is a very tight one. It is much tighter than many of the trials. So they'll be planned, contoured with an empty bladder and treated with an empty bladder. And we have many endpoints that we are looking at. So this should hopefully change the way we look at things in prostate radiotherapy. And it's called MTRT, so it should be interesting. So it's not the technology, it is us who are using the technology and understanding what the issues are with it, and the devil is really in the detail. Thank you so much for your attention.
Thank you, Vedangji. We will take the discussion at the end because there will be otherwise repeated questions. I request our moderator, Professor Francis and Lekosi, to have a brief comment about this this last talk.
Okay, what may I do afterwards? I think it's better during the discussion, and I think we have to move forward. So I would like to ask for Dr. Maris Mazetskis to give his lecture. And right now the title of this presentation is Radiosurgery of Primary and Recurrent Prostate Cancer. So we're talking about evidences and clinical results. Thank you very much.
Dear colleagues, it's a real pleasure to participate in this great educational course, and even more to speak about this very important topic for our country, and as I will show, also probably for your country. One moment, should I? With this? Okay, I understand. Okay, brief introduction. I'm coming from Latvia. It's one of the Northern Europe countries. We have very small population, just slightly below 2 million, and the area is also not very large, and our clinic is located in a small town around 50 kilometers from Riga, and we are standalone CyberKnife clinic, no other linear accelerators, so unfortunately my experience is limited mostly to the CyberKnife system. But we treat patients from all Latvia, of course, and also closest neighboring countries, and also occasionally from further countries if patient request treatment. And here you can see the incidence of the prostate cancer in the world. We are in this region where it is we have high incidence, and if we can see below, the mortality also in our country is rather high. Actually, prostate cancer is a few years ago become #1 in incidence among all other cancers. Even lung cancer left in the second place. But what I found interesting that there are also some regions in India where it's not in first place according to incidence, but in second place. So it's also very important question, cancer location in some regions. And as we see, according to statistics over the last decades, it is growing incidence of prostate cancer in India. I would like to remind in the beginning, according to European guidelines, prostate cancer is divided into the 3 main risk groups: low, intermediate, and high risk, according to PSA level, Gleason score, and clinical stage. But more precise is NCCN classifications, which subdivides two separate subgroups in every this risk group: very low, low, intermediate, favorable, unfavorable, and high and very high risk prostate cancer. However, there are still challenges in these classifications. I think we really don't know what we treat, because if after radical prostatectomy you can investigate whole prostate, all lymph nodes, and quite clearly know what you treat, then from the biopsies, double sextant biopsy, we cannot be sure whether urologist got material from the dominant lesion which is visible on MRI. And not every patient can access targeted biopsy, fusion biopsy, or MRI controlled biopsy. So there will be always some imprecisions according to this, also in results. European guidelines are very conservative regarding SBRT. But currently the latest version recommends SBRT for organ-confined prostate cancer with some note, but still. However, if we look at the references, there are only 2 prospective controlled trials which are included in the references, despite the fact that there are large number of trials also run in USA with quite solid evidence, multicentric trials, which somehow European Association of Urologists do not put as references. And here you can see the NCCN, based on all these trials, recommend SBRT, prostate SBRT, in all risk groups from low to very high risk, if this is organ confined cancer, then you can apply it based on these guidelines, and also you can see those schedules which are recommended in these risk groups. Why to think about few fractions instead of conventional or moderately hypofractionated schedules? At first it's less workload for you, but even more for radiographers. Few fraction schedule is more easier, more reliable for regarding quality assurance for the patients. Less time and the resources also spent by the patients to reach the hospital for each fraction. Less missing working days for the patients who still working during who are in the age of working. And additional, as also previous speaker underlined, that prostate has low alpha beta, so we potentially may benefit with a few less fractions. So altogether, it should be cost effective if to calculate all these costs altogether. And what important points should be underlined in order to provide treatment in few fractions? Careful, repeatable patient preparation, good imaging, CT. I would say that for few fractions, MR would be mandatory, and precise co-registration of these images. I would say that it should be done according to fiducials. Tight CTV to PTV margins. If you do these first steps, then you shouldn't apply more than 5 millimeters around the target volume. Sophisticated dose distribution as far it is available, but you will see not all these trials used very sophisticated dose distributions, and of course ability to repeat it, these 5 or 7 fractions, what regimen you choose. Within the ESRS working group for prostate cancer, we collected data from 3 clinics and also protocols and other data. And as an example, I will show you some of these protocols, and you can pick up some information if you find it useful. However, we in this data cohort, we concentrated on intermediate, unfavorable, high and very high risk prostate cancer, because regarding low risk cancer there is quite many data published. This is not so scientifically unique. And here you can see the number of patients and the time period during which patients received the treatment, and also some age distribution. As you know, it's really necessary to minimize the interfractional and also intrafractional error during the treatment. If we deliver treatment in few fractions, then you, with some error, you will underdosage the peripheral zone, whereas in most cases is located cancer, or overdose some target organs at risk. And with linear accelerator, it's slightly might be complicated, especially interfractional motion management, because only special systems, special specification of Linux allows to take images during the treatment. But it's still possible. With CyberKnife system, it is more easy, because CyberKnife delivers those in a longer time, and we can set as many images as we want to do during the delivery, and then on the screen we can see how precise is treatment, and the system automatically detects markers, calculates what correction should be done, and automatically applies these corrections in order to deliver the dose precisely. And here you can see our Sigul the clinic protocol for the prostate cancer. All these points, as you see, we implement in daily practice in order to deliver precise treatment. We use gold anchor markers, but there are several other markers. Actually almost any markers is suitable in order to increase the precision of the treatment. We use usually prescription dose is 7 gray, but we strive to increase focally dose over the 40 gray, and in last period even over the 42 gray. So far we didn't see any increased toxicity, and the CTV to PTV margin is like standard 5 and 3 millimeters, but if all the preparation is we see that is perfect, then also 4 and 2 millimeters to rectal direction is acceptable. And here you can see a protocol from my colleague Ferenc Lakosi from Somogyi County, Kaposvár Teaching Hospital, where SBRT is done with a linear accelerator. And still, as you see, fiducial markers are used. The dose is the same prescribed, and as you can see, particularly the colleague's system has ability to make these images during the dose delivery, but actually it, of course, it improves the quality assurance, but I would say that it might be not mandatory. Forward. As I said, there are a number of gold markers in the market. We use such gold anchors which do not, where it's not necessary to delay CT and MRI. We do this immediately after marker implantation. This makes some comfort. And the other important point that they are better visible on MRI. They have 0.5% iron added, and then it's very well visible on T2 sequence of MRI. But ordinary gold fiducial markers are still usable and well visible, at least on T1 sequence. So here some evolution of dose distribution from three-dimensional conformal, so-called box, to very sophisticated VMAT plans, and CyberKnife even distribute the dose with non-coplanar beams. But as we can see in the further slides, also with 3D conformal dose distribution, it is possible to deliver treatment in at least 7 fractions. So these are dose constraints. The main thing, despite the dose distribution, what is available is to be within the dose limits which are recommended for prostate cancer. Here you can see the standard radiosurgery dose limits, but there are also other clinics use different dose limits, like Gliwice Clinic. They are like volume-based more than like in conventional radiotherapy, and still actually it is possible to use also the such dose limits. And here are Somogyi County Kaposvár Teaching Hospital dose constraints. You can later also ask if you are interested. And some plan examples. Here are patient with a lesion located anterior part, very close to urethra. Still we can deliver 40 grays to the lesion, and we limit the dose below 40 gray to urethra. We see that there is very few side effects from that organ. In contrary, Gliwice Clinic does not contour urethra, but limit the maximal dose inside the target. So if you limit below 42 gray, then also you will not have very severe side effects from urethra. And then the plan is much faster, and you can see the beams are less in order to cover the target volume. And here you can see also Linac-based plan, very sophisticated dose distribution, and also dose limited to urethra. So also with Linac, very good plans are achievable. And these are results of our cohort of intermediate and favorable risk group. Our total 5-year biochemical free survival was 89.3. This is actually in concordance to previously published data. However, in Sigulda clinic, there was slightly worse results, and looking for the causes why it's this, most of our patients refuse androgen deprivation therapy. So in this risk group, only 14% received androgen deprivation therapy. Obviously, androgen deprivation therapy can postpone biochemical relapse. And also for the high-risk group, patients really do not want to receive androgen deprivation therapy. In Gliwice, all patients received in our clinic, most of them refused androgen deprivation therapy. So the 5-year biochemical control for biochemical free survival was 66.9. Also slightly inferior comparing to previously published data where it was 74 in 5 years and 66 in 9 years. This is also probably due to utility of anti-androgens. But in general, if we put these scientific data on the plot with surgical biochemical control, we can see that SBRT for primary prostate cancer is as effective as radical prostatectomy. But if we speak about quality of life, this significantly better comparing to radical prostatectomy. And here is one of the crucial trials which is in references in urology guidelines, which concluded that biochemical control of conventional fractionation and moderate hypofractionation was the same as in ultra hypofractionation. In this trial, the treatment was delivered in 7 fractions, but they found that toxicity is higher than with conventional fractionation. And let's see what's the reasons. And actually, I think the not carefully following the protocol was the reason, because not all the patients had fiducial markers. MRI was recommended, but it was not mandatory to co-register according to fiducials. Actually, the dose distribution, it was allowed 3-dimensional conformal radiotherapy and IMRT as well. So it seems that also with these dose distribution opportunities, it is possible to deliver treatment in 7 fractions. But of course, all the other quality assurance parameters should be fulfilled, such as fiducials, MRI, and others. And then, of course, here 7 millimeters were applied around the CTV, but really my belief is that if you carefully follow the quality assurance, then it's not needed so large margin around. But the other prospective control trial, PACE-B, they followed very carefully to the initially set protocol, and they found that there is no difference in toxicity in comparing these dose schedules. In our cohort, we had quite favorable low toxicity rates with very few and quite few grade 2 toxicity, and actually no grade 3 toxicity. LINAC part of the cohort had slightly higher toxicity, but also no grade 3 and no extremely high. In the Sigulda clinic cohort, I also collected quality of life data with EPIC short form, and here we can see the genitourinary toxicity. It surprisingly somehow even improved over the time. And regarding gastrointestinal, it decreased in the first period of time, and they later returned to baseline. And sexual quality of life also was not altered severely, only very slight decrease. And for the conclusions for this first part, despite variation in treatment technologies, most SBRT reports, including focal dose escalation, show low rate of or no grade 3 toxicity, early toxicity, and low rate of late toxicity rates, similar to conventional fractionation. Biochemical free survival is similar to conventional fractionation, not worse. And what else? Androgen deprivation therapy might postpone relapse of high risk and very high risk group according to our data. But its influence on overall survival has to be clarified. It's not clear whether if you prescribe anti-androgens later to the patients, maybe they do not, the survival might be the same. And of course, further accumulation of data and multivariate analysis is needed to find the optimal parameters for the prostate SBRT and make recommendations, what is the best schedules and best treatment techniques. What should be the PSA after the SBRT? It should drop down, as you can see here. According to opposite to biochemical control, from 3 to 33% of patients will have relapse, biochemical relapse. And then we should find where the origin of relapse. But what should we keep in mind about the PSA bounds? From 9 to 20% will have PSA bounds, spontaneous increase of PSA, and later spontaneous decrease to further lower nadir. And this is explained by the immune response, which is created by the SBRT, and then cell breakdown increases due to this immune response, and therefore we see such an increase. And also it could be even more than 2 nanogram per milliliter, which is according to definition biochemical relapse. And also in our cohort was some cases of such patients. What is important that patients who has such PSA bounds, they are not at higher risk of biochemical relapse because of this immune response. According to statistics, they have even a lower risk of cancer relapse. Okay, but still, if it's not a biochemical PSA bounce, then it's recurrence. Then we should find the origin of this recurrence. It's either, of course, if it's after the surgery, this is might be prostate bed. If it's after radiotherapy or SBRT, it might be intraprostatic or somewhere in the body, either regional lymph nodes, out of regional lymph nodes, or elsewhere in the body, in the bones, or even in organs. Then we call this oligorecurrent disease. And in this, we should pay attention to oligometastatic disease, where, as you will see, we obviously can help to these patients in such conditions. Of course, in order to find this origin of relapse, PSMA PET-CT is the best option. And there are various isotopes, but I will not speak about because it's another topic. What is the risk of local relapse after SBRT? It's actually not very high. For low-risk cancer, this is even below 2%. For intermediate and high, it's somewhere below between 8 and 5% probability of such local relapse. And what can we do if we have such local relapse? There is growing evidence that we can repeat SBRT and treat such local relapse if 2-3 years after initial treatment has been gone. These are Glivita data, but there are more available data in the internet, published trials, and you can see that toxicity is not extremely high if we retreat. such patients. And we also have had such a case, clinical case. This is initial lesion, dominant lesion according to PSMA PET-CT. But unfortunately, after 2.5 years, patient had biochemical relapse. We made repeated PSMA PET-CT, and here we see the lesion in the prostate. And unfortunately, also some bone metastasis and lymph node metastasis. Patient refused whole pelvis radiotherapy, and actually it was only one lymph node. So we made repeated treatment, as you can see, only to the lesion and to the found metastasis. And patient agreed to receive the androgen deprivation therapy, and we continue follow-up. So regarding metastasis, it's a short time to include all the information, but from the STOMP trial we must understand that with the SBRT we can postpone initiation of androgen deprivation therapy. So for patients who want to postpone, we can apply SBRT to oligometastasis and defer androgen deprivation therapy. And from SABRE-COMET trial, which also included prostate cancer oligometastasis, we know that with concomitant systemic therapy and SBRT, we can increase survival, even double survival in this case. And how many metastases are oligos metastases? Still unclear question, but TRANSFORM trial answered that comparing 1 to 3 to 4, 5 lesions, there were no difference. So up to 5 lesions we could call oligometastases, but further it will be discovered probably. There is large ongoing trial, OligoCare in Europe, which will answer probably many of these questions. So PSMA PET-CT has crucial role to find origin of relapse of prostate cancer. Local relapse can be retreated if 2-3 years after initial treatment has gone, if patient has no late side effects. And radiosurgery for relapse is safe with low toxicity and provides high local control according to trials, up to 100% regarding oligometastasis. And it might stop, delay metastatic cascade dissemination. It might boost immune response, what is discovered in Oriole trial, and it might delay necessity to start androgen deprivation therapy. And in the very beginning, I would like to announce our ESRS prostate working group. Everyone who treats such patients has access to follow-up data, are very welcome to join to our activities. As I presented, the ESRS prostate register is already there are 453 records, but recently a colleague from Poland, Mateusz Bilski, created also oligometastatic prostate cancer register, and you are welcome also to join in any of these registers. We will have more data, and every who implement data or participate into the creation of publications are co-authors automatically, so every impact is of great value. So thank you very much, and looking forward for collaboration.
Thank you, Dr. Mezekis, for that wonderful talk, sharing your Latvian experience. For the final talk before the lunch break, I would like to invite Professor Encheva from Bulgaria. And Professor Encheva will be talking on complications and their avoidance in prostate cancer. Over to you, Professor Encheva.
Hello, everybody. Thank you for the opportunity to speak on complication and their avoidance post radiosurgery for prostate cancer. You all know that SBRT has a valid option for treating localized prostate cancer, Only a decade ago it was considered experimental treatment, but now we have proved the efficacy and safety in phase 3 trials, PSB and hyper-RTC, and other ongoing. What is the rationale? It was said the low alpha beta, increased patient convenience, increased patient access, more cost-effective than more moderate hyperfractionated and external beam radiotherapy, and the indication for SBRT, according to ASTRO-ASCO and AUA 2022, is only for low intermediate risk, but no NCCN recommended even in the high and very high risk in different schedules. So what about complications? We call them side effects, toxicity. We observe usually acute and late toxicity. Acute is during treatment and 3 months post-treatment, later. Post 3 months post-treatment. So we could observe GI toxicity, genitourinary toxicity, and sexual toxicity like erectile dysfunction. So there are a range of toxicity. So we have, unfortunately, different scoring system. This is a big problem. What we see in the trials, we can see used common terminology criteria adverse event version 3, 4, 5. We see R2G late and early scales and Sommerland. So we also have diverse patient outcome measures. And why it's important to see also the patient perspective, not the physician perspective, because it could provide us with more sensitive metric and better reflects the patient's experience during the treatment and his priorities. So we have also a different system, mostly reported in the SABRE trials, IPSS, EPIC, PCSC, PROMS. So scoring toxicity is very important, but unfortunately, as I said, the different the trials, they don't speak the same language. For example, you can see urinary frequency. If we see what is in third version of common toxicity criteria event, it's one definition. Then in version 4, it's different, even no grade 3 toxicity. R2G is frequency with urgency and nocturia hourly and more frequently. For version 3 with more than 3 times per hour. So it's really a diverse definition of toxicity during among the different scales. So that's one of the trials used both, like PSB trial, they define toxicity based on R2G and CTC version 4. So the first randomized trial that shown us the safety and efficacy of SBRT was high-priority prostate cancer trial. It was very, I won't focus on the trials. It was, of course, good results with non-inferiority. Failure-free survival was similar. But what was interesting, they used a 3D conformal radiotherapy in 80% of the patients. And the schedule they use is not all common now. It's 7 fractions to total dose of 40 to 7 gray. And the margin they used was 7 millimeters. And 90% of the patients have fiducials. Image auto, and this protocol, this study reported higher toxicity compared to the newer studies. So the authors, they don't find any difference in physician-reported GI and GO toxicity, except for increased urinary toxicity at 1 year post-SBRT. It was 6% versus 2%, and 5-year cumulative incidence of grade 2 GO toxicity and GI toxicity were all similar. So the grade 2 toxicity, GU and GI, were also very low across and similar across 2 arms. So unfortunately, erectile dysfunction worsened in both arms and constantly decreased to 35% at 5 years. And what about the PROMS, patient-reported outcomes? It was observed greater urinary and bowel symptoms with SBRT, with no difference in late symptoms, except for urinary toxicity, which was observed 1 year post-SBRT. What are the important symptoms and functions? We see there is a statistical difference between in PCS scale and ERTC quality of life. So the patient perspective showed that there is, of course, more complication, more severe side effects. So the PACE-B trial was performed in low intermediate prostate cancer, and the schedule was different. Mostly used schedule now. It's 5 fractions, 725 gray. And here what was interesting, they use fiducial in 73% of the patient. They have motion management in 42% of the patient. This was not in the previous trial. So since they observed no difference in acute toxicity with SBRT, including patient-reported outcomes, but the occurrence, the timing of GI and GU toxicity differ. They observe earlier this toxicity during treatment, which resolve faster with SBRT. And they compare here conventional with moderate hypofractionated radiotherapy to SBRT. And as we see, based on R2G toxicity, we have comparable acute and toxicity between SBRT and conventional. And the worst R2G toxicity plus grade 2 and plus GI and GU occur typically for 6 weeks after the treatment completed. And but it was similar in both arms, not significant difference. And again, by 12 weeks, there was no difference in toxicity in both arms. But common terminology criteria adverse event toxicity scale show again significantly worse, shows significantly worse CTC GI toxicity, which was 15% compared to 8%. And this difference disappeared at 12 weeks, but in common, no difference of acute grade 2 GU toxicity. And what about the late results? They were published here in Lancet, and it was presented ESTRO 2021. And we see that the late GU toxicity grade 2 and plus is 3.4%, and GI 1.6%, and is comparable to the moderate hypofractionated regimens. And they observed that when they use a common terminology criteria adverse event, 3 to 4 times fold increase in toxicity, in GU toxicity. So R2G scale reported only 2.9 toxicity, and CTCA 11.6. So they didn't observe this difference in gastrointestinal toxicity. So it's very important to know which scale to use. And about late toxicity, there was a high likelihood of GU toxicity between 9 and 18 months. Then it was just transition. It disappeared. So what is the reason we observe this toxicity? There are many unanswered questions. Of course, technology probably is important because in a PACE-B trial, they observed GI toxicity higher with LINAC compared to CyberKnife, and also GU toxicity was higher. They use probably different margin matters, or a patient profile that got CyberKnife, or LINAC that not used fiducial always, and of course the tracking and urethral dose. So this still it's not an exact answer. So we have another trials that explore SBRT compared to moderate hypofractionated radiotherapy. This is the HIT trial that reported no statistical difference in acute toxicity at a median follow-up of 11 months. Another trial was the Indian trial that was Dr. Murthy reported, and he reported these results at ESTRO. I was there. So this Indian trial already was said compare moderate hypofractionated with SBRT, but in high-risk patient, whether, of course, also the lymph node could be irradiated, and it's very low incidence of grade 3 toxicity, 1%, which is very supportive for our daily practice, if you'd like to do it. And of course, the GI toxicity, diarrhea, and similar grade GU and GI toxicity. GU toxicity was 60%, and GI toxicity around 32%. and both arms have a worsening of GU quality of life scores. Very interesting paper was published 2019 in JAMA. It pulls analysis of prospective trials from 10 institutions with 2,100 patients, 7 studies with CyberKnife, 5 with Linux, and they have very good results, but what you see again, they use different scales, R2G, CTC different version, and they reported the lowest rate of late toxicity. Severe late GU toxicity, it's only 2.4%, and severe GI toxicity is 0.4%. It was really impressive, and they compare with the other modalities of radiotherapy rates of grade 3 toxicity, and they show very low profile of toxicity, which is great for low intermediate risk prostate cancer. You see at the bottom is the trial SHARP consortium data. And another review has compared SBRT ultra hypofractionated with moderate hypofractionated have found similar grade 2 plus toxicity GI and GU, 12% GI across all modalities and 20% across all modalities for GU at 5 years, which is also very good result. And here I just summarize all the results here. The best results reported in so far for a SABRE consortium. And what about MRI guided radiotherapy, which is probably the future for Linux-based SBRT. What is the advantage? Of course, we have enhanced prostate visualization, enhancing visualization through uretra. We can track the prostate real time. We can reduce our safety margin. We can adapt online. So do we have the data so far? Of course, there is a contra statement that the longer duration of treatment session can potentially affect our interfraction motions. So we have some data prospective trials which show very low profile of toxicity, and one prospective phase 2 trial have shown very low GU toxicity 2 plus 90% and 3% GI toxicity. So this was not compared to conventional CBCT guidance. So we have already phase 3 trial comparing MRI guidance to CBCT guidance. This is Mirage trial. It has 3 months follow-up to show the early toxicities reported so far. And the study included 156 patients, and the margin, you see how small margin they use. For MRI guidance, they use just 2 millimeters margin, and for CT arm, 4 millimeters. And the dose they give is 40 Gray in 5 fraction with the boosting dominant intraprostatic lesion, depending on the physicians, and the lymph nodes could also be boosted if there was 25 and 5 grays. And the primary endpoint here was the acute toxicity grade, genitourinary grade 2 plus toxicity based on CTC A4 version. And you see here they included all kind of patients with different stages of risk patients, prostate cancer, and they use rectal spacer in 50% of the patients in both arms. They have similar GTV boost, so the patients were well distributed. And what they observed is that acute grade 2 plus GU toxicity effects significantly were lower with MRI guidance, 24.4% compared to 43.4%. And for acute GU toxicity, MRI guidance observed 0% plus to high grade toxicity compared to 10% with CBCT guidance. So comparing to PACE trial, you see the rate of acute GI toxicity, here is really huge difference in acute GI, 0 compared to 15%. And they also reported better scores for IPSS and EPIC for the patient. So the patient outcomes measures was also better with MRI guidance compared to CBCT guidance. And it shows that technology improvement matters. Of course, not only the technology allows us to lower the margin, so the higher toxicity rate we observe in the first high priority trial, as I told you it was 80% of the patients treated conformal treatment, 7 millimeters margin. Of course, they have fiducial but not motion monitoring. So we see that in the SABR consortium with the lowest rate, they have fiducial in 100% of the patient. Intrafraction prostate motion guidance was 88%, and very small margins again to 5 millimeters, which really matters to limit our endotoxicity. So can we avoid this toxicity? Is it possible? Yeah, if we properly select our patient, if we use precise target volume delineation, good constraint, proper constraints, advanced radiation techniques, use of image guidance, adaptive planning, prostate motion management, proper dose prescription, and of course the overall treatment times also could matter. I won't focus on patient selection. Of course, could be the volume, the stage, although it's not shown to have toxicity so far, the transurethral rejection. So one study wanted to find predictors of this genitourinary bowel quality of life, toxicity post difference post SBRT, and they stated that prior transurethral resection of prostate in the CTV size of the was associated of 2-year urinary incontinence, but not the bladder in urethral doses. And they showed that the rectal maximum dose significantly is associated 1 month and 2-year bowel quality of life. And the patients with rectal maximal dose more than 37.4 gray are more likely to have bowel symptoms at 2 years. And what about dose escalation? We expect dose escalation to higher the toxicity, and this study compared 35 gray in 5 fraction to 40 gray in 5 fractions with 5 millimeter between margin, and they didn't find any difference in grade 3 toxicity. The data in the literature are contradictory. We have different diverse results. When we another study comparing 3 schedules, they found the predictor of late grade 2 geotoxicity dose of 40 gray and higher IPSS score at baseline. Another predictive study have shown that there was a significant association of grade 3 geotoxicity with increasing the BD. What about the number of fractions? There are studies with 3 fractions, with 1 fractions, SBRT, and the study of 3 fractions showed that this is acceptable profile of toxicity. Although they reported mild acute geotoxicity grade 2 11% and acute grade 3 toxicity 1.7%, but there was clinically relevant worsening of IPSS score, patient reported outcome scores. So another Patriots phase 2 trial have shown that prostate SBRT delivered once weekly improved acute urinary quality of life of the patient compared to every other day. Also, for overall treatment time, it's shown no difference. This is a different contradictory result that once a week or every other day urethra-sparing prostate SBRT shows similar toxicity profile. So looking in the literature for predictors for lactose tolerance, it was shown that grade 3 late 3 toxicity was strongly correlated of the volume of rectal wall receiving more than 50 gray in more than 3 cubic centimeter, and also the circumference of the wall could matter. Another very good study of Wang published in 2021 showed that suggested those constraints that we should look at are the bladder volume receiving prescription dose more than to be less than 510 cc, urethral Dmax to be less 3842 gray, and rectum dose to be less than 3538 gray. So we don't have, unfortunately, so far firm guidance what kind of tolerance dose to use in our daily practice. So this should be based on further research. This is the study they use in this paper. So also high-risk study with pelvic lymph node irradiation have so similar profile of toxicity. I'm not going to focus here. Hypoflame phase 2 study, for example, gave 50 gray for a prostatic dominant intraprostatic lesion, and they show that GU toxicity grade 2 was 34%, GI toxicity was less than 5%, and they didn't observe no grade 3 toxicity, which is very interesting study. So it's acceptable to give this boost for the dominant intraprostatic lesion. And what about the patient experience? It's very interesting study showing that the patient regret mostly regret less after SBRT compared to IMRT and high HDR brachytherapy. So how can we avoid again with imaging or rectal spacers the toxicity? Still, although the low rate of GI toxicity, we observe some, and of course our patient would like to have any toxicity. What are the means we can use? We can use a rectal spacer as was shown, a rectal balloon, and rectal spacer was already mentioned. Could be hydrogel, could be also inflatable, which is very interesting tool to reposition, because once you position the other gel, hydrogel, or hyaluronic acid, you cannot reposition, but with the balloon, it's, I don't know how many use. I don't have personal experience with this, but there are studies showing that the spacer could reduce the toxicity. When we have no spacers and give high dose, 50 gray 5 fraction, we observe 3 gray toxicity plus in 6% of the patient. But when a rectal spacer is used, you see just GI toxicity gray plus 3 is just 1%, is statistically better than without. And of course, there are different studies. This is one study that showed between 11 studies using spacer ORI can reduce the dose to the rectum by 29% to 56, and no acute grade 3 plus GI complication reported. And of course, placement can reduce rectum in 50%, 70%, 90% of maximum prescribed dose. And phase 2 trial have shown reduction of incidence on rectal ulcer using spacer OR. Also, a spacer OR now is ongoing trial, SABRE, which I hope will show the significant result. Again, a target motion is important. It's very important, interesting study showing immobilization with endorectal balloon using intrauretral Foley catheter, and they give very high dose, 5 times 9 grade, and the late grade GU and GI toxicity were only 2.9 and 2.4, very low toxicity rate, delivering this high dose. And about motion management, the most important is real-time tracking. It's very important when we give less fraction, when we use it in high-grade prostate cancer patient, not to miss our target. And when we like to have boosting to the dominant intraprostatic lesion, and different systems have been used in the nowadays. Electromagnetic guided MRI is one of the system, Calypso. The other is the ultrasound, like Clarity or Ray Pilot. But these are electromagnetic transponders for Calypso and Ray Pilot. The problem with Calypso that they're implanted in the prostate, and the Ray Pilot is good because it's in the catheter, intrauretral catheter. It's more convenient for the patient. And the advantage of Clarity that it's ultrasound based, it's not invasive. So these are different systems for Ray Pilot. Current one series published 2021 have shown 0 acute and late gastrointestinal toxicity, 0 getting to urinary toxicity. I haven't seen study like this with 0 toxicity. So it's a very good option. And also Calypso system, this looks like ultrasound. It's really operator dependent, I think. It's more difficult because you need to place ultrasound and to without fiducial markers. This is the advantage, and it's shown a good results. And what about the future? We could rely on predictive biomarkers like genetic testings. 2021 was published by Amar Kishan in Radiotherapy Oncology. It's extremely interesting study showing that we can use SNPs to predict the toxicity either for conventional or for SBRT treatment. So they designed predictive models like using germline SNPs, and they could predict late genotoxicity grade 2, and each model was unique for each treatment. For a conventional fractionated, they use 22 more SNPs, and for a the other SBRT 32. So when they try to apply one model to another, it didn't work. So it works only for the definitive treatment, which I think it's really a good for the future. So SBRT in conclusion is a valid treatment modality. Outcomes are comparable with XBRT, and we have comparable early late toxicity. So we need to carefully select our patient. We have to have the modern technology best to do best for our patient, IGRT, fiducial, motion management, spacer, MRI, LINAC, and we of course hopefully will rely in the future of predictive biomarkers. So thank you for your attention.
Thank you very much. Shall we have questions to all three speakers? Please.
Thank you for the speakers. It was a very interesting presentation. I have made some notes just to memorize. I think it's a 5-grade fraction is currently, I would say, the standard of care. I know I'm conservative, but we do not have hard evidences, especially for high risk and very high risk cases, because we have the PACE, and the PACE trial is currently running for risk and high risk patients, so no hard evidences. The second one is PACE-B trial. We have seen that there was a 3 times higher grade 2 toxicity, but it was not significant. But we know well that with time, the incidence of genitourinary incidence increasing. So it's still an open question. This year, there was a presentation for PACE-A. PACE-A is the first trial which has been fulfilled between laparoscopic assisted prostatectomy and SABR. And SABR outperformed indeed surgery, except for gastrointestinal toxicity, is a very important message. But you have to also know that low-risk cancers, very low-risk cancers right now, according to the updated European urology guideline, no other treatment option, just active surveillance. So the others active treatment has been removed. Concerning high-risk and very high-risk lymph node treatment, this is just a comment. I had the same comment on our society congress this year. This is the same problem. So we have to also monitorize systemic treatment. I'm also involved in systemic treatment of prostate cancer. And it's a never-ending debate, whether should we include elective lymph node regions or not. And we have to say that we can't see any overall survival improvement. But the truth is that according to the new STAMPEDE trial, by adding new generation androgen deprivation, there is a clear and significant overall survival by adding 2 years plus ADT. So probably the future will be that way. So I give you an example. For oligometastatic disease, for low volume disease, STAMPEDE trial, ADT plus prostate-only radiation therapy improved overall survival for low volume metastatic de novo disease. However, this year there was a refreshment of this trial by adding new generation anti-androgens, and this benefit completely eliminated. So there was no overall survival benefit if you add such kind of treatments. And the third comment is to the lymph node irradiation, that with PET-CT, it's recommended for high risk and very high risk disease. And the second most frequent place of lymph node metastatic disease is the mesorectal lymph nodes, which are not included within our elective volumes. So a lot of questions still open, but probably, more intensified systemic treatment will answer to these questions. It's really, we will focus on probably the prostate and the residual disease. This is just a comment. Another thing concerning the margin, I totally agree with this, because if you are working with
moderate fractionation, homogeneous dose distribution, maybe margin and intra-fractional organ motion is not very important. But as you decrease with the dose and as you give targeted inhomogeneity, like for example intrafocal boost, yes, to shrinkage the margin is important. The Mirage trial was a comparison between apple and pear, unfortunately. But the conclusion is that volume does matter. But again, there was only a significant difference in acute toxicity and nothing about late toxicity. So, yeah, and I think
Can I make a comment?
And nothing more. Yeah, just last comment about the biomarkers, because there is also a possibility with blood sample. It is called RELA, radiation-induced lymphocyte apoptosis. It has been already validated by independent institute for prostate and for breast cancer. It is done by the French group. We have also done, not in my institution, the National Institute of Oncology, and there are right now some cutoff to predict whether a serious late side effects occur or not. So it's already validated. And right now we also doing an evolution for cervical cancer, just by adding this.
Thank you for your comments. I would like to comment on your comment on Stampede, abiraterone, that it has shown, I mean, you almost made it that is the panacea for everything, and radiotherapy, especially pelvic radiotherapy, may not be the way to go. And it's a debate, I understand, but I'd like to, and we wrote a letter in European Urology, I'd like to make a few points. Stampede had 40% node positive patients. And I spoke to Gert, this is not ATAD. This is not published. And we've written this in the letter. Half of the patients on Stampede who had node positive did not get even pelvic RT. That's inadequate radiotherapy by any standards. Second, 70% of patients, or 65-70% of patients who were node negative also did not get pelvic RT. We do know that certainly for node positive patients that pelvic RT improves outcomes significantly. The cost of abiraterone, the side effects of abiraterone are not trivial, especially given for 2 years with a steroid. It cannot be, in fact, luckily for us, the cost is not much. That is another problem. I would not take it lightly. So based on this, I think for node positive patients, it is okay to add abiraterone, but for node negative high risk or very high risk, that should not be considered as a standard of care, even based on Stampede.
Good comment.
Thank you.
Yeah. Dr. Vedant, there's few things I need to understand. See, now what I understand from your talk, that bladder filling, bladder empty, there's a small, because we are matching the bone and then treating the prostate. If you put the fiducials, and then actually we don't have to worry about the bladder filling, rectal filling, or anything. So, and then we can give lesser margin also, because we are more sure what we are treating. So,
Sure.
So what the perception is that LINAC based, fiducial based, whatever, fiducial based LINAC also is possible. But everything, but if you put a fiducial, internal fiducials, then it is we are more sure about what we are treating. What is your comment on that?
You may be more sure, but there is no evidence that the side effects of CyberKnife or fiducial based treatment are any less or more than anything else. So in theory, yes, you are right, putting in a fiducial. How do you know you are more sure?
See, same thing for VMAT or IGRT. So
Yes.
IGRT has not shown that we can reduce the PTV margin, but we are sure what we are treating. See, when we are doing a CT-based treatment compared to the EPID-based, basically we are seeing it well and treating. It does not improve the outcome. Neither it reduces the PTV margin, but we are sure what we are treating. And same thing is applicable for fiducial-based also, because we are having internal fiducials, which is going to move along with the prostate. And our target is based on the fiducial, not the bony markers.
Sure, it is very interesting and exciting to have that technology, but everybody doesn't have it.
for LINAC based also it is possible. It is not only you need a cyber knife.
For tracking, isn't it?
tracking.
That is also how many people have intratumoral intrafraction tracking on a standard LINAC. It is there, but do you need it? Do you really need it is the question. If you get, I showed some methods of getting your imaging absolutely right. The treatment lasts for 1.5 minutes. You can do a CBCT in between, but I'm sure there will be little advances, but it's, in my view, it's not clinically significant.
So one more small thing is that when you there's a node positive disease, do you need to, conventional is today hypofractionated radiation, which is much more,
Yes,
instead
yes.
of making it a short 5 fractions where the GI toxicity is a little on the higher side.
Yes. So surely, I'm not saying that you should treat with SBRT. I just said that it is possible. I would not call it the standard, absolutely. I would still call moderate hypofractionation or conventional moderate hypofractionation is certainly standard. And what I would include is go till the common iliacs and give a boost to the nodes. Do not avoid that. So, to a gross disease, whatever, 60 gray if you're doing in 20 fractions, I would do that. I'm not saying that SBRT should be done. I said it can be done.
If I could add a comment regarding fiducials and cyberknife, in the same trial which was many times mentioned, PACE B, there was sub-analysis of different treatment platforms, and cyberknife is not possible without fiducials, and cyberknife part of the cohort had lower side effects.
Yes.
But the fiducials you can use with portal imaging system without cone BCT. You can use fiducials and precisely track what you treat. So you cannot replace fiducials in prostate.
Sure.
If you want to precise treatments, and it's mandatory.
Vedant, can I ask a quick question?
Yeah, you showed that with SBRT, the incidence of a distant metastasis has increased to 16%. The local control improved, but the distant mets were higher, 16% as compared with the hypofractionated. So how was this explained? Like we are gaining at one point, but we are, the distant mets has increased. In one of the graphs you showed that.
Actually, you mean that distant metastasis increase? No, regarding high-risk cancer?
Yeah.
High-risk prostate cancer.
Yeah.
Actually, the local control, it's, as you saw, it's around, local failure could be around 8%. But the most, of course, the highest risk is for regional lymph nodes or distant metastasis. But I don't think that we somehow increased with the treatment the risk.
But it was there in one of the slides, so I was wondering, did we really gain with SBRT?
Maybe there's some misunderstanding.
The distant mets with...
Maybe there's a misunderstanding. He's not saying that it does.
Yes.
Maybe something else.
No, it was there distinctly that with the hypofractionated, the distant mets were something around 6% and it increased to about 16%.
There's no such
It's
data.
not there, then that's good. Then.
Maybe I somehow incorrectly.
Vedant, are there patients who you predict a more urinary toxicity so that avoid SBRT for localized prostate?
Yes.
So TERP and IPSS score.
Multiple TERPs, bad IPSS, bad functioning bladder. Sometimes the invading, the median lobe going into the bladder and a TERP has not been done. So the constraints will be difficult to achieve. We do not do SBRT in that. Vinita asked me about size. There is, Sean Collins only has published 80 cc prostates, 100 cc prostates, only data on that, and it is safe as long as you can achieve the constraint. So size is not an issue. Going in is a thing. What else? Sorry? So that is a problem with any radiotherapy. It's not only SBRT. If it is residual, and now that we are doing this MTRT protocol, we are simulating on empty bladder, we are seeing how many of the bladders actually are full on an empty bladder. And it's absolutely amazing to see that. But I don't think residual. So if there is residual, I would use an alpha blocker, improve it, and then treat.
I have one basic question for CyberKnife users. How do you do prostate SBRT on CyberKnife? Because you're doing imaging, is X-ray based imaging. So how do you check for the bladder, rectal volumes, etc.? I mean, that is why probably Devnarayan is asking about fiducials in prostate.
Yes, that's a very good question, and that is, I could say, minus of CyberKnife comparing to MR Linux. CyberKnife, we cannot see bladder volume. We repeat this protocol as we did before CT. We repeat with every treatment fraction, but we cannot be 100% sure that the bladder volume is absolutely the same. It might be slightly changed. If we want to be 100% sure, then we should ask patient after the treatment to empty bladder and look at the volume, or make ultrasound investigation, to check. But you know, with ultrasound you can check some 2-3 measures and calculate this. Actually, even without such additional efforts, it's clear that it works.
So I don't do too much of prostate, but still a basic understanding in my mind that bladder volume has to be reproduced and it should be filled. So the general discussion which I heard from the talks and your statement and this CyberKnife statement tends to lean towards the fact that bladder filling is not important, just focus on the prostate, which again seems counterintuitive given the fact that the expansion would also increase the denominator of the bladder and would reduce the fraction of the bladder that is getting exposed to a higher dose. So how do you explain this dichotomy that I'm hearing?
I can't.
You are a proponent of the empty bladder study.
So
you started this, Vedant, you started this.
So just adding to that, is it correct that on CyberKnife, what you plan is not what you treat? How regarding the bladder filling, because it takes time also, isn't it?
But one more addition to the previous answer. Actually, we see if bladder is not the same filling, because if it is the same, all the angles are the same. Once the bladder fills, we see on the screen that prostate turns under the angle. It depends on the patient to which direction, but we really see. And if the feeling is the same, then it stays the same.
Sure. And can you treat with a 3 millimeter margin on CyberKnife?
Yeah.
Is that a standard thing?
It's a standard treatment with a 3 millimeter margin. I think most places treat with a 5 millimeter, but if you have end-to-end system verification, you can treat with 3 millimeter.
So on Mirage, Amar Krishan says that he could do 3 millimeter because of MR Linac.
Correct.
The question is, can you do 3 millimeter because of CyberKnife?
So people are asking that now,
Yes.
but the standard for CT-based treatments has been 5 millimeters, and all the trials were 5 millimeters. So for all the patients treated on Linac-based systems, it's always been 5 millimeters. On the MR Linac systems, it's always been 3 millimeters. So that's why that's a trial of
So my
margins
question
and the
was,
technology
are
facilitating
people
margins.
comfortable on CyberKnife? Is it standard to use 3 or still it's 5?
So almost all facilities are using 5 millimeters.
Okay.
Since the Mirage trial, there's some of the CyberKnife centers that have started using 3 millimeters. I think going back to the question
if I can add some regarding MR Linux, it's very big minus of MR Linux. They do not have 6D coach. They technically cannot have. The aperture is so small that they cannot correct. They can see it doesn't fit really, but it's within 3 millimeters. But they do not.
But yes,
they can replan. But usually, if there are minor deviations, of course they will not replan. But CyberKnife system immediately corrects the angle of the beam, which is unique. Therefore.
And how comfortable are you treating the pelvis on CyberKnife? Prophylactically?
No,
there's no issue.
We do not treat.
That has
No,
not
that's
been
a
done
problem.
because they don't have the visualization.
No,
so
that
I'll get back
is
to
a
the very
problem.
question about the. Yeah.
I was coming there.
Yeah.
Now that I will not, I mean, I can agree with fiducial and this and that. I will not agree that just because you cannot treat the pelvis, you would say it's not important. I think that cannot be the...
So I go back to this question about the CyberKnife and visualization, and I think once you start to see more with regards to the anatomy, you'll see practice patterns change over time. So for example, at our facility, again, CyberKnife has actually the longest history of treating patients for prostate SBRT,
Sure.
right? If you look at the published literature to date,
no problem.
The history started
Low
there.
risk,
So that's why
intermediate
we
risk,
actually started
no
with
problem.
that program, right? And then when we went to treat patients with MR-Linac, because of the creation of the Mirage trial, we were thinking about doing similar studies. Our physicians actually saw such big changes in the anatomy, right? So you see a lot of changes with regards to bladder filling, but then also, I mean, you have some videos in the MR-Linac space. Even if you say, for example, a TrueBeam plan can be delivered in a minute, 15 seconds, basically, you'll see within a 20-second space a patient pass a gas bubble and the prostate move completely outside of your volume. That's half of your treatment, and the prostate is sitting halfway outside the volume. So when our physicians started seeing the MR-Linac patients, then they refused to go back to CyberKnife because then they said, we can't see the bowel and we can't see the bladder. And so then they went to TrueBeam. So most of our prostate SBRT patients are actually treated on either a TrueBeam with triggered imaging, or an edge, or the MR-Linac, but they actually stopped treating them on CyberKnife, and they're afraid to treat them on CyberKnife now because they can't see that. But the data is actually there. So the non-prostate teams are actually, we're trying to push them back to CyberKnife.
Sure, but
and
I
prostate
think the
teams are
more
actually taking
important
them off.
issue is about treating the pelvis.
Yeah.
We do not see low intermediate risk
See,
patients.
now we actually will not able to treat the pelvic nodes with CyberKnife because we track the lumbar spine, and the distance between lumbar spine and the pelvic nodes are more than 5 centimeters. There is a tracking error. So usually the pelvic areas we cannot treat with CyberKnife that much because we don't have a pelvic tracking system there.
I think majority of us
so we don't
here
do
are
that.
C-arm Linac users, and I think Rupesh has made a very valid point. In CyberKnife, we are keeping our eyes shut about the bladder and the rectum volume, and MR-Linac is, in MR-Linac you cannot correct all the setup errors. People who are C-arm Linac users, I think, are in the best space, most safest.
Almost the best space, because IMPT proton again. No, on a serious note, so your trial has demonstrated amply, world-class trial, especially the burden of the patients that we have. You got to treat the pelvis. You can't just ignore it.
Yes.
And that doesn't mean, as you rightly said, lack of technology doesn't mean you ignore the fundamental clinical principles of treatment. So why not IMPT and proton?
That is because of the cost.
1 second.
Yeah.
Yes.
You will know in 5 years. We'll tell you in 5
I mean,
years.
we are doing the prostate.
I
I know what you mean.
Yeah.
So there is lack of awareness and accessibility,
Yeah.
affordability. But if the cost was not an issue.
And I think I showed in my talk that significant toxicity of pelvis is on the bladder, not the rectum, not the bowel. And proton is, and that's one of the letters I had written with Srinivas, that is where protons can help when you're treating the pelvis. All that bladder dose will be, it can be reduced.
In our meetings, Srinivas always focuses on bladder, not so much on the proton.
It's not required.
When they do the planning.
Yeah.
Right.
Because of the shortage of time, shall we wind up?
Yes.
Otherwise, it might lead to machine fight.
Thank you, faculties, for the interactive session. We shall now break for lunch. We shall reconvene earlier at 1:45 p.m. I request all people to also give their feedback, which has been circulated in the WhatsApp groups. And people who have not registered for the e-certificate, kindly do so.
We'll be having a lecture on technologies for SRS and SRT, comparison of advantages and limitations. I invite the moderators for this session, Mrs. Soumya N.M., Senior Medical Physicist, Amrita Hospital, Kochi, and Dr. Uday Krishna, Senior Consultant, Department of Radiation Oncology, Apollo Proton Cancer Center, Chennai. I request the moderators to take over and please announce the speaker for this session.
Good afternoon and thank you all. When we reassemble for the next session, I'm sure nobody else than Dr. Rupesh would have been the best choice for this talk, because he works in a place with all technologies possible under one roof, from TrueBeam, LINAC to CyberKnife, Gamma Knife, ZAP, Protons, MR, LINAC. So he's got everything under one roof. So he's the best person who has used all the technologies possible for SRS, SRT, and also with his background experience. So I welcome Dr. Professor Rupesh Kotecha, who is Chief of Radiosurgery at Miami Cancer Institute, to deliver his talk.
Okay, thank you so much for the organizers for having me here today. I'm scared to give this lecture, especially given the experience I've seen over the last 2 days. I know we're very particular about their particular technology. So we'll discuss some of the advantages and limitations, and hopefully nobody will throw anything at me. These are my disclosures, and you'll see I obviously with conflicts with many of the technology vendors given our relationships at our institution. So we showed this yesterday. So, we have a variety of technologies that are available at our particular institution. Actually, just last night, we upgraded the Gamma Knife to the Esprit, and then we are working on installing the ZapX radiosurgery system. And then Minash, who actually leads our center, is working on bringing a brand new particle therapy system to our facility as well, which is not even on this slide yet in the future. But really, the goal of having all of these technologies at the exact same center is to employ the optimal modality for any patient given any diagnosis. And I think we've talked about this over the last 2 days of the course, is that there's a variety of differences between the technologies. Almost like if you looked under the hood of a car, you would see differences with regards to the radiation type, whether this is an isocentric or non-isocentric delivery platform, what's the IGRT that is available, both inter as well as intrafraction, and that ultimately leads to a variety of ideal clinical indications for every single technology, as you can see here. At our facility, we have a very thorough process in which patients are evaluated for their treatment. So, for example, if we see a patient in consult, we would create an original simulation directive to say, this is what I would like to treat this patient with using this technology, using this dose and fractionation schedule. And then we actually do a multidisciplinary prospective peer review process every single morning, and that requires both the physicians as well as the physicists and the dosimetrists. We look at images, the patient is simulated, and then an individual physician does the target volume and organ at risk delineation. We then have a second peer review of the contour set, then do treatment planning, and then when the individual treatment plan is approved, there's another peer review of the treatment plan with all the physicians in attendance, and then the patient gets treated. So essentially every patient's plan is looked at 3 different times. And specifically, if we just go back to the first step in this process, or the technology triage piece, when we looked at our data for the patients who are prospectively evaluated, when you're using advanced radiation, so IMRT, SRS, or SBRT, 25% of the time there was a change just at the initial technology selection and simulation stage itself. So this is important when you have multiple technologies.
So given that we're in the extracranial section here, we'll talk about an example of SBRT that doesn't really require any introduction, early stage lung cancer. We know there's a long history of offering SBRT for those patients. If I see a patient at our facility, essentially I have 5 different machines to choose between, right? CyberKnife, a TrueBeam, MR-Linac, proton therapy, as well as tomotherapy. All of those machines have published evidence of treating patients with SBRT and clinical outcomes. So essentially, when I start to think about going through the patient history, looking at their images, when we start to evaluate the patient in the clinic, I start to think about some of these factors. So if I'm thinking about a CyberKnife, is that lesion trackable? Do I need fiducials? If I'm thinking about an MR-Linac, does that patient have claustrophobia? Is it a very lateralized lesion? If I'm thinking about proton therapy, is there going to be a large amount of motion that could potentially result in missing the target itself? And then if I'm thinking about tomotherapy, would there be a need for coplanar versus non-coplanar beams? So these are kind of some of the factors that we start to think about. One of the lucky parts about our center is that you go through each of these things, and if there's a yes to more than one machine, we can actually make the physicist and the dosimetrist do a comparison treatment plan, which initially at our standpoint sounds very intriguing. But ultimately then, at the end of the day, when I have to evaluate and treat a patient, I may have to look at multiple different treatment plans. We don't often do this for SBRT, but for example, for very complicated tumors like we were thinking about with chordomas, I potentially will see a plan that is protons all the way through, or protons plus a CyberKnife boost, or protons plus a tomo boost. And so we'll have to evaluate 2 or 3 different radiation plans for any particular patient. Ultimately, we want to treat the patient with the best quality plan. So at our facility, it doesn't matter to me as a physician which machines that we use. We just want to use the best dosimetric plan to treat any particular patient. Now, we talked about on day 1, some of the comparisons between the treatment planning systems themselves, and I get these papers to review all the time for journals, and I hate reviewing these. But this is actually one of the most commonly cited articles that basically supports edge radiosurgery over gamma knife radiosurgery. This is the experience from University of Alabama, where they looked at their patients who were clinically treated with the gamma knife and then replanned with multi-arc VMAT in that second column there. And they showed that the conformality index was higher with multi-arc VMAT compared to gamma knife radiosurgery. What they didn't say is, for example, this was a gamma knife model C, so you can see that's the addition that I put there. Yet this paper was published in 2014. That's 2 years after the perfection was introduced. So again, when you're using comparison plans, you should use the latest versions of each of the technologies. And then finally, these are clinical plans. So we talked about the gamma knife and how the source decays with time, and therefore sometimes you accept lower conformality indices just because of treatment time. But then if you look at, for example, at our center here, this is just raw data of the last 500 cases that I've done. Our average conformality index is much higher than even, for example, what they got as best theoretical plans, for example, University of Alabama. So it's not only having the machine, but how do you use it? This gets even more complicated when you enter the world, for example, with MR-Linac-based radiotherapy. So this is a study that we did for adrenal SBRT patients, and you could look at the original treatment plan that was developed on a TrueBeam, and then you look at every single fraction anatomy, because the anatomy changes so much for these adrenal SBRT patients, right? For left-sided patients, the bowel and the stomach moves closer to the target. For right-sided patients, the duodenum or even the bowel can move closer to the target. And so we replanned these cases with every single fractional anatomy case. And although a TrueBeam actually won with regards to the initial treatment plan as a VMAT plan, it actually lost out, and 70% of the time you would actually overdose a constraint with regards to the bowel or the stomach. So you have to think about what the anatomy is going to be on the actual treatment itself. So when we're thinking about technologies, I divided this into some of the principles that are similar across the technologies. So things that don't change, like the contouring guidelines, your prescription doses, the dose constraints, and the plan evaluation. And then there are things that are different across the technologies. So we'll start with what things are similar across the technologies. So all of them need contours, right? And that contour needs to be done on the planning scan. There are certain technologies in which you use a breath hold scan, and there are certain technologies that you use an average CT scan, for example, with proton therapy or with a TrueBeam or edge treatment. Our contouring guidelines are the exact same if I'm going to contour a lung SBRT case for proton therapy versus a TrueBeam versus a CyberKnife to some degree. There's always going to be a GTV. Some machines use an ITV, right? So for CyberKnife, you don't need an ITV. For MR-Linac-based treatment, it's a gated treatment, so you don't need an ITV. But for example, for proton therapy, we would use an ITV. We use a CTV at our institution and then a PTV on top of that. So these are the same target volumes essentially across the facilities. We do use a CTV margin for our cases. This is data from Beaumont showing here that with early stage lung cases that were all resected, there was a difference in the microscopic margin based on the histology of the tumor. So if you have a low-grade adenocarcinoma, these bronchoalveolar adenocarcinomas, potentially you need a larger margin with regards to your CTV compared to a normal high-grade tumor which we treat, in which you potentially don't need a CTV or a very small CTV margin. The next step is delineating the target volume. So this is a case of mine, right lower lung. You can see a very nice delineation of the tumor, and GTV is in red. Then you have a small ITV. This tumor didn't have a lot of motion. Then you have a CTV. Then you have a PTV, right? So this should be very straightforward. Interesting enough, if you go back to, for example, some of the historical astrocontouring guidelines, this is the original target volume that was delineated for this Astro class in 2017, which was part of. And then look at the contours that I got from the class itself. So you can see the contours are all over the place. These are all attending physicians in radiation oncology, and you can see the contours can vary significantly. You also have to contour the normal structures, and this should be the same across all the platforms of the machine. So for example, these are all the contours that we use for our normal lung SBRT cases, just an example here. And the prescription doses should also be essentially the same across the machines. So for our facility, essentially peripheral central tumors are all treated in 5 fractions. There are some special indications. If I see a medically operable patient who just refuses surgery, we try and push the BED. If you look at the long-term control rates, potentially with 5 fractions are a little bit lower than using a 54-3 regimen. If they're frail patients, we treat them in a single fraction if they're on a clinical trial. And then for large tumors or ultracentral tumors, we use a risk-adapted fractionation schedule. And then finally, the dose constraints and the plan evaluation, those should be the same regardless of the machine that you're utilizing. So for our facility, every patient that we treat with SBRT, a physician puts in an individualized treatment planning directive for any particular patient. And then on the back end, the dosimetry and physics team at the time of plan evaluation, they will show you a plan evaluation sheet. The reason why we have to keep this separate is because each of the systems do this differently. So if you treat a patient on CyberKnife, it's not actually in the system itself, versus if you treat a patient, for example, using Eclipse on a TrueBeam, you can actually have in your ClearCheck, it gives you these SBRT planning constraints. So one of the things when I evaluate programs, they don't always look at these constraints. So I reviewed a plan from another institution the other day, and they didn't actually look at their R50 or their gradient index for a lung SBRT case, and they were significantly exceeding what you would think about for normal constraints. So make sure that you're looking at this, whether the system tells you that or not. Okay, so let's talk about the different principles across the technologies. So simulation is going to be different across the different machines. The immobilization devices are different, tumor localization, and then treatment delivery itself. So again, we're going to go through each of these technologies one by one, but whichever machine you have, I'm sure you're doing great with it, so you don't have to fight with the other centers. So with regards to CyberKnife, so when do I think about triaging a lung SBRT patient to CyberKnife? Well, I think about patient indications and then tumor indications. For a patient, they have to be able to maintain the treatment position for an extended period of time. We talked about earlier in the prostate SBRT section, TrueBeam or an Edge can deliver an SBRT treatment in under 3 minutes. That's not the case with the CyberKnife, so the patient has to be able to be on the machine. The patients who are unable to tolerate a breath hold delivery case, if they're going to have a lot of tumor motion, treat them on the CyberKnife. They do have to have a reproducible breathing model, though, because you have to develop a good respiratory correlation model. So we have a lot of patients who are elderly, who are coughing during that treatment. It'll throw off the model. You'll never be able to develop one. And then finally, if the patient has significant tumor motion, despite, for example, a maximal abdominal compression, I treated a patient last week who has a very, very large stomach. He's 300 pounds. And so, you can't actually compress this patient. And so that would be a patient you'd think about. There are also patients who cannot tolerate compression. So another patient I simulated 2 weeks ago has had chest tubes in the back of their lung for other things. Therefore, you cannot compress that patient. A patient has recently had surgery for a gallbladder surgery. They couldn't be compressed. For tumors, you should think about peripheral or island-located tumors. If patients come in with fiducials, then I might as well just treat them on the CyberKnife because the system can track it. But I don't usually send patients for fiducials to be placed. And then if there are tumors that are abutting the chest wall, the CyberKnife has a non-isocentric delivery platform. If you treat that patient, for example, on a TrueBeam, we talked about using a 6 FFF beam. That's a very shallow beam. The average energy from a physics standpoint is probably about 4 MV. So that ipsilateral VMAT arc is actually going to draw a lot of low dose into the chest wall. So if you look at those plans and you look at your 20 or 30 gray isodose lines, you're drawing a lot of dose into the chest wall that you would not with the CyberKnife platform. With regards to simulation instructions, typically these patients are simulating the supine position, their arms are at their sides, and you remember their arms cannot be in weird positions because the machine could collide with that patient. We use a non-contrast CT for planning, and you do have to use a breath hold scan at the time of actual treating. And then on the day of the treatment, in addition to simulating the patient, you actually have to do a CyberKnife tracking test to ensure that the tumor can be tracked on the machine. This is different than any other machine that you have in the department that can do that. With regards to plan evaluation, always look at the target coverage, the stereotactic planning parameters, dose constraints, and then look at the delivery method. So again, something in the brain, we think about cones versus iris versus MLCs. Sometimes you can get a very fast plan with MLCs. So I just got a CyberKnife plan for the brain with MLCs that could be delivered in 25 minutes to treat 3 different brain mets, but the conformality was terrible, and so we had the dosimetrist replan it overnight, essentially, and I wanted to go back to iris. Look at the treatment time, and then finally the beamlet path. This is something that's not always evaluated. I think people that don't treat on CyberKnife a lot don't always think about it. But for example, for an apical tumor, make sure you're not going through the jaw or something like that. This is an example case of mine. So this is a patient with an early stage adenocarcinoma of the right upper lung. The patient actually did not want radiation, did not want surgery initially, and went for a cryoablation at a different facility. Obviously failed that treatment. You can see this is the PET scan after the cryoablation. That's why it's not really a treatment, curative treatment for this. But in this case, you can see that this is a very well localized target that can be treated with CyberKnife, and you can see the dose distribution here. So why did I triage this patient to CyberKnife? Well, number one, it's an adenocarcinoma, has lipidic predominant features. So in that case, you have to add an additional CTV margin. So in this case, as a low-grade adenocarcinoma, we used a 5mm CTV. If you're going to use a larger CTV, you really don't want to have an ITV on top of that. So we chose a machine that doesn't have an ITV expansion. Secondly, we wanted to stay off of the chest wall. That superior aspect of the tumor comes close to the chest wall. So again, I'm selecting a non-isocentric delivery platform. This is a cavitary mask that has spiculations, and so sometimes it cannot be tracked very well with other treating modalities. For example, if you treated that patient on an MR-Linac, you'd actually get a low correlation model. And then this patient could not tolerate breath hold, and so you have to treat them on a machine that doesn't require that. If you look at what the tracking images look like for this case, this is ideal because you have a hole in the middle of the tumor from the cryoablation procedure. So you have a hole, and then you have tumor, and then you have air. So this is actually very well visualized on the machine. And you can see the respiratory correlation model here. This patient does excellent on the machine itself. Second example, so this is an 85-year-old with a very large left lower lung mass. And in fact, she was initially seen when it was 5 centimeters and was going to be referred for radiation therapy. And she said, I don't want radiation. If I'm ever going to get chest wall pain, I'd rather die of my tumor than get chest wall pain. So she kept getting treated on her EGFR targeted therapy. This kept growing, and finally she got referred to us now when this mass is about 8 centimeters and it's touching 3 different ribs. So now I have to treat her and not cause any chest wall pain. So triage her to CyberKnife. I need to stay off the chest wall, so I'm thinking about a non-isocentric delivery platform. This patient is very elderly. She's 85, cannot tolerate a breath hold, so patient compliance, she couldn't understand the instructions for breath hold. Yet, she was a non-smoker, right? As an EGFR mutated patient, she had never smoked, and therefore she has very good baseline lung function. In fact, she has more than 1 centimeter of motion with maximal abdominal compression. Even with the 30 PSI, she's still moving 1.5 centimeters. If you have an 8 centimeter tumor, 1.5 centimeters pulse of motion, plus your CTV and your PTV, that tumor volume is going to be very large. So this is our treatment plan. So 60 gray and 15 fractions to really limit the chest wall dose. If it was a younger patient, they were okay with some chest wall pain, I would have treated in 8 fractions, but we did 15 fractions. We talked about on the first day some of the physics of and secrets of really SBRT is that it's 60 and 15, but look at the dose to the actual tumor, right? The mean dose is 81 gray and 15 fractions. The max dose is 93 gray and 15 fractions. So this is a very hot plan because I'm really trying to get good tumor control in a very large tumor. And at the same token, I gave the dosimetrist the instructions that I want the chest wall dose. I looked at the 250, 120, 60, and 15 cc's. Essentially, I wanted the dose to be 20, 40, and 60%, basically. And so they were able to meet these constraints for me. Oops. So that patient was able to be treated. That tumor obviously reduced in size, and she never had chest wall pain. And that's giving basically 90 gray and 15 fractions to that tumor to control it. Next machine, TrueBeam. Probably the least controversial. So patients that I consider for TrueBeam, they're patients that need to be treated expeditiously. Those patients who really need to be treated with a treatment time that's going to be 3 minutes or less. And the patients who have limited or minimal tumor motion with abdominal compression. I think about it for tumors that are centrally located, but not ultra-central, is that I want to look at the patient alignment and the OARs. I also consider it for small tumors that are unable to be tracked with the other machines or without fiducials. Also for tumors that have a ground glass component, they're not visualized with, for example, the CyberKnife or the MR-Linac. These patients are typically in the supine position, their arms above their head, they have a full body immobilization. Typically, we don't use contrast unless they're central tumors. Look at the target coverage, stereotactic planning parameters, the delivery method, and sometimes you need a CBCT, and you potentially can put tolerance isodose lines if you're looking at a very sensitive structure. So, for example, if you're treating an ultracentral tumor, I would start to put these tolerance isodose lines so you know at the time of treatment what you're looking at. These are 3 examples of patients. The first one is a patient who was initially planned for CyberKnife, but they couldn't stay on the table long enough for a tracking test on their simulation day, so they just need a fast treatment plan. So they're treated on the TrueBeam. The second is a patient with an apically located tumor, and you can see there's a nerve root close to the tumor. There's the esophagus, put a PRV on there, and the brachial plexus looks far here, but in the superior aspect of this tumor, the brachial plexus draped right over this area. So I really wanted to see this with 3-dimensional anatomy for each of their treatments, so that's why I would treat them on this machine. And finally, the last patient has a tumor that's very small. This is too small for real-time tracking on the MR-Linac or with the CyberKnife without fiducials. And so a very straightforward case to treat on TrueBeam. Also think outside of the tumor itself and what you're treating and what else is in the patient as well. So this is a patient who's medically inoperable, early stage lung cancer, right lower lung, SBRT case. And although this would be very straightforward to treat on a variety of platforms, patient happens to have a pacemaker in the left part of their chest. And interesting enough, as you can see here, camera B can't see that tumor because the camera is going right through the pacemaker. And you can, from a physics perspective, go through an exercise to say, well, we take 200 kV images during a course of CyberKnife treatment. We have 5 fractions. That's about 1,000 images. And you're going to exceed the pacemaker tolerance just by putting that image through there. On the other hand, this is what these types of treatments look at when we treat them on the TrueBeam. So typically they're partial arcs, and I typically treat them in 2 arcs, potentially a 3rd arc if you have a very close critical structure. MR-Linac, so we've heard that there's one MR-Linac machine in India. This is actually increasingly being used for lung SBRT. So there are some patient and tumor considerations for these patients. For patients, they have to tolerate breath hold. It's a gated treatment. And typically the shortest sequence that you can do on MRI for a patient is 17 seconds, but really the patient needs to be able to hold their breath for 25 seconds because you need some time for the machine to kick into the image, then do the image, and then finish the image, otherwise you can have an issue. The patient has to be MR compatible, so you cannot have a pacemaker or metal hardware. We will have a paper coming out on how to treat these patients with a pacemaker, but for other facilities I would not do it for right now. They have to tolerate the extended setup time. It's a longer time in the bore itself, and it's a tight space, so the patients who are not claustrophobic, although we installed actually a camera system so that the patients can actually view everything that's happening, and now there's a new system with the upgrade. They can actually participate in their treatment. They can see exactly what we're seeing, and I'll show you the images of what this looks like. And so this actually has helped a lot with claustrophobia for our patients because they're paying attention to something and they're actively engaged in their treatment. I use it for patients who have interstitial lung disease. That's actually where we get referrals from outside our center, as patients they're never treated at other facilities. Like I have a patient with a DLCO of 9% who's on 5 liters of oxygen. That's not a patient that any other facility is going to treat, and we treat them with a GTV to PTV of a 3 millimeter margin. We use it for single fraction treatments. Things to be aware about, so beware about peripheral tumors. You have to offset that patient in the bore, and that bore is very tight, so sometimes you don't have the room to do that. Beware of very small tumors that can't be tracked. Typically those that are smaller than a centimeter can't be tracked on the machine, and then those that are non-solid tumors, they have a poor correlation in tracking. You're just wasting everybody's time. For single fraction radiosurgery for the lung, this is our table of the dose constraints that we use at our facility. Essentially, we're treating all of our single fractions on the MR-Linac. It gives you the fidelity that you know exactly what you're treating. It reduces the lung dose with single fraction because there's no ITV margin. You have the ability to replan the case if you need to recontour or reset up anything. And then you can visualize the treatment. So if we're giving only 1 fraction, I feel comfortable for the fact that I can see that tumor being treated the entire time of the fraction itself. We just completed our single fraction lung trial called the SMART-1 trial, so we'll show you the results in the future for that. With regards to simulation, patients are simulating in the supine position, their arms above their head. There's a non-contrast CT scan that we use for dose calculation purposes. They do have an MR sim at the same time in the breath hold position. When you're looking at the plan, target coverage, stereotactic planning parameters, dose constraints, also need to look at beam entry. There's a lot of restrictions for beams, for example, at the corner of the couch, which is typically where you see tumors too, so be careful about some of those beams. Physics may put some beams in those locations, and that can be an issue in the future. And then make sure that there's a MR fusion with a tracking structure. I'll show you what that looks like. So this is the workflow for these patients. So they get an MR first, then they get a CT, then you fuse and contour. We do our planning QA, and then at the time of treatment, the patient gets a cine MRI scan, and then the radiation is delivered. So this is the traditional non-adaptive workflow. So at the time of treatment, you actually identify the target that you want to track. That's typically the tumor itself. But you can also have a critical structure that you want to avoid treating. So for example, if we're doing SBRT close to the thecal sac for a patient who's getting reirradiation, you can actually make the thecal sac your contour and your target. So if the thecal sac moves within any radiation zone, then the machine is automatically triggered to beam off. So I typically use targets of interest, and Manesh goes the opposite. He likes to use regions to avoid. You can create the boundary around that tracking area, and you can restrict the machine for treatment during that zone. And then you can visualize the tracking algorithm as it deforms to the anatomical target. So essentially, if the target is within the boundary, the machine is on. If the target moves outside the boundary, then the machine turns off. It's very straightforward. This is the first patient that I actually treated on the machine about 4 years ago. Actually, a physician himself, locally advanced colorectal cancer, very large tumor in the left lung, needs SBRT, would not undergo surgery at his age, and basically no other facility was able to treat him for such a large tumor. Essentially, this is what we do. So the tracking structure is drawn every day, and then a boundary structure, which is 3 millimeters, is expanded based on that. And we adjust this every single day based on the tracking availability. This is actually the treatment delivery itself. Let's see if I can click here. So this is just to show you, this is what the patient sees, and this is what you can see actually on the machine itself. So when the patient's taking a breath in and out, you can see the heart breathing, you can see the diaphragm moving, and then as this moves in and out before he starts his treatment, nothing is actually happening with the machine. I can't forward this video, but essentially he will go into a breath hold eventually. I'll skip for time. But once he goes into a breath hold, and then the tumor actually is within the zone, then the machine turns on. So it's triggered just to this time. We use this for very high-risk patients. So this is a patient what I think is a trifecta. So a very large tumor in a very critical location. So this is potentially a central, or as most people will define this is an ultracentral tumor, given how close it is to the trachea and potentially the esophagus. And you can see the baseline lung function. This is the patient who has interstitial fibrosis. So this patient has bad lung function, very large tumor, and an ultracentral location. So basically every other facility said they couldn't be able to treat this patient. And this is basically the only patient we have ever treated in 40 gray and 5 fractions, because we could not meet any of the dose constraints, and he was coming from a very far location. And normally I would give 60 and 8, but we had to give 40 and 5 just because he could not come for more than 5 treatments. You can see the image before, and then you can see after treatment. So essentially you have an excellent response to treatment, and you can see just some residual fibrosis and scarring in his lung, which on axial image probably is what he had even before the tumor actually developed. And so this is, didn't have any decline in his lung function, ended up passing away later of a heart attack unrelated to any treatment itself. Really the power of MR-Linac therapy, though, is in the adaptive workflow. So this is the difference for the non-adaptive workflow. The first part, simulation treatment planning, is the same. But then the actual treatment, we have an MRI for adaptive planning, we recontour the case, we do plan adaptation, and then we do a cine MRI, and then the patient is actually treated with their radiation. This is a ultracentral lung SBRT, or what was previously thought of as a central lung SBRT. You can see this tumor in the left upper lung, and you can see the esophagus here in green. And if you look at their first fraction of delivery, now you can see the esophagus is a little bit closer to the tumor. So if you initially made this radiation plan, if you gave 50 and 5 to that tumor, you thought the dose to the esophagus was probably about 25 gray, right? It's going to be right your 2 cm ring, so you think you're very safe there. But look at fraction number 1. It's probably like 30 gray and 5 fractions. Look at fraction 2. That's probably right within your 47.5, so that's going to be exceeding your dose to the esophagus just by that. And with the use of adaptive planning, for example, for that last case, you can make the new radiation plan. Not only do you reduce the dose to the esophagus from, for example, 47.5 and 15 back down to about 35 and 15, but it also lets you push up the dose to the actual tumor itself. So you're getting 2 advantages here. You're increasing the dose to the tumor, and you're decreasing the dose to any organ at risk. There's a trial that we were doing before for patients who had central and ultracentral lung tumors. Unfortunately, this was funded by ViewRay to us, and so when the company went bankrupt, we had to pull this clinical trial. But we still use this for central and ultracentral lung tumors, and I know we were talking to somebody earlier. I've sent these constraints and everything for this trial to a number of other facilities, and so a lot of people are actually using this to treat their patients. Then finally, we'll go to proton therapy just at the end here. So things to think about. The rationale for proton therapy, this is really in general for any cancer. This is not specific to lung SBRT, but it's really to reduce the dose of the normal tissues. And it more safely allows treatment to tumors that are close to critical organs. That's why we use it, for example, for chordoma patients. It most safely allows for dose escalation and then potentially for retreatment of patients that are not treatable with photon therapy. So a lot of the patients we treat with protons for lung tumors are patients who have already had 60 and 30 in another facility, go on adjuvant durvalumab, and about 30% of those patients end up having a local failure. Now they're getting sent for proton therapy at our facility. Potential benefits are reduced treatment-related toxicities. You can potentially provide a chance of cure that's not otherwise achievable with photon therapy, potentially improve local control, progression-free survival, and then potentially, gives overall survival benefit. So all the technologies I've talked about till now have been on photon SBRT. And although the dose distribution looks really good, it's because we typically look at just the higher isodose lines, whatever in our 2-centimeter ring. But when you start to turn on the lower isodose lines, you see dose everywhere with regards to the rest of the lung. You can do that same exercise with proton SBRT, and just like non-SBRT cases, you don't see any of those lower isodose lines. And so there's a significant dosimetric difference here, even in the SBRT space when we're using if you look at the lower doses. We have some limited data to date, which is very intriguing, actually. So there's a meta-analysis of 72 photon SBRT studies with 9 really hypofractionated proton studies. And in the proton series, they had larger tumors. Those are patients that get referred to proton therapy facilities because they were difficult to treat. So the average tumor size is larger, and they're less likely to have T1 disease. So you're treating worse patients. Yet, if you look at the progression-free survival, you look at the overall survival, and you look at the grade 3 pneumonitis, they're lower with proton therapy. And so it's a safer treatment for even these smaller tumors compared to photon SBRT. There is one randomized trial in this space. It's a randomized phase 2 trial of SBRT of photons versus protons, and they selected out the higher risk patients, those that were centrally located, and then patients really who had smaller tumors, but they included up to T3 tumors. And the primary objective was to look at the toxicities, because it was based on this earlier study, and said, listen, it was a safer treatment, so potentially that's how we should power the study. What they interestingly found is, although the safety was there, and photon SBRT was overall very safe, the survival in a randomized trial was actually longer with proton SBRT. In fact, it was actually not even reached in this study with the follow-up that they had, versus 28 months with photon SBRT, which is very consistent with what you see in the photon literature. This was driven by higher rates of tumor control as well as progression-free survival. With proton therapy considerations, typically our patients do have to tolerate breath hold or have very limited motion. They do have to tolerate an extended setup time. You can't have any potential anatomical distortions such as pleural effusions, pneumonias, and atelectasis. This is not common for our SBRT patients because they have early stage disease, but it's a disaster for me for these locally advanced patients because you have any change, it can throw off your proton therapy plan. We're actually replanning a case right now because of a small pleural effusion in a patient. Fiducials can be placed, but if you have volumetric imaging in our facility, we have CBCT on every single gantry, and so potentially we don't actually have to place fiducials. Do be aware about anatomical changes in the patient as well. For example, patients who have gained a lot of weight, the prostate cancer service actually sees this all the time because the patients get started on hormones and then come back for the treatment, and on hormone therapy, they've gained so many pounds. That can potentially offset your proton therapy plan. And then for tumor changes, patients who have any changes in the tumor size or density can actually change your radiation plan. On the top image is actually an example of an apical lung tumor, and you can see typically the beam arrangement is, and we will use more than one beam, but this is just showing one beam here, a right posterior oblique beam. As the tumor is shrinking during treatment, we're very excited about this, right? And on a normal CBCT, we'd be excited that patients responded to treatment. On a proton therapy CBCT, I'm getting very concerned because that means I have to do a new QACT and I have to replan the treatment because now you're going to shoot right past the tumor and into the heart. And in this case, other examples are you don't even think about the spinal cord, but it's actually part of your treatment with that posterior oblique beam. So you actually increase the dose to the spinal cord. It actually just happened to me in a case last week, and I didn't even think the beam was going into the spinal cord at all, but you had such a reduction in tumor during the course of treatment that overshot the dose. With regards to simulation instructions, typically they're in the supine position, their arms are above their head with their ipsilateral arm up. We use a non-contrast CT scan for all proton therapy planning, and we use a 4D CT scan. You have to look at the target coverage, stereotactic planning parameters, the dose constraints. In proton therapy, typically for SBRT, we repaint those cases. That means essentially we're delivering the treatment into smaller subfractions, but the same volume being repainted multiple times. you always have to look at the beam angle entry, any potential overlap, as well as where is that beam exiting, so that if you have a tumor that is shrinking, then where is that going to exit into? So ultimately, this is very complicated, but I think teamwork is key to this process. Since the buzzer didn't go off, I actually put a example case at the end of how do you put this all together, so we'll move to that quickly. So again, we have all of these technologies to treat this. This is, I think, an interesting case to show you an example. So this is a 73-year-old male who actually came to me from outside facilities. So he had right lower lung and left lower lung squamous cell carcinoma. So he said, well, we don't know, do you have synchronous primaries versus metastatic disease? He started for upfront systemic therapy. And ultimately, the right lower lung nodule had progressed. So you can see this PET scan that he came to me with. You can see the tumor there, but on the coronal image of that PET scan, you can see there's a decent amount of motion to that because that PET signal is moving up and down. So this patient actually was simulated for treatment, and initially he said, I want the quickest treatment possible, and I am claustrophobic, and so we said, okay, we'll treat him on an average CT scan, right? So this is a supine, arms above head, we'd use abdominal compression, we did a 40 CT, and that's his average CT scan for planning. The problem with using this average CT scan is that he had a significant amount of respiratory excursion, so he had more than 1.5 centimeters of motion despite a 30 PSI abdominal compression. That means that his tumor treatment volume was more than double the size because of that respiratory excursion. I also can't delineate the edge of the tumor given that vascularity in the lower lung itself, and this could potentially undercover or over-treat the inferior extent of disease, and you have no idea where this is in the diaphragm. If you look at the lung SPT series for lower lung tumors, there are incidences of gastric perforation, and specifically its stomach, because we don't know that inferior extent of tumor. So we had 3 machines that could have treated that patient, but because of that average CT issue, I can't use either a TrueBeam or a TOMO or proton therapy, right? With the first machine, I have an increase in the treatment volume. You have difficulty accurately registering the CBCT. You get some imaging artifacts. With the tomotherapy system, a lot of the same issues, especially with the MVCT. And with proton therapy, not only do you have that issue, this last bullet point, which is a particular issue, is that you have non-synchronization of the spot delivery and respiratory motion. So you have an interplay effect. So again, 3 machines that we have to cross off the list here. So next we said, okay, he's really claustrophobic. Let's just try the CyberKnife. So this is the CyberKnife sim for that patient. So you can see an expiratory breath hold scan. Although this is a problem because we can't actually create a respiratory correlation model for this patient because you can see the camera in camera A can't actually see the tumor itself from the surrounding lower diaphragm itself. So again, this system actually failed for this patient. So we're crossing off 4 of our systems here. So we ended up simulating him. I convinced him that he could get through an MR-Linac despite having significant severe claustrophobia. So this is the MR-Linac scan for this patient. You can see how beautiful this image looks. I have a GTV, I have a CTV, I have a PTV, and you can see the tumor very, very clearly. And this patient received 50 gray and 5 fractions, and obviously you can see a great response to treatment. So this is a patient who actually got simulated for multiple different machines, but ended up receiving a specific treatment for a specific reason. So hopefully that's an example of how we tailor this for any particular patient. Got through it. Okay.
So if you have to compare photons and proton plans, you immobilize them separately?
So it depends. So proton therapy patient, if you're going to immobilize them, for most cases it's the same immobilization that you would use, for example, for TrueBeam, sometimes for tomotherapy, depending on the site you're using. We use the boss frame for protons, and then all of our photon machines can actually have the same immobilization applied to them. So you can transfer them across machines.
Thank you, Professor Rupesh, for the excellent talk. Now it's open for discussions.
Yeah, there are many actually doses fractionation schedules. So are you treating with like single fraction on 60 gray and 3 fractions to lung as well?
Yeah, so as I showed, essentially most of the patients are treated in 5 fractions at our facility. It just makes it easier. We have so many issues with the technologies and other things. At least make that similar across the machine. So essentially any peripheral tumor, 60 and 5, central tumor, 50 and 5. It also, then people are less likely to make mistakes across the different things. If you have a medically operable patient who is just a young patient and says, I do not want surgery for any reason, or for some reason, what if they had a heart attack last month, and they can't have surgery now. They have an early stage lung cancer, but they're 45 years old. That patient I push for 60 and 30, which is technically, when that was developed, it was homogeneously planned. So heterogeneous planned is actually 54 and 30. And so those patients I push for that. Single fraction we were doing on a clinical trial, and so use it for elderly or frail patients. we have randomized trials now, 3 that have been done in the lung space of single fraction versus 3, 4 fractions, and they had equivalence with regards to toxicity. So I think it's a reasonable option. Long term, the control is different with single fractions. We don't use it off trial or for example, for younger patients.
Yeah, like the BD of like 60 grain 3 fractions is around 180.
Exactly.
So like amongst all the fractionation schedules, it seems to be more as
Yeah.
per BD.
And that's why I use it for the younger patients who are going to live a long time. If you look at the median...
16.3?
I use 16.3, yeah, for those patients. If you look at the median survival for the patients that we're treating 85-year-olds, and they have poor lung function, they probably have a median survival that's about 2, 3, 4, 5 years as it is. If you look at the data beyond 5 years, then you start to see where that BED of 180 is going to carry somebody with regards to local control, and you're going to see a decline or failures over time with 50 and 5, so at least we'd give 60 and 5, a little bit higher of a BED. And that's why for a younger patient, I would push that BED to 180.
Yeah.
For an older patient, then I think 5 fractions is very reasonable. Yeah.
There would be many case scenarios where a patient would be eligible for many machines. How do you decide?
Yeah, I mean, I think, by the time I've gone through the history of the patient, looked at their evaluation, talked to the patient in the clinic, you start to cross off machines, right? So I start with that diagram that I showed you of 5 different machines, for lung SBRT.
Do you accede to patients' requests?
Well, if a patient requests a particular machine, that will play a part into it, but really it's the dosimetry. Like, it's not the patient says, I want a particular machine. They're saying, I'm claustrophobic, so then I don't choose, for example, tomotherapy or MR-Linac for that particular patient. We'll have patients come in for things like, they'll come in the door saying that they want proton therapy, and sometimes we treat them if that's the best modality, but sometimes I'll move them to another machine if that's not the best modality. So we will do a treatment planning comparison, and sometimes I'll have to sit with the patient and show them this is why you're getting treatment on this particular machine.
2 small technical questions and 1 a general question for the benefit of everyone. One is the adaptive component of the MR LINAC is the beauty, right? But you did show a lot of non-adaptive plans also. So is there a real difference in non-adaptive MR plans?
For lung SBRT, I would only use it for the patients who have significant motion. So I treat it for a very lower lung tumor that cannot be visualized on CyberKnife. Then those patients you can treat on MR-Linac because it's really, you're just using the gated version of that machine, right? For the outside of lung SBRT, a majority of the patients are treated on MR-Linac because of all of the anatomy changes. I mean, if I went to a facility that did not have MR-Linac, I would not be able to offer what we're able to offer for our treatments. Like, I would never feel comfortable treating those cases again, almost like we were talking in the prostate space, because once you see those changes, then it's hard to go back, right? With the adrenal SBRTs, we looked at our literature, it's like 87% of the time you're violating an OAR with a fractional anatomy. And so you can put PRVs and things like that, but you never would have seen those. And that's why we're able to use the dose constraints that we're able to use for those patients, because we can see on the actual day of what is the dose to that structure.
Right. In the proton, you of course showed the plan where there was a single beam, but we never use a single beam.
No, that was just showing one of the beams itself, exactly. So not all beams can be affected, right?
Sure.
So I have a patient that we're replanning right now. It's a 3-beam lung plan. The posterior beam, which is 1/3 of the contribution, is because the patient has developed a very small pleural effusion from heart failure. And so that's the reason why I'm treating this patient with protons.
Sure.
They have such bad heart function that
yeah.
their heart dose is
It's
1
very
gray.
good.
It's 1 gray with protons. Despite a locally advanced tumor with every single lymph node involvement, their heart dose is 1 gray. But this small effusion drew that proton beam back so much that our coverage dropped. But the other 2 beams were perfectly fine.
Sure.
So it's not always, all 3 beams.
So we have to adapt most of the lung cases. Even we treat with free breathing and repainting you already mentioned, and it is typically 3 to 4 fields. And what Srinivas has shown us that there is typically a flare initially, an increase, and then it shrinks. And that's quite interesting. It may not be so relevant in SBRT.
Yeah, exactly. So in SBRT, I don't see any of those changes, and I don't expect them to be case, but exactly what you say. For the conventional lung cases that we are doing, are 60 and 30, we essentially have a replan planned at week 2 and week 4. And if I don't need them, then I don't use them. But we will plan on needing an adaptive plan at week 2 and week 4 because of any changes can really shift not only your tumor coverage, but also the dose to the OAR.
Absolutely.
And sometimes, it's not a huge dose. For example, in the spinal cord for my case from 2 weeks ago, it was 30 gray on the original plan, and it went to 40 gray. I said, technically it's okay, but it's such a big difference. So then we replanned that beam, and we got it back down to 30 day, just by replanning for the anatomy difference.
Okay. A general question is then you have so many platforms, now 6 or 7. So there are 3 obvious questions. One is that you need to keep on training the physicist on different platforms, and each physicist, we have a physicist as a chair, has a different philosophy of on one platform, how do they talk to each other, whether they agree upon the plans, and that could be hard, I guess, to some extent, even from an RO, MD perspective. Number 2 is the time, because you don't have sometimes time. For example, our patients, they demand to be started in 3rd or 4th day, and then you have that challenge. And finally is the reimbursement. Now, reimbursement and cost in our setup is enormously different in different platforms. So how do you account for all the 3 points?
So reimbursement-wise, last. So SBRT is actually independent of platform in the United States. So if you do proton SBRT versus photon SBRT, you actually charge the exact same, because the SBRT code overrules the technology particle therapy or not particle therapy code. So that's actually a way to get proton therapy approved, is to do SBRT. So that's one thing, is to try and use that. We're a cost neutral center as well, so we will charge the same if the insurance will take it, so that we will charge and just treat the patient with the best quality plan itself. Going back one question to the treatment start dates, essentially all SBRT plans will start the same time out for any case with regards to any machine. So that shouldn't be an issue with the actual delivery. Now, one machine may be so busy that you can't start the patient exactly, so maybe 1 day later. But from a planning perspective, dosimetry physics has agreed that regardless of what machine I choose, that it will be the same number of days if we're doing an SBRT case. It's different for brain mets and things like that, because we treat those within like next day and day afterwards. But for a conventional lung SBRT case, it's the exact same number of days across all the machines. And then the first question about physics and dosimetry support, the dosimetrists typically, will learn more than one technology, so they'll be able to do 2 or 3 technologies. Physics typically does 1 or 2 technologies. Proton only does proton. But for the Gamma Knife team does Gamma Knife, plus they actually do CyberKnife, so that you have backups to each of the platforms as well. The MR-Linac team does MR-Linac as primary, but then they can do Edge as a second. And so they kind of know 2 technologies themselves. When I asked for a comparative treatment plan, when I said, when I can say, listen, I want this plan. So I had a very complicated base of skull tumor, and we ended up saying we wanted 3 different plans for this. Then we have 3 different physicists made 3 different plans. And they actually will do the best plan that they want, because ultimately, if we choose their plan, their work went to something. For the other 2 plans who don't get chosen, they did all of that work and it was wasted. So they want the best quality plan. And sometimes, I got a plan and I said, well, actually, I thought the Gamma Knife plan was going to be the best, and CyberKnife plan was actually better. The Gamma Knife person said, let me go back and let me just tweak my plan. And then they came up with a better plan. And the CyberKnife person said, now I saw their plan. Well, I'm going to work on my gradient.
Someday they will kill you, though.
So they said, they have the motivation, because if their plan is the one that gets treated, then they feel good.
Yeah.
If their plan does not get treated, then I tell them, thank you. But that's it. It doesn't go anywhere. And so they've wasted all that time and effort. So they want the best quality plan. So that's a little bit good to have, because then you get real plans.
Yeah.
So
just 10 seconds. I just want to tell the audience, we did the same for proton. As many of most of you are from the country, the proton charges are unfortunately a little bit higher. But for 5 fractions SBRT, it is the same as any Tomo or CyberKnife.
Yeah.
So you are free to send us the patients for proton, because the cost is 1/5 of the cost, I think.
Yeah.
1/4 or 1/5 of the cost of the regular proton. It's about 7.5 as compared to 30 odd.
Yeah, thank you. I was waiting, Dr. Jalali, to give the mic to others. Sorry. Thank you. Wonderful coverage on the spectrum of the technology. And the point to the Dr. Jalali's question to you, I must appreciate the Indian physicist who knows all the technologies. So they are ready from the day one probably, and I think that's good that they can do all the treatment planning as such, like what the dosimeters do in the other country. My comment to you is basically any experience on the MR alone treatment planning.
Yeah.
Have you ever bypassed the planning CT?
Yeah.
And
So-
used the synthetic CT from MR?
Yeah, so we are doing MR only based planning for any abdominal pelvic case now. And we have two papers. Actually, a paper got accepted to Green Journal last week. So we do MR-only base planning for those patients. You generate a synthetic CT. That's not a problem, and we've had good experience over the last 2.5 years doing that. For the lung cases, we still need to have a CT scan. But for any abdomen pelvis case, we treat with MR-only base plan. The areas where you get caught, or you don't think about, is if you have, for example, a dome with a liver, and you think you're MR-only base planning, and you have a little bit of lung on either side, so then you have to go back and get a CT for those patients. So just be careful.
Thank you.
So for a particular case, in terms of treatment time, can you just compare this?
Yeah, so the fastest is probably the edge. I think the rest of them will have very comparable. I mean, on protons, it'll take about 45 minutes at our facility, which will be the same for CyberKnife. The MR Linac, if they're non-adaptive, they're booked in hour-long slots. If they're adaptive, they're booked in hour and a half long slots. And that's the majority of what we're doing on the MR machine is they're daily adaptive treatments. And I mean, I did an ultracentral last week, and I have to adapt based on the brachial plexus, the left, the right, the esophagus, the trachea, and the PBT for a very large ultracentral tumor. Every single day, 5 structures were all exceeded. And sometimes the PBT dose, this is 60 gray, the PBT dose went up to 77 gray in one of the fractions just because of the difference in the setup. So you'll start to see these changes, and we have our paper coming out for ultracentral lung tumors, and you see the variation go all over the place, just like the esophagus dose can be very high on one day because the esophagus will be here and the esophagus will be here on the other day. And you don't catch this when you're doing CBCTs daily. We don't really think about these and the location. But if you look at some of the data, that's potentially why you have higher toxicities with the ultracentral lung tumors, right? The Amsterdam group just updated their data with central and ultracentral tumors, and they were treated 8 fractions up to 12 fractions. They still had a 35% rate of high-grade toxicity. You know, we've actually never had any high-grade toxicities with MR Linac with daily adaptive planning. So.
Yes. I have a question regarding CTV for SBRT lung. That was new to me. So is it for some of the histologies as you showed? And the next question is, I mean, it is conventionally told that the dose fall off in SBRT lung will take care of the microscopic disease. That's why there is no need of a CTV. The second question is, if we are theoretically claiming that the proton has a, sharp dose fall off, then there is a need of CTV in SBRT proton?
So the interesting thing is we do lung conventionally is GTV to PTV of 5 millimeters, right? And that's how it was originally developed. The way that they did the end-to-end accuracy is that actually the machine can deliver it with a 3 millimeter accuracy, but then we have like a 2 millimeter CTV margin in there. So although the trials were always written GTV to PTV of 5 millimeters, right? R2G0813 or R2G0236, they actually were a CTV that was hidden within that kind of target. We use a CTV margin, and specifically for 2 reasons. Number one is for example, low-grade adenocarcinomas in situ. You potentially need a larger margin for microscopic disease. And secondly is the PTV may differ across the machines. So for example, in proton therapy, you either use a proton therapy specific, beam-specific PTV, or you will robustly plan and not use a PTV. So there are some machines where the PTV can change. So on MR Linac, you can potentially use a 3 millimeter PTV. On some machines, you may use a 5 millimeter PTV. And so that's why we do a GTV and a CTV. And then the PTV should really be machine and technology specific. So that can vary across the different platforms.
Thank you. Thank you.
So thank you. Thank you, Professor Rupesh. We'll wind up the session now.
Let us now engage in thought-provoking discussions on real clinical cases as our esteemed speakers share their experiences, challenges, and innovative solutions. I welcome the moderators for the session, Professor Ferenc Lakosi, Head of Radiotherapy Department, Somogy County Kaposi Mor Teaching Hospital, Hungary, and Professor Elitsa Encheva, Head of Radiotherapy Department, University Hospital St. Marina, Bulgaria. I request the moderators to introduce the speakers for the session.
Stereotactic Radiosurgery. Korius from Stereotactic Radiosurgery Center Sigulda, Latvia. Please.
Dear colleagues, my case report will be also about the prostate cancer. One moment. I would like to have a pointer. Okay. So the patient at the time of admission was 60-year-old, good general condition. He was former sportsman, no obvious complaints. He turned to diagnostic investigations due to the rising PSA from 6.1 in 2017 to 11.8 and further to 12.69. Urologists made transrectal biopsy, and all 12 cores were involved with Gleason 4+4 adenocarcinoma in all cores, up to 90% from the core. Patient had MRI, and the conclusion was extensive malignant neoplasm of the prostate in the apical part and middle part of the gland, with the greatest spread in the right lobe, mainly peripherally, also infiltrating the transition zone and the base of the right seminal vesicle. Signs of extracapsular growth, and obviously lesion, PIRATS 5. No lesions on bone scan and chest abdominal CT, and according to initial investigation, it was classified as C3A N0M0. Patient is very active and is seeking for different options for the treatment, and he turned to the Germany, to private clinic, and they invited him to the clinic and repeated MRI. They do not rely to the MRI what is made on the place. They have advanced MRI with rectal coil and 3 Tesla MRI, and repeated MRI was carried out, and also repeated transperineal mapping biopsy. And according to their data, they did not see extracapsular growth, and also did not notice invasion into seminal vesicle, so he was restaged to 2C clinical stage. And this clinic offered nano-knife treatment. I was not familiar, honestly, about that treatment method, and then afterwards started to search what it is. It's selective microaspiration. It's actually with the current, electric current, and together also I think there is chemotherapy also involved. Some nanopores are created into the theoretically only cancer cells, but it should be investigated actually whether it's only in cancer cells. And yeah, it somehow works. PSA drops down. Subsequently, PSA again increased to 3, and later to 4, and later to 5 nanogram per milliliter. And patient yeah, there are some additional words, but I will not go in small details. This technology in the scientific literature available since 2009, year 2009, I think. Oh no, later, 2014, I think. So quite not very young technology. And in USA, I found there is more than 100 urologists practicing this method, and also in other countries, but so far no very solid evidence collected from these clinics. And repeated MRI was performed, and there was suspicion of some residual. It was described as relapse, 5 millimeter relapse lesion in the apical part of the prostate. Okay, and patient also, to confirm this, received repeated PSMA PET-CT, and also accumulation of radiopharmaceutical was seen also in seminal vesicle, what was previously also noticed on MRI, and also some lesion in sacral bone at the level of second vertebra. So patient, they offered second treatment with nanoknife. It was with the complications, with the urethral trauma during manipulation. After the treatment there was acute obstruction, catheterization was done, but later actually this resolved within a few days. And patient was recommended, yeah, we can treat these soft tissue lesions, but we cannot treat bone lesions, of course, with such needles. And patient then was recommended to turn to some other treatment method to treat this lesion in the sacral bone. And we treated this lesion with a single fraction of 20 gray. Here you can see the treatment plan. And afterwards, the PSA actually did not reduce. It just fluctuated around this previous value, and later started to grow and reached 9.54 on 27 April 21, year 21. PSA, I recommended to make a PSA. I suspected that there might be some lymph nodes involved, as he did not receive any treatment to the lymph nodes. And PSMA PET-CT showed wide accumulation of the tracer in prostate, extraprostatic tissues towards spinal bulb, left external iliac lymph node, right common iliac lymph node, left ischiac bone, bone lesions near right acetabulum. Initially, patient wanted to remain maximal quality of life and refused androgen deprivation therapy, but now I convinced him to start androgen deprivation therapy, and the patient started with bicalutamide, and later triptyline was added. Of course, PSA dropped down, but this is oligometastatic case already, and actually the initial lesion also relapsed. Actually, the nanoknife seems that didn't work in this case. So we offered our treatment both to the initial lesion, both to the involved lesions in bones and lymph nodes. It was done in the 2 stages because summary doses to the nearby bowel loops would increase, might increase the tolerances that might cause some additional side effects. So there is initial lesion, relapse of initial lesion, and we treated, of course, whole prostate gland, as it was wide and aggressive lesion. And it was a surprising finding during CT that some adenoma nodule has severe calcification, you can see here. And here also all the lymph nodes and involved bone lesions were treated with adequate ablative dose. Well, after the treatment, of course, PSA dropped down, but patients suffered to continuous bacteriuria, obstructive symptoms, pain after urination, episodes of acute obstruction, repeated courses of antibiotics was prescribed, and time after time, microcalcinates from this large nodule, which was in prostate, just went out with the urine and caused also some irritation. I suspected that it's hard to eradicate these microorganisms if such a nodule is inside the bladder, actually. And at the end, last year, epicystostoma, complete obstruction happened, and the epicystostoma was inserted. and retrograde ureterography was made. I have also, yeah, here is MRI with epicystostoma. Here is the nodule, and yeah, here is the retrograde ureterography, and you can see that it actually the whole prostate portion of the urethra contrast medium doesn't comes through it. And yeah, patient was not, of course, satisfied with the quality of life, with the epicystostoma, and was actively seeking for the different solutions. I had no immediate solution what to offer to him. He turned at first to the State's hospital. They offered cystoprostatectomy, which is also actually to living with stoma, might be even worse. Then to other clinic, to neighboring country university hospital. They recommended urethra plastics from other tissues to reconstruct urethra, and referred to Charité clinic in Germany, but actually it was not possible actually clinic did not respond it. But patient continued actively seeking for the help, and his part of the life he spends in Tenerife, in the islands of Spain, and there local urologists with seems very good advanced clinic, they have Da Vinci robot offered to remove this calcified adenoma nodule, and he managed to do it, and also a recanalization was done and removed epicystostoma. So normal urination was restored. After the manipulations, prophylactic self-catheterization was prescribed in order to avoid repeated stricture. And yes, still some bacteriuria present, but it's not very high numbers. It might be due to the catheterization. Currently, patient has complaints of occasional pain in the left inguinal region with the irradiation to anal region. Occasionally increases during rotation of the lumbar spine, bending forward increases pain. I will explain it as combined origin. There are a number of manipulations have been done in the pelvis, but also I sent a patient to the MRI of the spine, as he's a former hockey player. It's not very healthy sport for the spine, and multiple trauma he has suffered already before. So it's hard to explain all these pains with the manipulations, what has been done in pelvis. So minor leakage still after this manipulation persists. It increases during walking. Patient made follow-up MRI, and there was suspected rectovesicular fistula. It was a very unpleasant condition. I asked to repeatedly review another radiologist. He actually objected this first conclusion, and according to the bacteria, only one species, and the numbers of bacteria with fistula would be significantly different numbers. So we will follow up. So far his PSA is controlled. He continues to receive the androgen deprivation therapy. PSA remains low, but slight minor increase might be observed during the year. It increased for 0.1 unit. We will see how it will be in the future. And yes, this is the MRI after the removal of adenoma, calcified adenoma lesion, nodule. And here you can see also, yeah, urethra is free currently. So yeah, the interesting case, even without any discussions and comments, just to hear about different technologies available and how it works and how what the complications could be. But yeah, we'll be glad to also to have your comments, suggestions, etc. I would like to ask to keep in mind, as I said, that patient, it was not possible to prescribe patient certain treatment, standard treatment. He always considered and reviewed the number of treatments and was searching in the internet everything that actually he choose what treatment he will receive. No doctor could prescribe straightforward. Okay.
Thank you for the interesting case. Do we have any comments? Or, of course, the patient. It seems that the patient decided to go for something new, and this new method was not very successful. I don't know if anybody is familiar with this method of treatment in the room.
Would be interested. It's first also that I see some calcified nodule which causes the problems. But if anybody has experience with this and how to manage with such conditions, would be very nice to hear such experience and comments.
Do we have any?
Yeah, Dr. Kotecha?
We actually have nanoknives. So
Wow,
yes,
it's good to know.
Yeah, we have nanoknife, but we are using it on a clinical trial only, essentially, and I think we do have nanoknife. So, not a joke, not a joke. Actually, yeah. So, I think they haven't been using it for our prostate cancer patients. We've seen actually some of the patients that have come from elsewhere who have had it, and I think they have been very mixed and very controversial in the United States actually to offer nanoknife for prostate cancer, especially when we have a lot of curative treatments for prostate cancer itself. There's a surge of use in, for example, pancreatic cancer as well. Actually, there are clinical trials. There's a large study, and our center is actually one of the places to lead that. And then I've referred patients, for example, who need a biopsy because they can get some tissue at the time of the nanoknife procedure too. So potentially they could, if they have like a liver lesion or something like that, they're using that for that treatment. So I consider it almost like any other ablative treatment, like RFA or something like that. There are going to be complications associated with it. I've had just 2 patients recently who go for it, and both of them had issues afterwards. So I think it definitely is a technology that needs to develop some space and clinical outcomes. So it's very rarely utilized. And so at least at our facility, we're using it on a clinical trial.
And, Professor Kuti, who usually is performing this procedure? Is
Interventional radiology will do it.
Interventional radiology. Okay, thank you.
What are the indication of this intervention? I'm very curious, because this is a locally advanced disease. What are the indications of nanoknife, for example, for prostate? I don't know, I'm just curious, but this is a locally advanced disease. He had a locally advanced disease.
No, that's why I don't, for this case.
Whatever they say, this was a locally advanced disease with 12 out of 12, Gleason 8, it is a T3B tumor. Yeah, afterwards.
Yeah.
So I don't think so that this is the clear indication of, no, I'm pretty sure.
Yeah, that's why I say I would think about it like an ablative, like an RFA type approach. And you wouldn't have used RFA for this, so that's why this does not meet the clinical indication for nanoknife, but it is being used like in another ablative approach.
I would put in the one line with this cryotherapy, HIFU and such treatments with very small lesions well visible on MRI, then of course that would be the place where to investigate. But to the large lesion in both lobes of the prostate, that was very strange for me to see the utility.
Okay. Can I ask one simple question?
Yeah.
Maybe the seniors can guide. So in this case, we did stereotaxy mainly because it was oligometastatic disease. That is what I understand. But now if I try to extrapolate the understanding from SBRT data, that post-TURP or any local manipulation of the prostate surgically leads to increased urological complications. In this case, non-standard or non-accepted modality was initially tried on this patient in the form of nanoknife. So then what was the compelling reason to offer stereotactic ultra-hypofractionated doses to the prostate? Maybe slightly lesser hypofractionation would have done a better job. eventually we came to know that the calcification nodule is mainly because of the dystrophy induced from the previous treatments. So that could be one reason that the urological quality of life in this patient was bad. So I was just pondering maybe if we can do a slightly lesser hypofractionation in the primary side and treat the Mets with the ultra hypofractionation. Maybe the seniors and others can guide.
Okay, actually, patient, if you saw the treatment plan, when patient turned to the SBRT, patient already had this nodule. So other way, I would also start to think whether our treatment caused such calcification, but seems that previous treatment, this nanoknife treatment caused this. The thing what we could worsen is the urethra stricture, of course. It's well-known complication of radiotherapy, and there was previously this trauma during second manipulation of nanoknife, and I don't know about the official complications of nanoknife. Didn't find yet such data. Yeah, but would you recommend to make more fractions, more than 5, not to go to SBRT for him? Yeah, if I understood. Yeah, that's a question whether it would be better, whether it decrease probability of urethra stricture or something like this. That's a good question. I don't have, unfortunately, answer. Well,
Okay, thank you. Thank you, Dr. Mazekis. Okay. I would like to invite Dr. Anushil Munshi. He's the head of Department of Radiation Oncology, Manipal Hospital, New Delhi, India. Please.
Thanks to the organizing committee for having invited me. I'll be presenting a very simple, straightforward kind of a thing because I believe in simple things. And over the next 10 minutes or so, we shall be discussing a case of lung, which was taken for SBRT. So there are actually some similarities between SBRT and the recently successfully launched Chandrayaan-3. High precision, advanced planning, can face unexpected challenges, so on and so forth. So my patient was an 82-year-old gentleman from Haryana who quit smoking 30 years ago. He had hypertension, controlled on medications, nothing in family history, underwent a knee replacement 4 or 5 years ago, was evaluated for his symptoms, and PET CT suggested avid lesion in the apical lobe of the left lung, which was around 4.2 centimeter, the maximum dimension, and there were few FDG avid, although the avidity was not very high. Some nodes were there in the mediastinum, and 1 or 2 were with calcifications as well. So this patient initially was being investigated by the surgeons, and they were kind of going on the surgical path, did a BAL, didn't yield much, then radial EBUS and cryobiopsy because of the suspicious nodes. Real-time EBUS TBNA was taken from the hilar, subcarinal, right hilar, interlobar, and they were all reactive nodes. Bronchial washings again was a bit suspicious for non-small cell lung cancer, and then finally transbronchial lung biopsy was adenocarcinoma of pulmonary origin, TTF1 positive, P40 negative, EGFR ALK negative. CT coronary angio, 30 to 40% luminal narrowing. Any questions so far? Otherwise, I keep on moving. So then, subsequently in the workup, PFT was done, severe obstruction, no reversibility, FEV1 around 1 liter, DLCO, again mild restriction, severe obstruction. So it was CA left lung, adenocarcinoma, CT2A, and 0. So this patient, as we know, the classical argument, SBRT, surgery, anything else. After discussion with patient and seeing the comorbidities and other things, so was initially planned for surgery, but then in view of so many factors, was sent to radiation oncology for opinion, came to me, I advised SBRT. So far, so good. So then this patient didn't come to me for a month or so. Apparently, he had gone to take a medical oncology opinion at an outside center. He was advised NACT followed by SBRT. So he indeed underwent 1 cycle of chemotherapy with pemetrexed and carboplatin.
So House has any opinion on this? Should it be done? Should it be done to reduce the size of lesion to make it SBRT-able? Vinita, you have something to say?
Absolutely not required. It's a small tumor, T2 disease. You don't require any CT. 82 years old gentleman.
I hope there is no difference of opinion. Is there any difference of opinion? So I understand the House agrees, should not have received. But the other question is, once these patients receive neoadjuvant chemo, and I didn't find a very credible answer to this. Once they receive neoadjuvant chemo, and then obviously they come to you and they are like saying, okay, now we have to take SBRT. There is no way out for us. We have to take SBRT. So what should we be cautioned, or should we be more severe in our constraints, or should we still consider these patients as routine SBRT patients without any chemo? Rupesh, do you have any experience with such patients who have taken chemo, and then how did they fare?
Yeah, well, I mean, not patients who get neoadjuvant because it's not done, but I think for the oligometastatic patients, right, we treat a lot of patients who have
No, this
metastatic
scenario.
disease. No, and so they're getting chemotherapy and they get these regimens, right? So all of our metastatic lung cancer patients will receive carbopemetrexid, and or Taxol, and they'll get lung SBRT in between those cycles. And so as long as they're not getting chemotherapy infused during the treatment, you haven't seen an increased risk of pneumonitis, at least, with most of the agents.
No, of course. I mean,
have no
we do treat many such patients, we don't. But then in the overall context of such patients who are elderly, have compromised kind of FEV1 already, and you do worry about kind of worsening or maybe doing SBRT in a predisposed situation. So further, this patient received one cycle and developed grade 4 thrombocytopenia. And after one cycle itself, chemo was stopped. Case was simple but was made complicated. Was simple but was made complicated. So then developed grade 4 thrombocytopenia and finally referred for RT. Okay. So post one cycle, this was the situation, more or less the same size of the lesion. Further reports came by that time, KRAS mutation present, PD-L1 was high, around 58%, MSI stable, and NCCT chest was done. We discussed again in tumor board, and we thought that we'd plan for fractionated SBRT. We discussed with the patients. So this was the radiation planning picture for this patient. We decided to treat this patient with 12 gray into 5 fractions over 2 weeks, alternate day treatment. Now, as ICRU recommends, I'm reporting the D2, it was 62 gray, D98 was 58, D50 was 60. So regarding the dose schedules, does everyone agree, or some would give a higher dose, some would give a lower dose, or you all agree with this dose fractionation for this location of tumor? All agree?
I just wondering about GI deep inspiration breath hold. He could tolerate it?
He could, because he was doing a lot of pranayam and yoga. So I was also very surprised when he said, don't worry doctor, I can hold my breath for 30-40 seconds, you don't worry about it. Yeah, he was 80-year-old, but he had left smoking 30 years ago, and since 30 years he was doing all that breathing exercises and yoga and pranayam. So he was very confident, and we also saw when we made him lie down for a dummy run that he was able to hold his breath for 35-40 seconds. Yeah.
Just one question, because I'm checking the PTVD2. So your prescribed dose is 5 times 12. So was it a homogeneous plan?
It was a homogeneous plan in which I accepted 104% areas. I did not go to and prescribe at 80% or 90% isodose. So would you have done it?
Yeah, this is an IMRT prescription indeed. It is not a classic stereotactic prescription.
It's a VMAT prescription, yes.
Yeah. I would give, in our institution we would give 5 times 10, but so 95% at least of the GTV should receive 120.
5 times 10 is lower in BAD compared to 12.
Yeah, but it's very inhomogeneous plan. It means that 125% or even higher of the prescribed dose should be received by the GTV. So it's so the 50 gray is just minimal dose.
You would have liked to create a central hot.
Absolutely.
Which I felt that the fact that I can easily give an overall, because now I'll come to that question also. Very good that you raised this
Sorry,
point,
just-
because now I'm going to that question.
Yeah, just to bring that up, I mean, that's why if you look at your fall-off metrics, I mean, they would be a lot tighter if you allow for a hotter hotspot. So typically for our SBRT plans, the minimum hotspot for a lung SBRT is around 23, 25%. The maximum is about 45%. So this is a very homogeneous, this is actually even colder than an IMRT plan that I would plan.
Upesh, I have a slight alternative view on that, and I'll tell you why. You know, we have been prescribing it central, peripheral, middle, and so on and so forth. But the question is, do you believe that the highest point dose in the PTV is important? Do you believe that the lowest point dose in PTV is important? Or do you believe that the average dose in PTV is important? And actually, if you see literature, you have arguments and counter-arguments for each. Now, if I show you studies which say that lowest point dose is actually the thing and not the highest dose, what do you have to say? For example, in the Electa collaborative lung study, they said it's the BD minimum which is more important than BD maximum or BD average. So while we have actually come down, everybody would agree that we have come down for that typical gamma knife prescriptions to linac-based prescription. We have actually come down, and probably I feel that we are more and more moving to more homogeneous distributions over a period of time rather than intensely creating a hotspot. Because the other thing is that when we create a hotspot inside, one, you have to control it well. For example, this is very close to the rib also. It's not something which is surrounded by parenchyma all over. So it's close to the rib, so you are also careful that you don't want to create some area that touches the rib in the hot zone. That is one point. I don't know whether you agree with that or
No,
not.
because your dose to the rib are actually going to be lower if you allow the heterogeneity in the tumor itself.
For example, the lung HILES trial warned us that be very careful about the hot spot, especially because these hot spots in lung cancer patients can go into the bronchi during actual treatment and create problems for you.
So I agree, but I would do a homogeneous plan if it's overlapping a bronchus. But we've seen that in other data sets. But what you can do is you can
probably the rib thing and probably the fact that I could give 12 into 5 easily without disturbing much constraints.
But the plan actually, if you look at the gradient index for that plan, you're actually probably not going to meet the gradient index standard for this. If you look at the gradient index for this plan, just if you're that homogeneous, your fall off is actually not going to meet the SBRT metrics.
The problem is when we create a hotspot inside, it's not a free situation. There is a trade-off. And the trade-off is that you create a higher low dose area beyond the PTV. It's not a situation where you create a hotspot and everything else is
Actually, by reducing the low dose, the trade-off is you have to take a hotspot somewhere. And the good thing is that you put that hotspot in the tumor itself. So we've actually, most places in the United States...
I've sat with my physicist on this. And when you prescribe at 80 or 90%, you do create a hotspot inside. And it's not that by prescribing at 80 and prescribing the same dose to the periphery, you actually have a lower dose outside.
No, you'll drive the dose. Actually, the way I do it is, if for example, if we're close to a rib, they have a hotspot of, say, 27%. I will actually let them go and said, let the hotspot go to 43%. And by doing that, my rib dose will go down.
My experience is slightly different. Anyway, yeah.
We try to prescribe in a lower isodose, 80% in
we're pushing lower.
So
80%. No, that way, why don't we do it at 50 then?
Well, we
do
can
it
do
at
it.
50. We don't do it at 50.
I will
Nobody
prescribe-
does it.
No, I routinely prescribe at 55% isoslide.
Yeah, but nobody does it. See the publications as of now.
But
nobody does it at 50. Everyone is talking about 80 or 90.
Sir,
no, I think yeah.
Anyway, we can have a discussion on this later on. That means the lower we do, the better we are. I mean, what's the problem then? Go to 30, 40.
But no, just one comment. Because we have this risk-adapted fractionation, and I wouldn't, be too cautious about the rib in this case. That's why we're using 5 fractions. Even 4 times 12 is also loaded. So even if you would like to be on the safer side, you can also prescribe 8 fraction.
4 times 12 into 4 actually leads you to around 100.
4 times 12, but with
Leads you to
homogeneous
around
dose
100.
Around
Around 100. I went higher than that. Oh, the only thing is that I give a homogeneous, almost.
Homogeneous. But
I agree. Then that is the good part that we are discussing this part
Okay.
of controversy, yeah. So I have these dose and fractionations and the BED and the EQD2 for each. Actually, I think ISRO also recommends 45/3 for such tumors. But 45/3 actually is lower than the dose that I gave, which was 16/5, which is for alpha beta 10 as well as alpha beta for 2. 16/5 is higher than 45/3. So, do we all agree on this? A BED of 100 that we know has been going on for quite some time, that we need to cross that magic figure of 100. So do we all agree that this is a basic starting point and SBRT prescriptions need to create higher Dmax or average dose wherever anatomically possible? Everyone agrees? Okay, good. So as we know, in lung we have risk adapted fractionation now, starting from the lesions which are T1 away from the chest wall, where we give 18/3, and then close to the chest wall maybe 11 or 12/5, then central and intracentral, where we go keep on going lower down, and of course alternate day fractionation. So motion management, we did breath hold in our patient. So of course all would agree that all patients should be subjected to assessment. Whether, I would not say that all patients should necessarily be subjected to a motion management strategy while treatment, but they should definitely be assessed. Would everyone agree? Or everyone says that we should actually implement motion, irrespective of whatever, we should be implementing motion management strategy for all SBRT lung patients? Okay, but we should definitely assess, and based on the quanta of motion, treat these patients with appropriate motion management. Now, the question of should the doses be same for adenocarcinoma and squamous cell carcinoma? And we have some literature from Indiana telling us that lower prescriptions, for example, 12/4 or 10/5, can actually be not so good for squamous cell carcinomas. So we should be very careful when we're treating squamous cell carcinomas that we should go higher than 12/4 or 10/5, which means around 100. We should definitely be higher than that. Now comes another twist. So after SBRT completion, in view of PDL1 high, TPS was around 58%, he went again seeking the advice of the medical oncologist, who told him that, okay, now I'll give you immunotherapy. Any opinion of the house? So now this patient, after
It's a very
all this,
active medical oncologist.
so you think pembrolizumab should be fine? Should be given?
No.
Any evidence? So we do have some evidence of using durvalumab or durvalumab plus radiotherapy, although this was low dose radiotherapy, not an SBRT dose, did show some major pathological response higher with durvalumab plus radiotherapy. Nevertheless, the critical question which I want to pose is that can SBRT lung be considered equivalent to surgery lung, which means that trials such as ADORA trial in EGFR positive patients where they give osimertinib, can we extrapolate that evidence, or can we extrapolate the evidence from the EMPOWER study where they gave adjuvant immunotherapy? So can we consider SBRT akin to surgery and subject our patients based on these trials which were actually meant for surgery? Rupesh, you have any idea?
So the problem is, so those patients are very different than the patients that we treat with SBRT. And so you have to worry. They had the same question of, for example, when you did SBRT for this patient, if they have a 3-centimeter tumor, they would have qualified for adjuvant chemotherapy if they had had surgery, right? But those are patients that don't get chemotherapy after SBRT because the patients that we treat are frailer patients. So if you have a 5% overall survival benefit with adjuvant chemotherapy in patients who are medically fit.
Once in a while, we do have a fitter class of patients.
Yeah,
Then
in a fitter class of patients, that's an open question, it's a plus or minus question. But for example, extrapolating these is very different than our patient population. So they're being run, there are trials that are running for these specific indications.
of course,
Like
we have trials, but
immunotherapy.
presently we don't have any answer saying that whether we can directly cut and paste the evidence for surgery to our
Yeah, and even this
to our
for-
SBRT patients.
For ADORA, I mean, that is
technically it was a disease-free survival benefit, but it has not changed practice as
Of course, we have the ongoing trials such as Pacific Force, SWOG, Keynote. So they are all assessing this very, very important question. So I don't have the long follow-up data of this patient, but obviously we need to be on our guard for example, late chest wall toxicity, which can be happening in 5 to 10% of patients, which can chest wall pain, fibrosis, or rib fractures. So that was all regarding this patient. So any other point of discussion? Most welcome. No, thank you.
Thank you. I would like to invite the next speaker is Professor Devna Yanduta. He's a professor, head of Department Radiation Oncology of Amrita Hospital, Kochi, India, of our host. So thank you.
Thank you. I quickly take two clinical situations. The second one is I need Dr. Praveen's help. He's an endocrinologist and it's a very interesting case we're going to talk. And the first case is something I need Dr. Vinita's help, Dr. Munshi's help, Rupesh and everyone's help to. So we are going to see, this is a case of a 52-year-old with dyspeptic symptoms for short durations, have it done ultrasound, then done a triple phase CT scan, which shown a portal vein thrombosis with a lesion in the segment 7. And pH is 0, child book A5, and BP4, because the main portal vein is blocked. And platelet count is fine. So it is a ACC with PVT with a good performance status with child book score of A5, which is a good, and BP4. Now, if we see the BCLC classifications, then we know that in portal vein is advanced. Now, but it is a good performance status patient, otherwise fit and fine. Patient didn't have a long-term symptoms, it are short-term symptoms. Now, what do? We do it as treat as a localized disease or an advanced disease. And is any local treatment required for this kind of patients where the portal vein is blocked and patient is good, fit and fine? And is opening the portal vein is a good idea for this patient? And whether treating only the portal vein is against the oncological principles. Anyone wants to take this up? Now, see, now if we talk about the rationale of treating the portal vein only, is that liver is supplied by the portal vein, the hepatic vein, and 2/3 is supplied by the portal vein. If the portal vein is blocked, then the supply to the liver is compromised, and that actually has a probability of decompensation more. So if you're able to open the portal vein, then chance of recanalization is higher. So it has shown in the surgical series that if they have removed the portal vein block by surgery, there has an improvement in terms of outcome. So with that, we have planned for a study in our institute, in the prospective study on portal vein thrombosis treating with radiosurgery. And this is the treatment what we do. We treat the portal vein. And this is the interim analysis of 72 patients who have published 2 years back. And there we saw there is a benefit. 60% of the patients have recanalization and they have a benefit in terms of outcome. Now, only the portal vein and the adjacent area, not the entire lesion. Not the entire lesion. So we are treating the portal, because you cannot, if you treat the entire lesion, you will not able to constraints, you cannot achieve the constraints. So recently we have shared our data in the ISTRO with 209 patients of this, and this is what we have seen, that patients who have done a portal vein thrombosis, I'm not going into that child, not going to the details of it, and there is a significant benefit in terms of survival in these patients who are responders. 60% of the patients are responders, and there is a significant benefit in terms of outcome in those group of patients. Now, we have a group of patients which were good performance status patients with portal vein thrombosis. They were not treated with SBRT because they didn't give consent to the study. They are treated with sorafenib or lenvatinib. And one group of patients were not treated at all, even in sorafenib as well. And we compared them as a control. And we saw that those patients who have a response and treated had the best survival, and those patients who are unfit and not treated with anything had a worse survival, and those patients who were fit but not treated had a poorer than those patients who have been treated and not responded. So this is what the data is, and what is the take on that? So what do you feel, that is it going to be enough data to or we need randomized study, or that study from some other centers also is required to make it as kind of standard indications?
So what was the treatment received after SBRT for the portal vein thrombosis?
Yeah. So all these patients received sorafenib as a standard, because if it was not treated as SBRT, they treated with sorafenib or lenvatinib, TKIs alone. And we added the SBRT along with the standard and the TKIs standard. 2 weeks after this SBRT over, they have been treated with TKIs as till progression.
And what was, is there any patient, they were A5, so any of them went for, the radiosurgery as a bridge to transplant?
Now, yes, that I didn't go in. There are patients who were complete responded, recanalization happened. There is a 10% of the patients actually underwent TACE for those patients for active treatment.
What was the dose?
45 in 5.
45.
And the standard dose planned? Yeah, in 5 days, 5 consecutive days. Dr. Rupesh, what do you feel? Do you need a randomized study on this, or is it possible to do?
Well, they did a randomized study from the RTOG of sorafenib plus or minus SBRT,
Yeah.
so they have done some evidence in this space.
That has shown that SBRT plus, but recently published, SBRT plus sorafenib actually is better than sorafenib alone. Yeah, recent paper has been published
I just
recently.
don't know how many patients had thrombus, or if they that were in the study.
Yeah.
Actually, local therapy would be given to the entire tumor. It would usually be a combination of tear. Tear was more commonly being done there because those patients were not amenable for TACE, most of these. So it was a combination of tear and SBRT to PVTT. And we sequenced it such that they would undergo an evaluation for tear. We do the PVTT SBRT, and they would go for the tear procedure for the HCC.
Yeah, I have
and
seen that
subsequently
data.
they would be evaluated for transplant if they
There is a catch on it as well, because those patients who have undergone tear and they underwent transplant as well, 30% of the patients. And if a PVT is involved, transplant, the recurrence rates and relapses rates are really on the higher side. So now this is actually has come as we have posted in the task force, and it has been now come as a recommendation. 2-3 days back only the recommendation has come, and it has been as a moderate kind of evidences and has been put into the task force recommendation for portal vein thrombosis treated with SBRT. Anyone has any comment, or anyone can add on it?
I don't know whether Ashwin is present. Only on
Yeah.
Shikha is also saying that when we are doing SBRT for PVTT, it has to be accompanied by some form of local treatment for the gross tumor also. I don't understand the concept of doing only PVTT SBRT unless you're aiming to do TACE later on.
See, the plan is
Or
always a
anything
plan
else.
to open because if you do a TACE without opening the portal vein, chance of
Yeah.
decompensation is very high.
Of
So
course.
you can't do it. So what the plan was to do the portal vein SBRT, open it up. Once they open up, 60% of the patients, they actually go and meet our intervention radiologist for a intervention thing. 10% of the patient had undergone a TACE, but many of the patients, they are otherwise fine, and they continued the sorafenib or TKIs. Now, if this patient were not treated with SBRT, they would have been treated only with, they are not treated with TACE or TAIR, they would have been treated with only TKIs. And the outcome is, we know that it is dismal. We have seen that it is a 14 months median survival compared to the 6 months or 5 months with only TKIs. So now, why we wanted to put it? Because it is a little against the oncological principles, because we are treating only the portal vein with the adjacent structures, not the entire lesion. But in many situations, we don't see in cervix. in many patients, when we did not done the assessment, there was para-aortic nodes, we never treated that. And then we compared it as outcome data. So now we know because we can see the lesion. But even if you don't treat, we can have a data to show that there is an evidences in outcome
So
and
Devna, your
that as
next
well.
question was that do we need randomized trials? See, ideal is to have randomized evidence. If not, then at least we need bigger prospective data,
Yeah.
you know, rather than relying only on a small
Yes,
case series
absolutely.
before validating.
Absolutely.
No, what I remember was Ashwathi used to work with Dr. Rela, and it was like a bridge to transplant. But there were some patients who we knew that would not go for either tear or TACE. So question then is, do we do both the primary lesion in the same sitting along with PBT, or how do you sequence it?
Now, problem is, all these patients who have a portal vein thrombosis, they have a multicentric disease most of the time. And if you want to treat with a good dose, giving a very homeopathic dose is not going to work. It doesn't make any sense. But if you give a full dose of 45 in 5, then you're not able to meet the constraints.
Sometimes, I'm sorry to bring it up,
Yeah.
proton may do so.
Yeah.
Protons can do it, larger.
Yeah. Sometimes if it is in the both the lungs, it is difficult in proton. Both the liver, it is difficult to do.
Dose
And many
fall-off
of the
is very
patients
low
who,
with protons.
Yeah.
So you get a very, very sharp dose fall
Yeah.
off. Even
Yeah.
with a lot of disease in the liver,
Yes.
you'd be surprised.
See, yeah. Yeah. See, absolutely, the proton is an option, but proton is not available, cost effectiveness, all these things are there. So this is the best data which is possible from a radiosurgery side.
Yeah.
Thanks. Yeah, just don't. So now about the contours. If you, I see now this is a very interesting study in that we did in that. We asked the people to contour, radiologist, interventional radiologist, radiation oncologist, hepatologist to contour the portal vein. Now there's so much of uncertainties that was there. And now what you feel, that whose contour should, now what is understood that radiation oncologist contour is much more than the interventional radiologist contour. So when the interventional radiologist, they just contour the portal vein only. But when radiation oncologist contour the GTB also, they contour a larger volume. So which contour should we take? So now there's an agreed volume. What I understood, there's a non-agreed volume. Agreed volume means that is everyone has contoured. And non-agreed volumes is more than 2 people have contoured or 3 people has contoured and others have not contoured. So I think that should slowly go away, because it is not only about the proton or doing a SBRT with a full dose, without appropriately contouring the structures. In liver, contouring is a real issue because we don't see it appropriately, even with MRI also. So, Rupesh, any comment? You don't do liver.
Especially when you think of things like SBRT, we have very small margins. And
Yeah, yeah,
Or even proton therapy.
yeah.
That's why in our facility we do the 3 peer review, and especially we look at all the contours before the treatment plan is done. It's very specific for these types of cases because you have to have something agreed upon.
Yeah. So now, do we put fiducials for all patients for even in proton? No need to put. Yeah. So when we put fiducials, actually you need to put the quality of fiducials as well, because if you put 3 fiducials and not able to track it, it happens many times that you put 3 fiducials on paper, but when you're tracking, either they're too close or too far off or 2 things, and you don't know the quality of fiducial placement. There's a way to calculate also the fiducial scoring system, and if it's a good scoring system, then only it is useful in many situations. And then I don't want to go into that. Now, if there is a cholangiocarcinoma, so I have a metallic stent in it, so we can track the metallic stent as well. We don't need to. Is it possible? Rupesh, have you ever done that? Just only the stent tracking. We can avoid putting the fiducial. Yeah.
We put fiducials in, but we put so few fiducials in that when I decided for a liver SBRT, they were going to treat on CyberKnife, the interventional radiologist puts them wrong. So they'll put them too close together and they'll make a mistake because we just so rarely do it nowadays.
So actually, we have done a very interesting work that actually you cannot track the stent because it is a long. So there is a rotational error in that. So you will not be able to track it appropriately. The correlation error is so high that you need to put a small fiducials because you cannot track the stent because there is a rotational error in it. So you have to put the fiducials if you want to track them. Now, the second case, I want Dr. Praveen to help me. This is a very interesting case of a patient presented with a low back pain. Yeah, Praveen.
Hello, good afternoon, everyone. So I was here for the last 1 hour. So most of what was going on sounded like Greek to me. So I'll just get on with this without wasting much time and try to get things moving for Dr. Datta. So the case in focus is a lady, 59 years old, with oncogenic osteomalacia. So what is that? So that is this is a patient that presented with bone pains, insufficiency fractures, and was mobile only with assistance. So finally it was found that her phosphorus was persistently on the lower side, and I would skip the diagnostics part of that. So basically we ruled out Fanconi syndrome, and in adults, if you find patient osteomalacia with low phosphorus, normal PTH, the diagnosis most of the time is something called oncogenic osteomalacia. So there is this tumor which has been termed as phosphaturic mesenchymal tumor, which secretes something called FGF23, which causes phosphorus to go out, and then it causes osteomalacia. So the imaging for this tumor it's best picked up by a DOTA scan, DOTA PET, and the pickup rate is around 80%. That's kind of sensitivity you have. So this is what was happening in this case. So we have hypophosphatic osteomalacia, and we did the scan, and there was this tumor sitting in the pelvis. It was near the psoas muscle. We had this discussion with our urology team. These are the guys who are wizards at doing laparoscopic surgeries. They said it's probably possible, but probably associated with considerable, you should expect probably a bit of a morbidity. You have to go in, do a bit of searching, you may not find it, and there is a real danger of a plexus injury as well. So that is when we remembered Dr. Datta's, some of these talks which he had given many years back about the wonders of cyberknife. So what, as non-radiation oncologists, what idea we have about it is something which kind of sends out beams, tracks the tumor, and you have these beams coming and sapping the tumor. Oh, that's why we approached Dr. Datta. I think this is good for an intro. Yeah. Please take over.
Yeah, you'll be here because you need to answer the question. So now, this is something different. Rupesh, have you ever treated like this? Something really different, and actually, this patient has responded. And this is the second patient I'm showing. He is talking about the first patient, which we have a 1 year follow-up. And this is how we treated, and 18 gray single fractions. And the hypophosphatemia was corrected without any kind of surgical intervention. The normal treatment is surgery, removing it, or doing an RFA. Both are invasive. So this is a classic example where the radiosurgery can be used in a different form, and we can actually have a benefit in biological. You have a phosphatemia which has been corrected over the period of time, and patient's bone pain has improved.
How did you know what dose to give?
Pardon?
How did you know what dose to give?
Yeah. So 18 gray, now why 18 gray? It is a mesenchymal tumor. So what I understood, you need, and it is a part of neuroendocrine tumor. So we have to give higher dose, more than 15 gray. So that is why 18 gray we prescribe, because it is the standard that 18 or 20 gray should be good enough for an endocrine tumor.
And you are giving me ideas also. So if something happens later, I'll get hold of Dr. Datta and ask him to give the rest of it. Without this talk going on, I wouldn't have had that idea. I would have just believed him. Okay. Yeah, this is a kind of phosphaturic mesenchymal tumor. Would be a soft tissue tumor. It's not a bone tumor. Biopsy is not possible in this case. This is a pelvis, deep in the pelvis, in the psoas muscle. We could go inside and create problems, get a hematoma and all those stuff. So the basic thing is,
Sir, this is second case. We are showing
oh,
here.
not the first case. We are talking about the first case here.
First case we have the outcome data. And this is the second case we have treated just last
Yeah, this patient had a biopsy. Probably Dr. Datta doesn't know about it. This patient was biopsied and a year back from outside. They found some fibrous tissue. So, but they couldn't, connect the dots. They thought that it was something else. But when we saw this patient and the daughter pick up, we immediately realized that that was a thing. So obviously they didn't do a fine biopsy enough to do all the immunostaining and all the stuff, but we knew enough to say that this is a benign tumor with fibrous tissue. And if you see that with a daughter uptake, 99.9%, that's a phosphaturic mesenchymal tumor. So we were pretty clear about that. This case, no doubt. The first case, we had our qualms, but that was the best which could be done in the given circumstance.
See now, in endocrine, what I understood, most of the things are clinical. And the blood parameters. It is a hypophosphatemia, patient have a mesenchymal tumor, and DOTA scan are showing uptake. If you connect all the dots, it becomes a hypophosphatemic mesenchymal tumor. And we don't know how to treat that, but we know either the surgery or ablation. And the dose need to be given more than 15 gray, but I don't know how much should be, but 18 gray should have been good enough because it is safe to give 18 gray in this situation. So we did that. There's 2 cases we have treated. This is the last week only we have treated. We don't have the follow-up data, but the data what Dr. Praveen is talking about, we have 1 year follow-up because we have treated 1 year back, and that patient responded. So we are treating now this patient, which is, I think you see one in a year a patient like that,
Yeah.
or 15, 16 patients we have seen last 10, 15 years.
Yes.
Thank you all.
Thank you.
Thank you.
Okay, I would like to invite next speaker, Dr. Vineta Goel. She's Director and Head Department of Radiation Oncology in Fortis Hospital, Delhi, India. Please.
So good afternoon, everyone, and thank you, organizing team, for giving me this opportunity. I think for last 2 days I was having fun sitting in the audience and asking questions. Now today I'm at the receiving end. So let's start. Please start my slides. So when it comes to SBRT, it is a new thing for all of us. So I think I'll present a case and how we treated that patient in our center, and would like to have inputs from everyone. Okay. So liver SBRT certainly is much more than contouring, planning, and achieving the optimum doses for targets and OARs. So I'll just share the philosophy of how we do liver SBRT in our department and share details of one of the patients. So these are some of the steps I think which we follow. The first is identifying the right patient and right indication. We do fiducial marker placement, motion management, immobilization, simulation, planning, QA, pre-treatment imaging verification, followed by treatment and then follow-up. So I'll take you through some of these steps. So when it comes to identifying the right indication and right patient, I think it is very important to use SBRT judiciously in an oligo situation, which can be oligo at presentation, oligo progression, or oligo persistence. We cannot rely only on the FDG PET scan. All patients have to have triple phase MRI, because it can sometimes show up some smaller lesions which are not picked up on the FDG PET scan. There are situations where contrast cannot be given. You cannot do triple phase MRI. In those situations, we generally do plain MRI so that at least we have diffusion information from the MRI and use ultrasound for correlation. From these images, we try to get the information about the size of the metastasis, number of metastasis, volume, as well as distribution of the metastasis, and at the same time also try to understand how much is the liver volume. When we are analyzing these images based on the imaging parameters, we also try to rule out if the patient has any cirrhotic features on the CT scan, or features of portal hypertension like choroidal lobe enlargement, or nodular contours of the liver, or splenomegaly, or varices, ascites, etc., which can all point towards liver dysfunction in these patients, and at the same time also do blood tests to rule out the hepatitis infection, if any. We also look at liver functions, LFTs, and calculate Child-Pugh score, LP score for these patients. And for selective patients, if we find that there is a lot of liver dysfunction, then we consider doing fibroscan and occasionally ICG liver scan to get the idea of functional capacity of the liver. Now with this background, let's look at our patient. Our patient in discussion was a 38 years old lady. In 2018, she was diagnosed with metastatic breast cancer. At presentation, it was a metastatic disease. It was ERPR positive, HER2/neu was negative, and she was successfully treated with hormonal therapy and CDK4/6 inhibitors for about 2.5 years. After that, she developed progressive disease in the form of a single liver metastasis and multiple bony metastasis. We repeated a biopsy from this, which came as a surprise. This time it was a triple negative breast cancer, but BRCA turned out to be positive. She was given palliative radiation therapy to the painful bony sites and was started on olaparib after radiation therapy. And the subsequent PET scan showed that there was CR in the bony metastasis irradiated as well as non-irradiated bony metastasis. They all responded. However, the solitary liver lesion increased in size as well as metabolic activity, and there were no new lesions. So I'm trying to say that it was an oligopersistent disease in the form of liver metastasis in a young, fit lady with breast cancer. So this is what her PET scan looked like. This is the lesion in the segment 4 of the liver. Clinically, the lady was well preserved. Her LFTs were normal. Child-Pugh score was A. And there was no hepatitis. There were no signs of cirrhosis on the routine cross-sectional imaging. This is how our MRI looked like. This is the diffusion sequence, which is showing a large lesion in the segment 4A. Apart from this lesion of about 4 centimeter size, there was another small lesion. If you can appreciate in this image, there was another small lesion which was identified in the triple phase MRI of the liver. So I think I would like to ask all of you, would you consider SBRT for this patient at this time point or not? I can see some heads nodding and nobody is objecting. Yeah.
It was my question. Did
Yes.
she have a PET scan after this discovery?
Yes.
And it was negative on the other side. I would say no other new lesions.
No other metastasis except for this. Yeah.
Very close to stomach and then again heart. This is different segment.
Okay. So for this patient, we generally do fiducial marker placement, and this is our policy. We generally try to place fiducials which are radio-opaque, MR compatible, so that later on also MRI can be done. The fiducials chosen are in the form of coils, so that later on the coil opens up and they can be identified in multiple sections of CT scans as well as CBCT. They are placed under ultrasound guidance. The critical question is where to place the fiducial. What I have learned over a period of time is that the fiducials should not be very close to the GTV or the lesion, because if they are very close to the lesion, then they throw some form of artifact which makes contouring very difficult. When we have to treat 2 or 3 lesions, then we decide where to place lesions. So if the 2 lesions are very close, for example, I'll show you this image. If the 2 lesions are very close, then probably single fiducial would be enough. But in this case, in the second case, you can see that the 2 lesions are very far apart. Then you probably need separate set of fiducials for both the lesions. So you have to decide whether you're likely to plan SBRT using the single isocenter for multiple lesions or separate isocenters. If they will require separate isocenters for planning, then you accordingly need more fiducials. Ideally, each lesion should have 2 or 3 fiducials. Placing 1 fiducial per lesion is not enough, but practically sometimes it becomes difficult. We also have to be cognizant of the fact that some of these fiducials can have displacement or migration. So ideally, the CT scan for planning should be captured 3 to 5 days after the placement of fiducials. If there are any disagreements or comments, please. Yes, they go.
So means there is a maybe 5-6 centimeter gap in between. So what we do, and I think many centers do that, they put the fiducials in between.
In between, yes.
And both are not more than 5 centimeter distance.
Correct.
So the correlation errors are taken care of, At the same time, we are using the same fiducials for both. So it is, fiducials are not to be put inside the tumor. It's to be put very close to the tumor so that you can track it. That is one. And
that is why you need a discussion with your IR person.
Yeah, absolutely. And the second, and we always should be there. We should tell them put fiducials there.
Correct.
And we should guide.
Because normally they are used to putting the fiducials within the lesion.
Yes.
Which you do not want.
So what we do a plan. Means we put a mark that these are the areas where you need to put the fiducials and guide them that, and then they put accordingly as we are present there and ask them to put it in appropriate places. Okay. So then that is taken care of. Second is we have a study on the fiducial migration. Majority of the migration actually happens within first 24 hours. After that, the migration is happens. Maybe they can happen anytime.
Extremely
rare. So maybe 2 days or 24 hours gap
is
can
sufficient.
be sufficient. We don't need to 7 days gap is definitely not required. 3 days is good, but at least 24 hours or to 48 hours gap is required.
So I agree with you, Devnarayan. So what we do is that we put the fiducial and we start with ABC training. We generally do breath holding based SPRT. So we start with that training. So meanwhile, the patient gets trained for that. So after putting the fiducial, the next step is to identify the motion management strategy. We cannot do any SPRT unless we have motion management strategy in place. And this is the algorithm which we've made for our own department and which we follow. That ideally we'd like to screen the patients using a simple fluoroscopy, which can be done even on linear accelerator. And you try to see if the motion is more than 5 millimeter or less. If the motion is less than 5 millimeter, probably no motion management is required. It will hardly happen in a case of liver, but you can still do that. Ideal is to do a 4D CT scan for confirmation of magnitude of motion. If then you have to see what are the resources which are available for you. If tracking is available, there's nothing like it. But if tracking is not available, all of us will not have that option. Then you have to see whether the breathing is regular and breath holding is possible or not. If breathing is regular and breath holding, patient can manage breath holding, then the next best option after tracking is breath holding based radiation therapy, because by that you're freezing the motion. So your volume of radiation will be less, which can be either expiratory breath hold or inspiratory breath hold. Suppose patient's breathing is irregular, don't give up. I think we should try and coach the patient and still try if breath holding becomes possible. Even if the breath holding is not possible, suppose breathing is regular, one can consider doing gating for these patients. However, if you find that breathing is irregular, cannot do breath holding, then the next best option is some form of abdominal compression. If that is also not tolerable by a patient, as one of the previous speaker was mentioning, then consider doing ITV based treatment. That is the algorithm that we generally follow in our department. Any inputs? No, sir, we don't have that. No experience on that.
Just was one comment, because I have heard several times that for breath hold, no ITV at all. But indeed, when we're preparing the patients, we repeat at least 2 times the breath hold just to see the reproducibility of the breath hold. And even at the machine, we have a 0 treatment. So at the machine, just repeat the maneuver and to see whether it is included into the original ITV or not. So we try to multiply the different time points, and see and validate whether the reproducibility is ensured or not. It's just a comment.
We also do that. When we finally take the scan, we do not take a single breath hold based scan. We take 2 breath hold based scans, fuse them and check whether the breath holding was reproducible or not. I think this is a very important.
So you have an ITV,
yeah, we do.
even for breath hold.
It's like a hidden thing for CT based planning. We don't do it for MR-Linac, but for CT based planning, essentially we do the breath hold, and I'll do 2 confirmatory breath holds.
Correct.
I'll ask them to send all 3 scans.
Correct.
And then I will actually, my GTV is on the original,
Correct.
but I actually do the other 2 to make an ITV. And it's like a millimeter or so, but
Correct.
there is an ITV, and people will get confused why I have an ITV in a breath hold patient, but that's why.
Correct. So, we have to look at our own resources and decide what can we do for the patient. In my department, we have ABC equipment from Electa, and we do not have 4D CT scan. So we decided this is the plan that we kept for her. We thought that we will first try and do breath holding. Now, when we're training a patient for breath holding for liver SPRT, our aim is to have a stable breath holding for a longer duration, it is not lung SBRT. So we do not require a lot of expansion. So we just ask them to do, comfortable breath holding, not maximum or moderate breath holding, because the longer breath holding and more stable breath holding is what is required for liver SBRT. However, if this patient, we kept a plan B or C also for her, we thought that in case she's not able to do this, then we will consider doing abdominal compression. Whenever we do abdominal compression, we also give them some anxiolytics every time, because that also reduces the work of breathing, the ITV reduces. And the plan C was that in case she's not able to do this, then we would consider doing ITV based treatment plan for her. So these are some of the equipments that we use for motion management. Motion management in liver also includes managing the motion of the surrounding OARs. Especially we are concerned about the volume of the stomach and duodenum. So we try to keep it reproducible. So for CT as well as treatment, we call our patients 4 hours fasting. It serves two purposes. One is that there is a reproducible position of the stomach and duodenum, and the breath holding is also better. Our patient in discussion could easily learn ABC, so hence we proceeded. We immobilized her using a vac lock as well as thermoplastic mold, and then we took a planning CT scan. The planning CT scan was obviously a triple phase scan. All 3 phases were required with IV contrast given with pressure injector. We gave her a small dose of oral contrast, 50 ml, for delineation of stomach and duodenum. And we acquired 2 scans in breath holding position, and 2.5 millimeter slice thickness was kept. And these 2 scans were required so that we could check if there was any ITV. Then came the step of planning. For planning, generally there is no hard and fast rule. One has to see in whichever sequence you can identify the tumor most appropriately, select the sequence where the lesion is best identified, and then we register it with MRI and PET scan. GTV is delineated, there is no CTV. In spite of breath holding, as was being discussed previously, we still give a ITV of 2 to 3 millimeter because there can still be some variation in the breath holding, and followed by a PTV of 5 millimeter and OARs, and we give a 5 millimeter PRV to the stomach and duodenum OARs. Any comments or any suggestions?
If you could just back one slide. But if you see the tumor and you can see the stomach, a 5 millimeter PRV is going to go into your GTV.
Yeah,
So
I'll come to that.
Okay.
That was the biggest challenge. So this is how it looked like. So both the GTVs were about 46 cc, and after PTV it was around 120 cc. The liver volume was normal. But then the biggest challenge was that there was an overlap of PTV with the stomach. This is hardly anything. Once you look at it in the coronal scan section, you realize that actually PTV has a broad area of contact with stomach. This is not a small area, this is a broad area of contact, which made me wonder whether we should actually proceed with SBRT or should we convert it into hypofractionated RT. Devnarayan, what do you say? It is because of inspiratory breath hold that, the liver has shifted and there is a broad area of contact.
So it is not about the volume only, it is about the location as well. It is like this, I will be very, very hesitant to treat with a very high dose radiation.
Yeah, so I would have treated them in breath hold on the MR-Linac, obviously with the adaptive approach, especially with the stomach changing daily. But I would have actually put the patient in expiratory breath hold, especially because and we would normally use mid-inspiration, but I would put expiratory for any of these patients because then I'd rather the tumor move away from the stomach rather than pushing the liver down into the stomach itself.
So in the present environment where I'm working, we do not have the facility for expiratory breath hold. Electa does not have that. Okay. But previously also I had a similar patient when I was working on Varian, and I tried expiratory breath hold. It makes a little difference, subtle difference, not much difference.
It depends on where the tumor is located.
I'm talking a similar situation, exactly similar location.
Because on the MR-Linac you have real-time visualization, so I can see, because we'll see a patient actually make a mistake. They'll take a deep breath and do inspiratory breath hold when they're supposed to do expiratory, and you'll see such a big difference between the two of them.
Yeah, Dr. Rupesh, but still, Dr. Rupesh, if it is a MR-Linac, if you are treating, then also you should need to keep a margin because of the image fusion errors and things, and then also things will come to the stomach only. 3 millimeter margin also will come there.
3 millimeter margin will go into the stomach, and so you underdose at that edge. But you'll also be able to adaptively plan, and you don't have any PRVs.
So I have a question regarding selection of this patient for SBRT because of the trials NRG BR002 and CURB trial. So we were doing SBRT for all the oligometastasis in breast cancer. So is this patient fit enough for SBRT after the results of NRG BR002?
I agree with you. The results are negative. The results are negative.
Yeah, we started getting denials actually for breast cancer patients now, so it's interesting.
This patient was treated prior to the results
of
this.
I thought it'd be harder for the lung cancer patients, but lung cancer patients we can get it approved. But for breast cancer patients now, we have a trial for these, so we're trying to put them onto the study now. And sometimes we have to, but exactly, this patient fits the CURB trial. In the breast cancer cohort, it was a negative study for those patients. So.
This is a patient we treated in 2021.
Right. But no, whenever you're treating metastatic patients, especially oligometastatic patients, I think the important thing is that you're trying to maximize tumor control, but you also want to minimize harm to these patients.
Absolutely.
And they get significant systemic therapies, and some of those therapies can potentially increase risks of toxicities overlapping with SBRT. So if you can't meet constraints, just go more hypofractionated, and so you can always do something like 45 and 15 or something like that.
So the lesson that I actually learned was that because I was looking more on axial scans, it is finally after looking at the coronal sections I realized that the area of contact is large. We still decided to go ahead. We actually treated her. So we gave her this dose. You can call it homeopathic dose. I know the dose is very less. 30 grain 5 fraction, 6 gray per fraction, alternate day treatment, but we allowed hot inside. And we gave hard constraints for heart as well as PRV stomach. And ITV and PTV margins were not reduced from these OARs, but we accepted lesser dose as per the OAR constraints. So if you look at the BD10 of 30 grain 5 fractions, it is only 48 gray. But actually, I'll show you the dose distribution also. Substantial portion of GTV and ITV were covered with 120% dose, so which meant a BED of about 62 gray. I'll show you the distribution. So this is how the distribution looked like. 30 grain 5 fractions. How do you decide that, Devnarayan? I'm confused. No. I'm coming to that. So, sorry. So this is how the dose distribution look like. This green color is the 120% and the yellow color is the prescription is 30 grain 5 fractions, but we allowed hot inside. Now the beam arrangement was 2 full arcs. We used 6 FFF. We were also conscious about our MUs because the patient was doing breath holding. So the MUs were not very high. I'll show you some more pictures of distribution. So this is how it looked like in coronal. So you can see that the GTV was made hot, but then the ITV and PTV are getting much lesser dose. And this is how our 50% dose look like. We tried avoiding the 50% dose spilling into the stomach. And if you look at the DVH, you can clearly see that the PTV is significantly underdosed, while a substantial portion of ITV and GTV are getting 30 gray, and there was a lot of hot volume inside. So if we look at the D98, for GTV the D98 was 113%, while for PTV it was significant underdosing with 89% coverage. If we look at the volume of 120% inside the GTV, it was almost 92%. So we did a lot of hot inside the GTV. That is the only thing that we could do at that time. In spite of doing all that, these were the constraints which we gave for PRV stomach. We were slightly above those constraints. We gave a constraint of less than 35 gray to PRV stomach in 5 fractions, and we got 35.9. Dose to 0.5 cc was 33 gray was prescribed, but we were at 34.7. This is despite so much of underdosing. The rest of the OARs like stomach, gallbladder, PRV, large bowel, etc., all were fine. These were our indices. The dose to 2 centimeter is quite high, 75%. But for the volume of 119 cc, I think I would have been happier if it was around 60-65%. 75% is a bit too high. I also want to share that when we treat these patients, we call them NPO by 4 hours. We give them pre-medication. And every day on the couch also we give them diluted oral contrast of about 20 ml, which helps us identify the stomach on CBCT little better. I forgot to mention one more thing here, that when we transfer the plant to the LINAC after QA, then we even convert the isodose lines into structures. And we see them on the CBCTs to ensure that a very high dose is not going into the critical OAR. We take CBCTs using breath holding, which also reduces the motion artifact so that the quality of CBCT is better, and we try to pay attention to liver contours, stomach, heart, as well as fiducial. So comments, please.
What any legal implications are there that if someone argue later if there is a perforation or something that 35 is 36, is there anything there? In India we don't see that because we don't, but that might be maybe a.
The constraints are based on a risk of toxicity level, right? And so and again, in a metastatic patient, we take a lower risk. So what we use at our facility, we actually use 35 gray for 0.5 cc's, and then we will use 38 gray as the max dose. So that's, you're within what we would have used. But again, that's the constraints that we use on MR Linac. These same constraints you have are what we'd use for CT-based treatments.
Okay.
For pancreas patients, though, so that's for metastatic patients. For pancreas patients, though, because this is your shot at SBRT for your cure of these patients, we will increase the constraints. So we use 40 gray as a max dose, and we'll allow 38. The one thing that we'd stop using is actually the D5 cc, the 25 gray and the 12 gray, because by looking at those or constraining those, you're actually, it doesn't affect your plan at all. The patient can tolerate 12 gray to the whole body, right? Essentially to the entire abdomen. 25 gray and 5 you give for rectal cases all the time to the entire pelvis. So we don't use those constraints at all, so that the planner can really focus on the max dose, the 0.03 cc's, and the 0.5 cc's. So in this case, what I would have done is I would have given 40 gray in 5 fractions, 90% coverage of the PTB, so 95%, so 90% coverage at that border with a D max of 38 and a D 0.5 cc's at 35. And you'll see the mean dose to the tumor will be 48 gray, so it'll be basically 50 and 5. So 48 gray mean dose, 40 gray prescription dose, 90% coverage, and you meet the constraints. That's what I would have done for this case, and not looked at the 5 cc's.
So if you push if you produce prescribing a lower isodose and make the hot inside and coverage we compromise a little bit.
I think this coverage, the hot spot is fine for this case. It's like 23%. I think that's not an issue.
Dose,
but I would have escalated the dose because if you go back to your dose distribution, you have parts that are cold that you could go back one. Did you see? So that top part, the part next to the heart, the other part of the liver, that's just normal liver you're treating.
Correct.
So that 40 gray or that 39 gray, the green area, that could go across the rest of the area. So it just needs to be cold at the stomach border. So what I would have done is just said 90% coverage to your PTV, and that would have been just at that margin, and the rest of the region of your PTV would have gotten the full dose of 40.
Actually, I created that sub-volume also along the stomach. I created that sub-volume and gave it to physicists that this needs to be colder. Yeah.
They'll create a what's called a GTV core.
Sometimes when you're not doing too many of these cases now, then you do not have the courage, honestly.
Yes. Yeah, I get scared when the pancreas team is doing 40 gray, but
And the other thing is that what gives us confidence to do treatment is when we see our own patients on follow-up either well or with complications. That gives you the maximum confidence of what you're doing right or is right or not. So we do not have that kind of volumes. Probably that is why I did not get the confidence.
And I would like to ask, because we have seen our patient and every day the stomach was in different position, would you consider replanning or be more, it was, how can you?
Yeah,
I do stomach protocol.
Every single day. I mean, even with the stomach protocol, we use the same for MR-Linac, because again, it'll take longer time on the machine if we have to replan. A case similar to this for a liver met, and the first day he went for a full steak. The second day he went for a Chinese buffet. Even though despite being told NPO, he said, I'm NPO. But then I asked him, I said, your stomach is full, because I can see it on the MR-Linac. So those patients, we replan every single day, and you'll see the stomach change on a daily basis. So. No, I think actually abdominal compression may put the stomach closer to it, because it brings all the anatomy closer together.
I don't like abdominal compression in upper abdominal tumors.
Yeah,
What
I
happens
don't
is that the liver shape changes, the contour changes. Liver is like a dough. So, sorry? It is not reproducible.
And also when you're using your diagnostic MR and PET for your fusion, and you have a
Correct.
CT with a
Correct.
compressed liver, it'll never match, and you'll never figure out what you're supposed to treat.
Just one comment, we're also using the same protocol, but we're using triggered imaging without true beam. But what we also do for example, pancreas in these cases, that we made a contouring on the pre-treatment COM-beam CT and the post-treatment COM-beam CT, sometimes an interim COM-beam CT for organs at risk. And we evaluate offline, just to see that whether we remain at the safe side. My question would be that why did you insert the fiducial? What is the goal with your fiducial insertion here? Because your matching protocol was the liver. It was not the fiducial. What was the purpose of using fiducial in this case?
Suppose I'm doing lung SBRT. It is very easy. I can see the tumor against the background of lung. When it comes to liver, I sometimes feel very lost because I cannot see the tumor. I have nothing except for the liver contour which I'm trying to match with. So this is an additional help, additional confidence that okay, I'm reasonably okay in my matching.
Because in my practice we're using triggered imaging, so you have an interfractional image verification, but there's another side for using this because we're using RPM, and the problem is this is an external surface. This is indeed an external matching. So this is a box, it does not reflect always what is happening inside. MR-Linac experience. So sometimes it could happen that the breathing pattern could change even during the treatment. So just before launching the treatment, we just verify, on the fluoroscopy whether your marker is in the good place, because it could happen that you have a baseline shift, that you can see that there's a discrepancy between your vertebra and between your liver, and it could happen because the degree of the inspiration is different. So you could ask the patient to inhale a little bit more, and immediately you can see on the fluoroscopy that your markers is matched. So you're more confident what you're doing. That's all.
Yeah, when our MR-Linac, was going an upgrade, we had to go back to CT. We actually did, to treat these patients because we were so concerned based on what we saw with MR-Linac, we did CBCT plus the patient prep, plus fiducials and triggered imaging, plus surface guidance. So we did all of those just to make sure that we knew what we were hitting.
I have some experience of using breath holding on Varian versus Electa. I think with ABC, the breath holding is, with spirometer, the breath holding is much more reproducible as compared to Varian breath holding system. Yeah. So this is the follow-up. She did not get any acute or late GI or cardiotoxicities. She continued olaparib. 3 months PET scan was very good. We were happy. 6 months was very disappointing. She had bilateral liver metastasis and peritoneal metastasis. So we do not know actually whether she benefited from this radiation therapy as was previously being discussed. When I think of what we could have done differently, these are the two things which came to my mind, that if we were using DEBH instead of DIBH, that probably would have helped. And the other is that I could have fractionated it more. I could have probably considered her for 40 gray in 10 fractions rather than 5 fractions because of the large area of contact with the stomach. So that's all. Any other suggestions or comments? we did not think of that. And then there was a separate satellite lesion also.
It's too big for RFA, right? So at about 2 centimeters, you start to lose control with RFA versus SBRT, especially with 2.5 centimeters. So.
Thank you so much.
Thank you very much. Thank you. I continue the last speaker. It's Dr. Ramit Jain. He's consultant radiation oncologist, Valentis Cancer Center, Meerut, India. Please.
I am so thankful to Professor Michael Charnow and Dr. Devnarayan for providing me the opportunity, though I was not in the scheduled program, but they gave me the opportunity to present initial experience with India's first CyberKnife S7, which is MLC integrated. This is a very emotional moment for me. Dr. Jalali is here. He has been my mentor and my teacher, and I got so like all the nuances of radiation oncology, basic thing I learned from him, and it is really emotional to present initial experience with one of the very advanced platform, and that of the country's first. And again, and Dr. Rupesh Kotecha is also here. I got the opportunity to follow him for a week or so at Miami Cancer Institute. So I would like to present our initial experience with the first CyberKnife of the country. So radiosurgery, we know the fundamental concept is that a very large number of radiation beams, especially from covering the typically volume, and especially non-coplanar beams, they converge on a limited volume target from various angles, as shown in the picture, and these provide a very great degree of conformity and precision. So in CyberKnife, non-coplanar beams are possible even for extracranial targets, as in contrast to Gamma Knife, for 201 beams for more than 4,000 possible beam angles are there, and with very high degree of conformity, and in addition respiratory tracking and artificial intelligence. So in comparison to previous options, now the CyberKnife S7 is integrated with the multi-leaf collimators, and we know that multi-leaf collimators have been a revolutionary important landmark in radiation oncology. So this we can use both cone or iris and multi-leaf collimators. Yeah, sure. Multi-leaf collimators, and the advantage is that with MLCs we can have any shape in contrast to fixed circular shape, because then we can have less penumbra and better and more convenient conformal radiation, and IMRT is possible with inverse planning. So size of target, in contrast to previous CyberKnives, we can actually have larger field size, 11.5 into 10 centimeter collimator size, but we have treated up to 20-21 centimeter tumors. It is then less time as compared to previous. Average time is around 20 minutes in contrast to 50-55 minutes of previous models, and it's very convenient in itself. So our experience, we have very short experience. In just 8 months we treated 172 patients, around roughly 21 patients per month, with more than 200 odd lesions. So 44 intracranial, with in contrast to other centers we treat relatively less number of intracranial, just a quarter. Majority are extracranial and age 19 to 98. So we are very selective. We see around 300 patients with solid cancers per month, but out of these only 21 patients per month with CyberKnife, around 7%. We have shifted our practice from conventional RT to this SBRT in prostate, majority of lung, acoustic schwannomas, pituitary adenomas, and meningiomas, and what we have started in addition with liver, kidney sarcomas. So we have treated 9 patients from abroad, and from far over places in the country are coming, as far as Kolkata, Manipur, Odisha, Bangalore, etc., and of course Delhi and Nagpur, Delhi, Jaipur, Lucknow, etc. So in extracranial we have treated 14 prostate, 8 renal, 18 lung, 9 liver, 3 pancreas, 26 vertebral mets, 2 liver mets, etc., 14 head and neck. And interestingly, we have treated 15 sarcomas, 12 recurrent, and all these majority 12 recurrent sarcomas didn't have option. They were earlier either operated or radiated, and then we gave re-irradiation or sort of. 2 definitive or unresectable, and 1 adjuvant, interestingly. So out of 110 patients with at least 3 months follow-up, 3 patients died due to SBRT. One was 88 years old, CAPFS given 35 in 5. He died of radiation aspiration pneumonitis. Another is CL lung, large lung tumor, died within 7 days, likely due to radiation pneumonitis. We have modified and adopted 0 dose model now. We make volume of receive on 0 dose for normal lung. Another was SCC child-pox-C with PVT post-air was being planned for liver transplant in Japan, and he was given SBRT to PV with thrombus only as a bridge, but he also died within 15 days, probably because of radiation. Another patient possibly with SBRT just died after 1 fraction, likely due to SBRT, though the spleen received maximum dose of 6 gray. We don't know what is the cause. And all these patients were treated within first 3 months of our starting the program and died within 1 month of receiving SBRT. We have become more selective now, and patients treated in next 3 months have not shown any acute intervention related mortality. So 3 more patients have died so far due to the progression of disease at other sites. There have been 1 local recurrence, 1 recurrent upper eyelid squamous carcinoma. We gave it, she was 88 years old lady. She was earlier operated, then she came and she would have needed plastic reconstructive surgery, but she was medically inoperable now, 88 years old lady. We gave initially 16 grain single fraction, had recurrence at 3 months because we were apprehensive to give more doses initially. So then later on we gave 22 gray. So far she's doing okay. We have got 3 marginal recurrences, all in head and neck large cancers. Probably we are not giving enough, we didn't give enough CTV margin, and all doses also less. And patients with at least 3 months follow-up, we have, though this is very short follow-up, and we have this control. Morbidity for patients with at least 3 months follow-up, we have around 6 grade 3. 3 were in head and neck, all got necrosis, especially in more than 5 centimeter. 1 was of prostate cancer, 1 was liver mets, and 1 was eyelid grade 3 xerophthalmia. This is a patient of left buccal mucosa with soft palate extension. He was inoperable, so we gave him 35 grain 5 fractions followed by surgery. Interestingly, on surgery, he got complete pathologic response. You can see there he had primary as well as left submandibular node also, and he had complete pathologic response in primary, and in nodes he got 2 out of 11 nodes positive. So I thought whether this we could try that, but then I searched the literature and I found that there has already been a trial, randomized phase 3 trial going on in US, because what we think Americans usually have already started this process and trials, and so already a trial of preoperative SBRT along with immunotherapy is going in head and neck cancer. This is another case, large this thing for re-radiation SBRT. So you can see like we prescribe for 50 gray, and inside the red hot is receiving up to 60 gray to 65 gray. So with Saber Comet trials, we know that it was very positive, increasing the 5-year survival in metastatic disease. So, and another trial showing the survival advantage of single fraction SBRT as compared to 3 fraction SBRT for vertebral mets. And recently Astro has changed the definition of oligomets. Now number is no bar. If ablative or curative RT can be given to the mets, regardless of number should be considered oligomets. So we have also adopted this practice, and we are now treating multiple liver, bone mets patients by providing SBRT. And interestingly, this is a patient CA breast with very large left iliac bone mets. She was actually suffering from severe pain and inability to walk. We treated her with 24 grain 2 fractions, and she had dramatic pain relief. Just next day after the completion of her 2nd fraction, she called, and doctor, what you have done? I thought maybe there is some problem. I got scared. She said, doctor, I had complete 100% pain relief. When I woke up in the morning, I didn't have any pain. How it could happen? So I think maybe with an increasing dose, we can have very early and very good pain relief. Interestingly, we are now actually exploring this SBRT in patients with cord compression, grade 3 epidural compression defined by no CSF between tumor and spinal cord. Additionally, surgery is recommended as per guidelines. As you can see, this is a patient with tumor involving the posterior thing. This was a patient of myeloma. He was earlier treated with spinal decompression. He didn't receive an adjuvant treatment and then got recurrence. I again asked him to go for surgery. He had actually grade 4 by 5 power, but the patient was refused, and I thought, okay, then we can give RT. And with that, this is the patient compressing the spinal cord. You can see Now this is another patient. Then we thought because the rationale of treating as radiosurgical spinal decompression in contrast to surgical decompression, because anyway patients would need radiation after the surgery, and we have seen many patients after surgery because they get regrowth of the tumor, and anyway in surgery you cannot remove the whole thing. So patients in which we do not have complete collapse, we can try that. So far we have treated 8 patients with grade 3 epidural spinal cord compression without surgery, 2 prostate, 3 kidney, 1 thyroid, 1 lung, and 1 chondrosarcoma. And usually majority of patients treated to 24 grain single fraction, respecting the tolerance of PRV spinal cord. And these were the power profiles of the patients. Majority had actually good power, 4 plus by 5 or 5 by 5. And all patients recovered grade 5 by 5. Only one patient needed stabilization surgery and not laminectomy, as he had complete collapse of the vertebrae, so he needed stabilization surgery. And so it is really encouraging. So when you have a hammer, everything looks like a nail, but this also gives you the opportunity to fix the things which could not be fixed earlier. This is a large recurrent GCT earlier treated, we gave him radiation. Angiosarcoma of chest wall, we gave this thing invading the chest wall and vertebral column. So this BD. Interestingly, this is a patient of recurrent sarcoma anterior chest wall. She had undergone multiple surgeries. This is anterior chest wall or anterior abdominal wall sarcoma. She had earlier undergone 4 surgeries and 1 radiation therapy session, and her tumor was coming back and back. So we treated with CyberKnife. We put the fiducial markers, and we use this non-coplanar option. We treated with multi-tangential fields and blocked the exit dose to the liver. So all the beams were playing tangentially above the chest wall only. And we made this pink 0 dose volume. So we asked our physicists that this volume of liver should not get any dose. So all the beams you have to play, no beam directly from the piercing to the tumor to the liver should be there. You can play with, you have so many beams, you can play accordingly. So we draw 0 dose volume. You can see that way. And you can see that we give BD 125 gray, and much of the liver is not receiving even 2 gray. So because the patient had earlier received RT, patient was around 65 years old, and we thought that because what we can do better. So this is another patient of 88 years old, squamous carcinoma, as I discussed recently, and this patient, even after receiving SRS and didn't have any even erythema, even conjunctivitis, but she has grade 3 xerophthalmia. But encouragingly complete clinical response as shown in this thing. The patient with synchronous or maybe metastatic, I am just finishing, lung cancer, complete clinical response. Another patient, CA lung, 60 grain, 3 fractions, though involving chest wall, complete clinical response. We respected the tolerance of chest wall. And when hepatocellular, this is probably one of the largest hepatocellular carcinoma, we treated 14 centimeter, we get 36 and 4 fraction, patients doing very well after 3 to 4 months, and post RT scan done 3 months later showed just necrotic area. This is another patient, one of the last patient I'm showing, that sarcoma, abdominal wall sarcoma. We treated him in prone position, and we use the beams so that no dose goes to the liver and kidney. So we planned our beams. The beam planning is very important. So from this we learned that we give 30 gray or 34 gray in single fraction. So we can actually use this thing, because now we have gained confidence, and we may try in maybe different platforms, maybe in tomotherapy. The problem is that we cannot have known coplanar in other platforms. So maybe with proton, and apart from proton, we cannot get such a good profile with any other equipment. This is patient with multiple liver mets, multiple lung mets. We have treated, interestingly, bilateral renal cancer. This patient from Kolkata, very big, high profile patient, general secretary of Tea Association. He went to US for opinion, and they asked to get CyberKnife, and then he came us. We treated in single day, 27 gray. Another large chondrosarcoma patient, earlier treated multiple times, invading the spinal canal with weakness of upper limb, and we gave this 60 gray in 3 fractions, respecting the tolerance of various OARs, and patient has got the recovery of this upper limb weakness. This is 98 years old patient treated with CA prostate. Interestingly, we are trying to now use CyberKnife in whole breast radiation therapy because now we know that 26 grain 5 to whole breast is becoming standard to reduce that mean cardiac dose to heart, because we know that mean cardiac dose is actually predictive, and for every 1 gray of heart dose there is 6% increase of coronary events. So if we can actually reduce the cardiac dose, especially in left-sided breast cancer, so we have treated 3-4 patients so far. And saying that this was a patient, very large descending colon cancer patient, and with just 21 centimeter, this is the last case I am discussing, 21 centimeter tumor of CA descending colon. It was invading when he was operated at one of the premier institute in Delhi, and they opened and it was found unresectable. They did just a colostomy, and then he was told that you may live just for 3-4 months. Then they admitted him in the night in our hospital, and when I saw in the morning, he was just moribund, 27 kgs, and even the patient could not, because it was obstructing the transverse colon, pancreas and duodenum also, and patient was not able to eat anything, and even nothing was coming from the stoma. I told them we cannot do anything, but family said that you may try. I said that preoperative radiation in rectum was known, so I told the family that we may try this, but I am not very sure. So we gave RT, we started him on RT 45 gray in 25 fractions, and patient had very good response. After that we got him operated, and we gave 6 months of chemotherapy. Fortunately, we presented 1-year data in American Association for Cancer Research. Generally, they actually accept very novel and very few clinical cases, and patient is doing very well 6 years post-treatment. So truth is,
okay.
Yeah. So truth is stranger than fiction, because now we never thought we could be able to give 60 grain 3 fraction or 30 grain single fraction, but technology and data are enabling us. So
Okay. Thank you. I think.
thank you so much.
Thank you. We close the session. I don't know if you have any question from the audience. We do have time, or we need to continue. We close. Okay. Thank you.
We'll be now moving on to our closing lecture on ISRS, its current activities and future projects. I invite the moderators for the session onto the stage. Professor Rakesh Jalali, Medical Director and Head of the Department of Radiation Oncology, Apollo Proton Cancer Center, Chennai, and Professor Dr. Selçuk Peker, Chief of Gamma Knife Radiosurgery Center, Koç University of Medicine, Istanbul. I invite the moderators to please introduce the speaker for this session.
Thank you so much. So I will invite, I would like to invite Dr. Cherno for the speech about ISRS, its current activities and future projects. Please, Dr. Cherno.
Okay. Thank you very much. Everybody is very tired, so I will try to make this presentation short. I don't know how many of you, as I mentioned in the first day, know about activities of our society. So ISRS was established in 1991, and it is led by a board which consists of 13 members, 5 of whom are so-called officers. Marc Levivier from Switzerland is current president, Arjun Sahgal from Toronto is vice president, Jason Sheehan is secretary, Thierry Gevert is medical physicist from Brussels, he is treasurer, and Laura Fariselli is past president. These people, they are exchanging in their position each second year. So it means that next president will be Arjun Sahgal, and then Jason, and then Thierry. So on each ISRS Congress, some new officer is also elected. Besides this, there are how many? 8 regular board members from different countries. Huan Tai-chung is physical physicist from Korea, Caroline Chung from the Anderson Cancer Center as a famous radiation oncologist, Alessandra Gargulia spent nearly the entire career in UCSF and now moved to Brazil. Konstantin Tuliaska is a collaborator of Marc Levivier from Switzerland. CPU is very famous, at least in the Asian part of the world, neurosurgeon who is working with gamma knife from Hong Kong. Cecilia Gjail is a radiation oncologist from Australia, Daniel Trefiletti from the United States, and Shoji Yama from Japan. And also there are some ex officio members as myself. These people previously served as ISRS board members, but still carrying on specific projects, as Jan Padik about certification, Samuel Ryu taking care about ISRS journal, myself about educational program, up to date, but soon it will be changed. And Patrick Hassens is doing something with bylaws. So there are different committees in ISRS and different chairs of these committees. And as you can see from this slide, only actually one committee, it's education committee, which is led by the person as myself, who is not currently a member of ISRS board. There is a guidelines committee, and Professor Kotecha is actually a member of guidelines committee. What is our activities? Biennial congresses were established a long time ago, and next one will be held in New York City in May 2024. There is a website with updated information. We are publishing newsletters, not so regularly, but maybe 3 to 4 times per year. And there is, of course, this journal, which is carried by Samuel Ryu. He put a lot of efforts on this journal. It's now referenced in PubMed. Still, I think there is no impact factor, but you can definitely send your papers there. There are several more or less new activities as guidelines. 15 guidelines have been published, and once again, Rupesh Kotecha is a member of Guidelines Committee. There are educational activities as webinars and courses. We are organizing webinars from 1 to 2 times per month. There is society membership with affiliated societies. We have one partner society, which is Elexel Gamma Knife Society, and 9 national affiliated societies from different countries as Russia, Latvia, Argentina, Brazil, Italy, Britain. Maybe I forgot something. There is one fellowship, so-called Lars Lexel Functional Radiosurgery Fellowship, which is awarded each second year during the Congress. And actually, the last colleague who got this fellowship was from India, Dr. Sveta Sani. This fellowship is for 3 months, I think 3 months training in Marseille with Jean Regis in functional radiosurgery. And there is certification of services. Professor Piquer, who is here with us, he is carrying the first ever the center which was first ever certified by ASRS. We have only one research project. This is a project which is carried on by Maris Mizetsky on prostate radiosurgery. And also, there were a lot of talks about collaboration between ISRS with the International Radiosurgery Research Foundation. I don't know, it was even in the time when I was board member, but still I'm not sure that this collaboration is well established. And finally, personally, I talked a lot with ISRS board members about creation and implementation of so-called International Radiosurgery board exam. Unfortunately, this project didn't progress, and well, it caused a lot of my personal disappointment. Educational day preceding ISRS Congress actually was established a long time ago, probably in 2007, when the Congress was held in San Francisco, but it was only one educational day in 2 years. So ISRS educational courses program was established in 2016, and now this educational day before the Congress actually is incorporated in the system of ISRS educational courses, while the structure of this educational day is a little bit different. It's mainly lectures with a review of current indications for radiosurgery. And of course, they're prepared not by Education Committee, but the organizers of the Congress. Nevertheless, this more or less the same system. Also, we have, as I mentioned, ISRS webinars. We have so-called ISRS endorsed events, which are training courses or meetings, which are not organized directly by Educational Committee of ISRS, but by some national societies who are applying for ISRS endorsement, and it's very easy to get it. And occasionally we have so-called ISRS sponsored events, it's educational lectures during national meetings, but it's not so often. So what are the goals of educational courses? It's actually coming from the objectives of ISRS, which is directed for promoting interaction among diverse international community of neurosurgeons, radiation oncologists, medical physicists, and therefore we decided to do this educational program. From the point of view of organization, if in future you are planning to organize such a course in your place, ISRS provides very strong organizational support, but not financial support. Actually, during all these 7 years, we didn't get any money from ISRS. We are preparing, on the other side, the ISRS office is preparing certificates, provides a highlight of the event worldwide. Education committee is working together with the local organizers on the program. We invite an international faculty and provide some other technical support. A lot should be done by local hosts, as here Deb Dutta did great job and his team. Actually, I wish at this moment say many thanks, not only to Deb, but for the entire team from this Amrita Institute of Medical Science. There are many people who worked and even working now, and thank you very much indeed. I don't know your names, of all of you, but without you, nothing could happen, actually. Local hosts should do all local organization to negotiate with sponsors. Of course, we are trying to establish the link with sponsors, but negotiations in details are going by efforts of the local host. Occasionally, we didn't do it here, but occasionally we're applying for SME credits. Creation of website, printing program, organization of participant set, all local transportations, visa supporting papers if necessary. If here in India it was really necessary. Organization of the social program. Faculty, it's absolutely voluntary contribution, and all our faculty members are covering the air tickets by themselves. It's from the time of initial education, it's just stated very clearly, or they can use personal or institutional grants. But on the other side, there is no registration fee, free accommodation for faculty, and social program and local transfers. So you can clarify, you can see by yourself how it is comparable with other meetings. You can go next year to New York City for SRS Congress, and you will see the difference with registration fee and some other things. And of course, participants is the main probably part of our courses. We are trying to keep, not only in India, but everywhere, registration fee as low as possible. We're trying to facilitate participation of young doctors, of students, of fellows. So therefore, and of course we have a lot of discounts for nurses, for SRS members. And so it's never was a commercial project. It's definitely so. So this general program, which was actually discussed by SRS board, I think it was in 2017, 2018, when Jan Padik was still a president. So there are several neuro topics and body topics which we defined, which considered should be highlighted during the course. And here it says bold and blue. These topics which we discussed here is benign tumors and skull-based tumors, genitourinary and gynecological cancers, and also abdominal cancers. And you will tell me that we also talked about brain metastasis, gliomas, vascular pathologies, functional disorders, but you can see that this was sponsors, seminars actually for sponsors. We are given opportunity to give talks according to their own preference. In general, we have programs, of course, educational program and all of these topics. We also have usually physics sessions. We didn't have so many physics lectures here because we decided to put attention on technology. And then from the course which was held in Costa Rica in December 2022, we started these discussions on real clinical cases, and immediately it was demonstrated high success, and it was here also. It was in Latvia the same. The previous course was held in Latvia. At the beginning of this project, we thought about some sort of hands-on workshop, but then we decided that we will not do it because first of all, it's very difficult from the organizational point of view. And then the people in the audience usually use different technologies, so it's very difficult to have many technologies at the same time. And we would never be able to compete with such workshops which are organized by vendors, so we don't do it. And of course, we are giving to all certification of attendance. And we spoke about examination, and within several years, it's not progressing. This is structure, general structure. Initially we tried to organize a welcome party before the course for the faculty, just to gather all people together, but then we abandoned this because, you know, usually people coming with different flights, it's not so reasonable to have welcome party. In general, first day is dedicated to neurosurgical indications, and the second day for residual neurosurgical indications and to physics, SBRT, and then third day for SBRT, for certification, for social program of faculty. But with time, you know, it's extending. So from 2 days of the program, we moved to the 3 days program. And I think we just intermixture with all these topics. But the structure of the course, as it was here, it is absolutely standard. It's typical sessions with discussion time, and this discussion is very important. I was very happy to hear all these discussions specifically today. I don't understand the topics. It's far away from my field of expertise, but it's definitely, I was very happy to hear. It's really a spirit of this course, these discussions without, as I mentioned on the first day, without these barriers between those who speak on this chair and those who are hearing the lectures. And also we have plenary lectures, and usually we are trying to finish around 6 o'clock each day, but sometimes so the time schedule is shifted. This certificate, which is standard for all courses which were held before. By the way, if you forgot to get it, please get it. All certificates are ready for all participants. And yes, so now I come into the slide. I usually show it. So now we have a line of courses, a line of venues which is to hold courses. We have number of faculty members so great that we have to select for each second course. And since all of us became friends, it's very difficult selection. Sponsors are contacting me and asking when the next course will be organized, and asking for providing information for support. So it's no problems, we're successful. We're so much successful then that some recognizable people in the field probably became a little bit jealous about our success. But let's go back 7 years ago when the project was approved by ISRS. And I spent several months just to find the first venue for this event. Many people thought, yes, it's a great idea, but let's wait a little bit. And I'm very thankful for the colleagues from Novosibirsk, which is the third largest city in Russian Federation in Siberia. They have a radiosurgical center where we hold first course. Maris Mizetskis was from the first course with us, Pavel Ivanov. We had at the time Roberto Martinez, some colleagues from Israel, around half people were from abroad, 12 speakers, 67 participants, and Brain Lab was the first sponsor who helped us. So by this time, this is 22nd course. We had mainly courses in Europe, 4 courses in Russia, 2 in Hungary, 2 in Latvia, in Finland, and Georgia. Georgia, not American, but Transcaucasian country, Georgia. 7 courses in West Europe, 2 in London, organized by Jan Padik, and 4 in Milan, and 1 in Switzerland, associated with the ISRS Congress in Montreux. Still no 1 course in North America, 2 courses in South America, in Central America, 1 in Costa Rica, and 1 in Brazil, affiliated again with the ISRS Congress where it was in Rio de Janeiro. And 1 course in China, and considering this part of the world, we had before one course in Cairo. So this is the second course in, let's say, this very wide area of Middle East, Africa, India, and South area. So this is our faculty, and probably this slide don't contain all names. I believe that anybody can be on position of myself just for coordinating activities. Without these people, nothing could be done. We highlight the names of all faculty members on the ISRS website after each course. So if you go to the ISRS website in 2-3 weeks, you will see an update about course in India. You will see names of all faculty members of this course. Our sponsors, once again, many thanks for all of them. Elekta was with us very often, including he and Kochi, Acure also. ZAP since recently closely collaborating. Brain Lab not so often, but it was the first company which supported us. Occasionally with giving, we are receiving support from Varian, and here even CRAT was with us. So we hope for collaboration in the future, and really thankful for all your support. Of course, a lot of sponsors going beyond these main vendors, and here Amrita Hospital put a lot of efforts and financial support for this course. Professor Prem Nair supported us, and it's really great. So regarding further plans, the next course will be organized in December in Istanbul in Turkey. We planned the course in October in Buenos Aires, but it was cancelled. So in Turkey, we will speak mainly about the brain metastasis and parenchymal brain tumors from the point of view of neurosurgical indications, and once again, genitourinary, gynecological, and abdominal cancers, nearly the same topics as here, probably with different speakers. And also we'll put attention on medical physics and imaging for radiosurgery, and Professor Selçuk-Piker will be a course director there. So if you will have a chance, please come. And then next May, it will be ASRS Congress in New York City. And this is nearly all, but just at the end, I wish to share with you some ideas. Of course, if some of you are absolutely happy with how is it going on with your practice here in India, it's absolutely fine for me. But for those of you who are looking on some collaboration, for increase of collaboration with ASRS, just my own thoughts how it can be done. First of all, we have webinars. And I heard here great lectures from the Indian colleagues, and I even spoke with some of them. Probably involvement of Indian community of radiation oncologists and radiosurgeons into our webinar system is really reasonable. Maybe in the nearest future there will be some talks by Indian colleagues. Then about organization of courses, maybe, of course, even each year it's a little bit difficult, but maybe in 2 or 3 years you can organize another course, maybe in another place with different topics, or maybe you can participate as faculty in other courses. Another thing that when you're organizing your own national meetings, maybe you can apply for ASRS endorsement. It's absolutely free. It's very simple education form. The only one thing which you should agree is just to display a standard logo, ASRS endorsed event on your course-related materials, and then your event will be highlighted on the ASRS website and actually in newsletters. So it's, I think, a win-win situation for everybody. You can consider application for ASRS certification for your centers through Jan Padik. You can contact him directly. You can find information on ASRS website. Jan is a very reasonable man, and I think it's also a very good option. You can consider affiliation of the National Society in India. You have the Society of Association of Radiation Oncology in India, Oncologists of India. You can consider affiliation with ASRS. It's not for free, and still there is should be some registration fee, but in exchange, all members of this society will become affiliated members of ASRS. So they will get access to all resources, and also I think it's a very good option. You can participate in research. Once again, the only one research project which you have up to date is research of Maris on prostate radiosurgery. If you are doing prostate radiosurgery, I think Maris will be happy about this. Well, you can try to apply for ASRS Congress. In 2026, the Congress should be in the Asian part of the world. And I think now application is open, but the thing is that it's highly competitive. You know, it's preparing of this application is a great work by itself, and there is no guarantee that you can get it up to date in the Asian part of the world. ASRS congresses were only in 3 countries, Japan, Korea, and Australia. So it's the same. And then beside SRS, you can consider collaboration with International Radiosurgery Research Foundation. Dr. Amar Al-Shehabi can share his experience. He is not here today, but for example, center in Cairo, they regularly sending data for multi-institutional studies of this International Radiosurgery Research Foundation. I think it's also good sort of collaboration. Finally, in the most end, as far as I know, finally we are from BRICS countries. BRICS countries provide grants for collaborative research between BRICS countries. Should be at least 3 countries for example, well, any countries from BRICS, Russia, India, China, and we can do good research altogether. We can apply for a grant for this. Well, it's nearly all what I had a wish to tell. If you have any questions. No questions.
Thank you. Thank you. That was very informative. I mean, we had the questions of membership, affiliation, congresses, potential educational research activities, but you have already spelled it out. I have just one question. It's a very precious resource, these talks. You saw the quality, and I'm sure it must be the same in different parts, in different educational courses. So are all talks on a website such that people or members can access them too?
No. I mean, you mean talks? No, yeah. we don't have this on websites. And
that could be potentially considered because, these days everything is on YouTube, on the digital platform, and anywhere in the world is so small now, they can access all the talks that we have had.
Yeah, you're probably right. And we discussed this, and I got this question not for the first time. For example, why we don't accept online lectures or online translations of our lectures, of our courses. But, it's we are going on traditional way, at least up to the moment. And maybe the next chairman of the education committee, maybe he will decide it in a little bit different way, but at least up to Turkey, we will continue it in this way.
Okay, thank you. Any other comment, please?
Yes, but webinars is a little bit different. Webinars, yes, of course, webinars.
No, I was not mentioning the translations and everything, but for example, 3 days we have done amazing lectures, but then the rest of the world, you have to sometimes repeat the same in other educational courses. So for example, in other societies, what we do is if we have another educational course, so we give them a link of the previous educational course so that they can access it and they are a little bit prepared for the next course. It's just a suggestion.
Yes, and well, once again, I believe that ISRS has enough different resources on web, and specifically not only general webinars, we have even national webinars. Up to date, these national webinars we organized only in Central America and South America by Alessandra Garguglia. They had this program for 6 months. So, for example, if you wish to organize the same program in India, I think it will be accepted with pleasure. But still, regarding courses, we are going in traditional way. Maybe I'm a little bit outdated.
I think you have a point. But just final, this will be my last comment. At least a pen drive with a PDF of all the talks can be given to the registered delegates, such that they can take care of them.
Yes.
Devnarayan?
Yes.
That could be done.
Maybe, yeah. No, not from me. You should speak on this matter with each individual speaker.
Yeah.
If you wish my talks, okay, go ahead. But each individual speaker should give his agreement. And my talks is fine, but...
Yeah, you have to have a consent and then prepare. Rupesh?
Yeah, and the only last thing I'd add is for the ISRS guidelines, one of the pushes that Arjun had is that they're going to be open access, so that at least you can just go to the website and either you can directly download it from there, or they'll get you to the link itself. But we had ultracentral lung oligomets guidelines that both got published recently. ISRS guidelines for radiation necrosis with a new grading system just is going to come out in regional. The proof is out. And then the next one is going to be for vestibular schwannomas, large vestibular schwannomas, a topic we talked about on the first day. That got accepted, and it's going to be coming out very soon. So there are a bunch of guidelines that are going to be new, but at least one thing we did is make them open access, so you don't have to worry about the journals.
That's very good. Any other last comment or suggestion? I think that's it then, Dr. Chernow. On a right note, you are the last speaker.
Yeah, but the most last thing. So I mentioned certificates, and I wish to award now certificates for the main organizers of this course, Professor Rakesh Jalali and Professor Deb Dutta.
I would like to now call upon Dr. Shruti, Assistant Professor Radiation Oncology, to give the vote of thanks.
So as we come to the end of this brilliant 3-day session, I know vote of thanks is a mere formality, but when we say vote of thanks, there is like a long list of names to say, because when you hear people saying vote of thanks at the end of any talks, you usually hear only a couple of names, but this program would not be possible if not for the team effort. We have an entire team here who's worked hard for the past, literally a few months I could say, but then definitely over the past few weeks, we've had our whole team into this, and each one taking different roles and organizing everything. I mean, I could just go on, and I would especially mention our entire radiation oncology doctors, Dr. Ajay, Hari, Dr. Pushpaja, Dr. Anup, all our physicists, our students, the IT team, who is, I think we've had not a single glitch during the entire talk. There's not been any error in the sound. And we've had our event management team who's continuously been supporting us, Mr. Sumesh, and specifically mention a few names because these are the guys who've been working with us day in, day out for everything, getting everything organized, keeping the stalls ready, the hall ready, the hampers organized, the delegate kit to be given. Then we've had these transport arrangements. I know there have been a few glitches, but please forgive us if there's been any mistake from our side. We'll try to make it up the next time when we hold the conference. And like our coordinators, especially our oncology coordinators, Mrs. Raji, Danya, then we have our RT techs who have been constantly supporting us, pack the delegate bags as well. Then we've had Mr. Prasad, our chief RT tech also, who's been constantly supporting us. Then that's what the names, I may miss out so many names here, but then it goes without saying that it's been a huge team effort. And apart from this, of course, this program would not have been a success without the faculty who have given us so much of their rich educational experience and time. Thank you so much, dear faculty members. It's been a privilege to have learned from you all for the past 3 days. I would have loved to be a part of this conference. It's like, as someone else was saying, it's like organizing a wedding. You organize a menu, especially Indian weddings are like kind of flamboyant. We have a good menu, we select, we take so much care, but we really don't enjoy the wedding. It's been like that for us. It's like we've organized this conference, such a rich conference, but we're still not able to enjoy the content of the conference. But then it's been a pleasure hosting you all. We'd love to have you all visit Kochi again, and definitely it goes without saying that Dr. Datta has been a constant support. Jalali sir, thank you so much for the entire thing, and Dr. Shanoff, you've been constantly in touch with us in mails, and definitely every single point you have mentioned to us to try to improve our course. So that's been a definite thank you from all of us. And dear delegates, without you, this program is not going to be a success at all. So thank you so much. Thank you all for coming. Have a great year ahead. Thank you.
I'd like to also express our gratitude, first of all, to the International Stereotactic Radiosurgery Society. Of course, especially Dr. Mikhail Cherno, who was kind enough to consider India and now, of course, Kochi to host this very nice educational course. Also, I have to say it's one of those meetings where there was an amalgamation of different faculties, especially now that we have moved extracranially, and you could witness today the enthusiasm. I truly believe these are very exciting times for radiosurgery, SRS, SBRT in future with the combinatorial therapy, as I mentioned in the first day. And again, thanks to everyone, but all of you would agree the 3 people who actually stand out, and I would like to ask them to come on the stage, Dr. Cherno, Dr. Datta, and Dr. Shruti. I think they need a standing ovation for the work that they have done. Thank you very much.